medical oncology, and we're also going to hear about hematology, one of our biggest areas, and we have a whole section of hematology. We have many of our faculty who will be here during the day. As you know, we're out at 15 plus centers around Connecticut and Rhode Island. So we really hope that this will be a great day to assimilate the data, talk about how we're using the data. I know I always find this useful, and needing to take the boards again in a year or two, this is always helpful to me. So this is, I think, the 13th time I've hosted this, but this actually was begun even before me by Eddie Chu when he was in charge of oncology. But it's just great that we have this meeting every year. I'm going to make my remarks brief. I'll be moderating a little bit later. We have a great day, by the way. We're going to hear from not only most of the major tumor types, solid and liquid, but we have a very special lecture at lunchtime by Lucila Ono Machado, who's our department chair now of informatics, bioinformatics, and she's going to really talk about how we're using big data, AI. I'm sure everyone thinks about that a little bit. Your phone probably does it. So it's really going to be a great day. But now it's my true pleasure to introduce our director, I think known to most of you, Dr. Eric Weiner, and he's going to say a few opening remarks and then turn it over to Pam to start the session. Eric.
Thanks, Roy. I'll start my opening remarks by saying that I always feel like I'm about to kill myself going from 91 to 95. And this morning was no exception. And as I was racing to get here, I thought, good God, I hope these cars avoid me. And they're just, it's a little frightening. But in any case, I've been here for 2.5 years. I'm slowly getting used to the roads. And it's really a pleasure. This used to be called an ASCO review. Technically, it's not an official ASCO review. It's a review of our interpretation of some ASCO abstracts. But beyond that, it's talking about advances in oncology and talking about how we take care of patients. And in my mind, meetings like this are very important for a number of reasons. Perhaps first and foremost, it gets a whole group of people together, and there's real value to that. And I think we've all learned that, particularly post-pandemic. But apart from the review of recent data, we also are going to spend a fair amount of time reviewing cases and building consensus. And certainly across our entire network, we try very, very hard to have a consistent approach to every malignancy at every site. And I think meetings like this really help contribute to that. So I want to invite all of you to actively participate in the day. It's really important to have an engaged audience. Don't be shy, speak up, and take advantage of all the people who are here all day. And with that, I will say thank you for coming and introduce Pam Kunz, who is the chief of yeah, you've got so many titles. It's like I'm deciding between the titles. Who's the director of our GI Center of Excellence and the chief of GI Oncology, and just a remarkable GI oncologist who leads a great group. So Pam, thank you very much for being here.
All right, you redeemed yourself. That's good. Good morning, everyone. Welcome. I am hosting the first few sessions this morning, so it is my great pleasure to introduce my friend and colleague, Dr. Veda Giri, to give the first talk. She will be speaking on unraveling the genetic tapestry, advances in germline testing. Veda has been here for almost 2 years and is the division chief of clinical cancer genetics and the co-director of the Early Onset Cancer Program. So thank you.
Thank you very much. Good morning, everyone. It's such, really great to be here, and I'm honored to kick us off. So this is a really exciting topic about unraveling the genetic tapestry, advances in germline testing. and bringing some of the highlights from the ASCO 2024 meeting today. And so please keep in mind that this is just a few of the abstracts that were presented. There was a spectrum of abstracts, and I'll give you a little bit of the summary of this information. So I have no disclosures relevant to this presentation. Just to set the stage about why this topic is brought forth is, I think, we all know that germline testing, which is hereditary cancer genetic testing, is really growing in impact in oncology across the spectrum, whether it's in cancer screening, risk reduction approaches, cancer surveillance approaches, and precision therapies for sure. Along the way in this spectrum of care, we know that with this germline testing, that there are hereditary cancer implications to always keep in mind. And these impacts span not only from the individual, but to their families and to then populations in general, one family at a time, but also thinking of some population level approaches. So in ASCO 2024, the spectrum of studies for germline testing really spanned the gamut in terms of thinking of various different topics. So the variant spectrum, what are we learning about genetic mutations or pathogenic variants that are involved in cancers? What does this mean for cascade testing in families, and what are strategies to develop for cascade testing? Impact of germline testing for screening and treatment approaches. There was some really nice abstracts about cancer disparities as well, and thinking about this more globally across populations, United States, but then across really across the world. And then clinical implementation was a big area of work that was being done and presented at ASCO, thinking about how to increase access to germline testing and really think about this in a more broad-based way. So when we thought about the abstracts to include in the review and then decide which ones to provide for highlights and updates, the inclusion for these abstracts regarding germline testing were those that really kind of, you know, the main focus of their information was about genetic testing or germline testing as the subject matter. This focuses on adult oncology studies. And the focus is really on hereditary cancer genes. There were some abstracts that were presented about single nucleotide polymorphisms or SNPs, some on polygenic risk scores and things like that. So we're not going to be touching on those. And we won't be focusing here, at least, on the somatic or genomic only types of studies that are shown here, really keeping the focus on germline testing. So overall, this came to about 53 abstracts that we reviewed and then selected some for highlighting here today. As far as the tracked categories from ASCO, you can see here that the majority of these fell under prevention, risk, and genetics. And these spanned several of the topics that I just mentioned already in terms of the spectrum of the work that was going on. There were some abstracts, and it was very interesting from a global perspective about genetic testing and germline variants in Brazil, China, Rwanda. And there were abstracts in the veterans populations. So I really encourage everyone to kind of go back and think about like maybe just perusing some of these abstracts when it comes to germline genetics and genomics, since we won't be able to cover everything, obviously, today. They spanned breast cancer topics, care delivery and models of care, genitourinary cancers, gynecologic cancers, lung cancer, which was extremely interesting, quality of care health services, gastrointestinal cancers, and melanomas. And some of these topic areas fell under prevention, risk, and genetics. So it's just a matter of, you know, kind of thinking through the different tracks and finding those interesting abstracts. So I'm actually just going to give highlights on 4 abstracts today for the sake of time. These were the oral abstracts and rapid oral abstracts that were presented focused on germline testing. So I'm not going to read all of these, but I picked a few of these to be able to present on today, since these were the ones that were given more attention at the ASCO meeting. So the first abstract we're going to just summarize here is abstract 10503, which was presented as an oral presentation by Professor Lambertini from University of Genova. And this is about the clinical behavior of breast cancer in young BRCA carriers and the prognostic impact of the timing of genetic testing, pre or post diagnosis. And this was an international cohort study. So the rationale for this particular study was that the clinical behavior of breast cancer in young BRCA1 and 2 carriers isn't fully understood and deserves some more study. And then thinking about the impact of the timing of genetic testing before or at the time of diagnosis, looking at tumor characteristics and outcomes. This was a very large study. It included sites from Europe, Asia, North America, Australia, and Latin America. The key inclusion criteria were stages 1 to 3 invasive breast cancer, diagnosis really over a 20-year time span. The key here is this was a young population of patients. So really looking at this in the early onset space, age at diagnosis of 40 years or younger, with a known pathogenic variant or mutation in BRCA1 or BRCA2. The total cohort for analysis included 4,752 patients with BRCA1 or 2 pathogenic variants. The median follow-up was 7.8 years, as I mentioned. There was some really great geographic diversity in this study. So the key findings, and these actually slides, I want to give credit to Alison Kurian, Dr. Kurian, who was the discussant for these oral abstracts at ASCO. And kind of the highlight findings here from this particular study was that compared to BRCA2 carriers, BRCA1 carriers were significantly younger at the time of diagnosis, had more grade 3 tumors and triple negative disease. These are well-known features of BRCA1. And had less nodal involvement as well as lobular histology. In looking at second primary breast cancers and also new primary non-breast cancers, which can happen with BRCA mutation carriers and carriers of other gene mutations, this was significantly more frequent among BRCA1 carriers compared to BRCA2 carriers. And BRCA1 carriers had worse disease-free survival and overall survival in the first 5 years. What was interesting was that for BRCA2, there seemed to be this sort of constant increase in recurrence over time, which kind of shows the different sort of clinical behavior of these two genes. And then looking at, compared to patients tested at breast cancer diagnosis, those tested before breast cancer diagnosis had smaller tumors and less nodal involvement, with a trend toward better disease-free and overall survival when that pre-diagnostic genetic testing was implemented. So the key takeaways from this particular abstract was that this was a global study, that it really looked at the clinical behavior of breast cancer, particularly in a very young population of patients diagnosed at age 40 or younger. And looked at the timing of that genetic testing with their diagnosis, and thinking about how to better characterize these carriers of BRCA1 or BRCA2 mutations. And then really, so what was brought up as, at the session, as well as when we think about this, is that there really wasn't data. Some of the limitations is that no data on the pre-diagnosis screening. Was MRI used? How was the cancer picked up? Which could have impacted some of the outcomes that we're seeing in terms of pre versus at diagnosis for genetic testing. And of course, there was healthcare system variability in this cohort. So how do we think about this? We have to factor in some of that variability when we interpret the outcomes. The second abstract that was presented at the oral session was by Dr. Shivak from Duke University. This was looking at the association between rare pathogenic variants in established cancer risk genes and the diagnosis of single cancers and multiple cancers in individuals. And this was a study from the UK Biobank. And the rationale for this study is that really, as we've arrived at where we have in terms of genetic testing or germline testing across the cancer spectrum, most of the original studies and several of the follow-up studies have been family-based studies or case-only studies with external reference controls, which could actually have led to some selection bias. And when we roll these testing practices out in practice, we may not always find some of the results that we see in the original reports and that have been published. So here they took a population-based approach in looking at the UK Biobank, looking at the relationship between these rare pathogenic variants in 96 cancer risk genes across 11 cancer types, bladder cancer, breast cancer, CNS cancers, colorectal, lung, melanoma, ovary, pancreas, prostate, renal, and thyroid cancers. So the study design for this particular study was looking at the UK Biobank whole exome sequencing data This really included primarily the white race and ethnicity individuals, and looking at associations with the various cancers as the data was available in the UK Biobank database. And then looking at this from the outcome perspective for one of those 11 cancers or multiples in terms of prevalent cases and controls. These were the demographics of the cohort. So you can see it was a very large cohort looking at the UK Biobank, over 25,000 cases, over 150,000 controls. And you can see some of the characteristics here in terms of median age at diagnosis. And those individuals that had 2 or more cancer diagnoses represented about 8% of the population. In looking at the results, what we can see here is that the presence of rare pathogenic variants were associated with various different levels of cancer development. And it was very interesting about looking at whether there was syndromic overlap or beyond syndromic overlap when looking at this from a population-based approach. And so the odds ratio was 1.8 for the presence of these rare pathogenic variants for having greater than or equal to 1 cancer development, and was significantly higher if an individual had 2 or more cancers that were developed. So in looking at specific syndromes and then looking at specific genes, first looking at the homologous recombination repair genes. So these would be classically linked with hereditary breast and ovarian cancer syndrome. What we see here, the cancers are, if it's hard to read, breast cancer, ovarian cancer, pancreatic cancer, and prostate cancer. Looking at the odds ratios and the various genes in terms of looking at rare pathogenic variants. So BRCA2 was associated with all 4 of these genes in this analysis. And ATM was also associated with 3 of the cancers, looking at prostate, breast, and pancreatic cancers. So actually BRCA2 was associated with all 4 cancers. When we look at by cancer type, if you look at breast cancer, several of those genes were associated with breast cancer in this analysis: ATM, BARD1, BRCA1 and 2, and PALB2. Ovarian cancer actually had some of the highest odds ratios when looking at the various genes across this spectrum of the cancer genes tested. Prostate cancer was associated with BRCA2, ATM, and CHEK2, and pancreatic cancer associated with ATM and BRCA2. When looking at Lynch syndrome genes, these were the 4 genes that were came out with positive findings in terms of association with bladder cancer, colorectal cancer, and ovarian cancer. EpCAM, one of the genes also involved in the Lynch syndrome spectrum, was not associated actually in this particular analysis with any of these cancers. And then I thought this was actually very interesting when we take a population-based approach, or when we roll genetic testing out in clinical practice. What we start to see is some differences or deviations from these original classic syndromes in terms of findings of genetic mutations in patients that may or may not match their clinical picture or their family history. So these were some of the associations of genes linked with various different cancers that are shown here in terms of genes linked with bladder cancer, CNS cancers, lung cancer, melanoma, and some of the additional results that are shown here. One of the interesting findings and questions that we get in practice is about germline testing for lung cancer patients. This is quite a frequent question, and we see this a lot for patients who themselves have lung cancer or have a strong family history. So, interesting that some of this data is pointing to potentially ATM, BRCA2 having higher odds ratios of risk for lung cancer. How we roll this out in clinical practice is to be determined, but this gives us some, information about thinking about various cancers where we may not have strong clinical paradigms quite yet in terms of thinking of germline testing. So some of these associations were classical with the syndromes, and others were not classical. And so again, that just points to what we see in clinical practice. Some of the limitations of this study were that this was looking at prevalent versus incident cancers, and so there may be a survival bias when we think about some of the results. As I mentioned, it was all European ancestry, so this does need to be validated across ancestral populations. And perhaps were variants being missed, since this was whole exome sequencing data, not full whole genome sequencing data, but really kind of thinking about this and pulling that together. So the key takeaways from the study team was that these rare pathogenic variants are associated with single and multiple cancers, particularly in DNA repair genes associated with non-canonical cancers, non-syndromic findings. And these population-based approaches do build on existing data largely from these family and case-only studies. And the discussant, Dr. Kurian, really had a nice slide that I thought was interesting to show in looking at who should receive genetic testing. She pulled together a summary of the recommendations for germline testing from ASCO, FSSO, and NCCN, showing here that this really does span a significant amount of the cancer population. But does it happen in practice? She presented some of her data looking at the Georgia and California SEER registry data that showed probably this is happening at about a 40 to 50% rate, even in populations that have, say, some clear indications for germline testing. And when we think about putting this in the scope of then how can this be applied in the real world, can we test everyone? Factors that affect implementation of being able to test everyone are, patient identification and awareness and practice, insurance coverage for genetic testing, limited access to genetic counselors, and developing a clinical workflow that'll help encompass the patients that need to be seen. Moving forward, Rapid Oral Abstract 10509 was looking at the frequency of HER2-low breast cancer among BRCA1, BRCA2, and PALB2 mutation carriers. This was presented by Dr. Goldberg from University of Pennsylvania. And this was based upon, the premise for this particular study was from the results from the Destiny Breast 04 trial that was published already in the New England Journal of Medicine, looking at trastuzumab deruxtecan in previously treated HER2-low advanced breast cancer. And this particular study qualified HER2-low as 1+ IHC or 2+ IHC with in situ hybridization negative. And these were all patients that were hormone receptor positive. And what was reported and seen was that the median progression-free survival was superior for the trastuzumab deruxtecan group compared to physician's choice, as well as overall survival, leading to FDA approval for this drug in this particular indication. Now, what's interesting is, particularly for BRCA1, these cancers are triple-negative breast cancers. So these are HER2, classically characterized as HER2 negative, along with hormone receptor negative. But when we look across different studies, BRCA1 is, in terms of rates of saying they're HER2 negative, maybe 2 to 10% of these patients, they have a lower frequency of HER2 expression. So 2 to 10% have lower frequency. BRCA1 and 2 associated breast cancers have lower frequency of HER2 overexpression. And so what this particular study was looking at is how can we bring that kind of testing technology to the space of BRCA carriers? And is there any reclassification of patients that might have been deemed as HER2 negative and actually thinking that they may be HER2 low and qualify for this type of treatment? So this particular study was looking at identifying the prevalence of HER2-low breast cancer among individuals with germline BRCA1 or 2 or PALB2 carriers, and those that had been classified as HER2 negative. It was a retrospective observational study at the University of Pennsylvania. And what they found was that 47% of breast cancers that would previously have been categorized as HER2 negative would have then been now reclassified as HER2 low. So would have been eligible for trastuzumab deruxtecan in terms of looking at this new way of classifying this. And also interesting was comparing the metastatic biopsy site with the corresponding primary site. 25% were HER2 low at the metastatic site when the original biopsy site was classified as HER2 negative. So potentially thinking of biopsying metastatic sites if that is possible and clinically indicated. So the takeaways from this particular abstract was that a substantial portion of BRCA1 or 2 carriers of pathogenic variants who have HER2 negative disease actually could express low levels of HER2, and to maybe think about this in practice. The sample size was very low for PALB2, so they couldn't really draw conclusions. And so it may be a thought in terms of reevaluation of HER2 status in metastatic samples as well. And then the final abstract was looking at real-world cancer care utilization among breast cancer patients with germline variants of uncertain significance. This was presented by Dr. Alison Kurian from Stanford University. And the rationale for this particular abstract was that when we do genetic testing, we can get three kind of general types of results back from genetic testing, one of which is pathogenic or likely pathogenic variants or mutations. The second of which is variants of uncertain significance. So these do not impact clinical management, but they are in patient reports. And so the question is there overinterpretation of these results that informs management when it's not ready to inform management? And then, of course, negative results. So the concern in practice is are VUS results prompting overtreatment, as there were some signals in the literature that there can be recommendations for surgical management or other kinds of cancer risk reduction or screening approaches, particularly when VUS results return. So this particular study looked at linked databases from a germline testing company and linking that with insurance claims. This was looking at a study sample population of females with breast cancer, looking at those patients that had had multi-gene panel testing. And the genes that were analyzed looked at those genes that were linked with high breast cancer risk as well as moderate breast cancer risk. And really, the summary of the results is that the analytic sample included over 12,000 patients in this particular analysis. The pathogenic variant rate in the breast cancer genes was 6.4%, and the VUS rate was 10.4%. The most common gene with a pathogenic variant in this group was CHEK2, and the most common gene with variants of uncertain significance was ATM. And really, these results showed that breast cancer patients with VUSs were treated like other patients who tested negative, which is the way that it really should roll forward in practice. No overuse of bilateral mastectomy, imaging, PARP inhibitors, or platinum chemotherapy. There was a signal, though, that there potentially could be more bilateral salpingo-oophorectomies in these patients, potentially as well as selection of the type of chemotherapeutic regimens with VUSs versus negative, which does deserve further study. And some of the limitations was that claims data lack some clinical details, so it does deserve follow-up, but was somewhat reassuring when we think about how VUSs are managed in practice and that these educational efforts to providers and patients are really important to keep pursuing. So at a wrap-up, I did also want to bring forward a few selected poster presentations. I'm not going to give the detail of these presentations for the sake of time, but I would point you to looking up these posters and their abstracts, one of which was neoadjuvant therapy in patients with pancreatic ductal adenocarcinoma with germline DNA damage repair mutations. This was a dual institution retrospective study, and they found that for those patients that had resectable borderline or locally advanced PDAC that also carried germline DNA repair mutations had significantly prolonged disease-free and overall survival. With improved complete or near complete pathologic response rates when they were given neoadjuvant FOLFIRINOX. So a really exciting area to think about how genetics can be implemented across cancer types and also with using standard therapies and, of course, new and emerging therapies as well. There was a study out of City of Hope that was the INSPIRE study looking at more broad-based universal germline testing for cancer susceptibility. And this particular study looked at in-person or remote approaches for consenting and testing. They approached 26,000 patients, and 82% of those patients enrolled in the study. And the pathogenic variant rate was 20% for this particular population. So they're really looking at a scalable model to increase germline testing across more unselected populations in their catchment. Another study was looking at remote delivery of cancer genetic testing in veterans with metastatic prostate cancer. So this was the Million Veteran Program, a really great abstract looking at ways to, again, enhance access to germline testing and engage a population where there is a uniform healthcare system. And so this was, again, using sort of a remote outreach approach using informational letters sent to all eligible participants. 35% of the veterans completed the informed consent, and 23% of them completed testing. And the pathogenic variant rate in this population of metastatic prostate cancer patients was 13%. So again, thinking of rolling out these into large integrated healthcare systems for germline testing. And then implementation of universal germline testing in underserved patients with young onset GI cancers. This was looking at identifying and then reducing barriers and facilitators to germline testing. Here they looked at patients diagnosed with GI cancers between the ages of 18 to 50 and looking at what was the ability to engage and uptake with genetic counseling and genetic testing. The mutation rate here was 17% for these patients, but what they did identify were barriers such as cancer care delivery issues, being referrals, uptake of genetic testing, and timeliness of testing, availability of genetic counseling as key barriers to address for germline testing. So some of these conclusions, really, as I mentioned, so germline testing is now becoming more and more central in terms of various aspects of cancer care and risk assessment. Some of the key insights from ASCO 2024 were this growing knowledge of the germline variant spectrum across cancer populations, the application of germline genetics for novel therapies into thinking about this when identifying the germline spectrum across populations. Care delivery models really do help to enhance access to germline testing with demonstrated feasibility. And there's greater systems-based approaches that are needed across populations to expand germline testing. So I'm just going to end with, a plug for our cancer genetics and prevention program. We are growing and we are addressing the needs of our patient populations across the state of Connecticut. Really looking at what we learned from ASCO 2024. We are addressing a lot of the needs for patients who have cancers, who are at risk for cancers, and thinking about this from a disparities and equity lens as we roll forth our programs. These are our physicians in our program, as well as our genetic counselors and clinical genetics coordinators as part of our fast track approach. And these are our current signatures of care that we are growing to really help enhance access to germline testing. The classic genetic counseling model with referral to genetic counselors. We've developed a new fast track program where patients can receive expedited genetic testing through our program by coordinators and be able to build in how we can then implement more rapid disclosure of results to help with their treatments and return of these results to patients and providers. And we're going to be significantly rolling out point of care testing such that providers can actually offer genetic testing in their clinics. This has been piloted by physicians over the last few years, really, who are here today. And I think this is a really important model to roll forth as well, as we know more and more patients need genetic testing. So we're here to help support the needs of our patients and our healthcare providers. So thank you again for this time this morning in terms of talking about advances in germline testing. I have my email here at the bottom if anyone would like to reach out to me. Thank you. Oh, okay.
Thank you, Dr. Giri. We maybe have time for one or two questions, and then we're going to move to the GU session. Does anyone have questions? No questions.
That's fine.
Well, maybe I'll ask a question. So what are you most excited about in terms of really sort of further developing the cancer genetics program? Like what's the low-hanging fruit that you're really excited to accomplish this year?
Mm-hmm. Yeah, I think two things. One is really this ability to enhance access to germline testing using the various models that we have available. And we're actually going to be tracking the implementation metrics of this. So be able to have data that we can present back to say what works, what doesn't work, how much, where do we need to improve? So that's one, is an implementation, work. And the second is really cancer disparities. So building out tools, resources, and models of care that really do address our populations across the state of Connecticut. We have populations that really have significant diversity in terms of racial, ethnic diversity, language diversity, educational, education along the spectrum, so of care and, being able to understand cancer genetics. And so we really want to have, significantly improved outreach and engagement across diverse populations. So I'm really excited about those things.
Great. Thank you, Dr. Giri.
Thank you.
Right. So we are now moving into some of our disease-specific content. So I'd like to invite up Dr. Joseph Kim. He will be giving the hot topics in 2024 GU cancers. And some of you have noticed, as Dr. Herbst mentioned this morning, we've reorganized the structure of the day. So these hot topics are meant to be quick updates on really key impactful abstracts that have occurred over the course of the year at ASCO and other meetings. So Dr. Kim, please come up. And then maybe what I'll do is introduce and mention who will be doing the case discussion. Then you can just turn over to Dr. Petrylak and team. So Dr. Dan Petrylak will be moderating the case discussions for this session. And presenters in that will be Drs. Michael Hurwitz, Matthew Austin, and Yi An. Thank you.
Thank you. Good morning, everyone. I'm Joseph Kim. I'm one of the geomedical oncologists. Good to see everyone today. So my job is to talk about hot topics in GU cancers in 2024. So what I will do is I will just highlight some data that was recently presented at ESMO as well as recent ASCO. And I will try to also highlight some research program that we have in our GU CRT. So I'm going to touch on a couple of about 3 trials in urothelial carcinoma and a couple of trials in prostate cancer. So the first one, I'm going to dive into the first one. So this is a phase 3 study of, neoadjuvant durvalumab plus chemotherapy followed by radical cystectomy and adjuvant durvalumab in patients with muscle-invasive bladder cancer. So we know that the neoadjuvant chemotherapy improves survival in patients with a muscle-invasive urothelial carcinoma. But we know that about 50% of patients who experience recurrence within the first 3 years. We also know that immune checkpoint inhibitors are used in adjuvant setting, and it's been shown to improve disease-free survival in a couple of trials. Checkmate 274, which led to the approval of the nivolumab and ambassador study, which I'm going to discuss later, which again show improvement in DFS with pembrolizumab. So perioperative immune checkpoint inhibitors could improve long-term clinical outcomes by priming the anti-tumor immunity before the surgery and also eradicating the micrometastatic disease after surgery. So NIAGARA study was the first global phase 3 study to evaluate the perioperative immune checkpoint inhibitors, durvalumab combined with a neoadjuvant chemotherapy in cisplatin-eligible patients with muscle-invasive bladder cancer. So this was a study design. They accrued over 1,000 patients. Again, they enrolled patients who are cisplatin eligible, muscle-invasive bladder cancer. They also allowed node-positive patients as well, and also some urothelial carcinoma with divergent differentiation pathology. They randomized to the durvalumab arm versus control arm. In patients durvalumab arm, they received neoadjuvant durvalumab combined with the neoadjuvant chemotherapy. They were followed by cystectomy, and they received about 8 cycles of durvalumab in adjuvant setting. In control arm, they received just standard of care with gem-cis and followed by radical cystectomy. The study was done actually before the approval of the nivolumab, so not many of these patients received subsequent adjuvant immunotherapy. There are 2 primary endpoints, event-free survival and pathologic complete response. The primary events were defined as progressive disease that precluded radical cystectomy or recurrence after radical cystectomy or date of expected surgery in patients who did not undergo radical cystectomy. In other words, they had some reason not to undergo surgery. This was one of the primary events, and also a death from any causes. So this is a Kaplan-Meier curve showing event-free survival. Again, this was a positive trial. Hazard ratio 0.68 with a significant p-value. As you see here, 2-year event-free survival rate was improved by about 10% range or so. So this was a positive trial. If you look at the subgroup analysis of this primary endpoint, again, there's no particular subgroup that sort of stands out. Many of these subgroups do favor the use of durvalumab. The other primary endpoint was the pathologic complete response. They did 2 analyses. Basically, they show about 10% improvement in the complete pathologic response rate with the durvalumab. This was overall survival data. Again, this was positive. They showed about 7% improvement in overall survival at about 2 years. The hazard ratio is 0.75, moving 25% reduction in the risk of death with a significant p-value. Again, if you look at the subgroups, there's no major subgroup that sort of stands out. All of the subgroups drive benefit from the perioperative durvalumab. Looking at the AE summaries, again, the adverse events were comparable between the two arms. Grade 3 events, outcome of death, they were comparable between the two arms, and also treatment-related grade 3 events, again, very comparable between the two arms. There's no major adverse events leading to discontinuation of the neoadjuvant chemotherapy or foregoing radical cystectomy or delaying radical cystectomy. Looking at the in adjuvant setting, there were a few adverse events in the durvalumab as expected, but there's no major safety signals were raised in the adjuvant use of durvalumab. So in conclusion, Niagara was the first phase 3 perioperative immunotherapy study in muscle-invasive bladder cancer, and it led to improvement event-free survival and overall survival. The benefits were consistent across subgroups. Pathological response rate as well as OS benefits supports the perioperative approach of durvalumab. And adding durva to neoadjuvant chemotherapy appears to be tolerable and manageable with no safety signal. And neoadjuvant durvalumab did not delay any surgery or impact the ability of patients to undergo radical cystectomy. So actually there are several trials going on in perioperative setting. We have one of the studies available in our GUCRT, that's a Veda trial. So just to cover other studies that are going on. So patients who are cisplatin eligible, there's a Keynote 866, also a Checkmate 276 trial looking at their own IO combined with the chemotherapy. And also there's EV-based perioperative trials using EV pembrolizumab in Keynote 304 trial. This is for patients who are cisplatin eligible. And cis-ineligible patients, they are comparing EV with upfront cystectomy or pembrolizumab as a monotherapy. We have a Veda trial sponsored by AstraZeneca. This is for patients with a cisplatin ineligible. This is with EV plus durvalumab with or without the tremelimumab, which is a CTLA-4 antibody, versus upfront radical cystectomy. Again, there's an adjuvant IO given in the experimental groups. The next study is an Alliance A03-11504, the Ambassador trial. This is a study looking at the adjuvant pembrolizumab in patients with muscle-invasive bladder cancer versus observation in patients who had radical cystectomy. They update survival data here. So again, this was for patients with muscle-invasive bladder cancer after cystectomy if they have a high-risk features defined by YPT2 or greater, or a node-positive disease or positive surgical margin, or for patients who did not receive neoadjuvant chemotherapy, PT3 or greater or node-positive patients. They were randomized to receive either pembrolizumab or just observation. Pembrolizumab was given over 1 year. And again, two primary endpoints, disease-free survival and overall survival. This was a positive trial, hazard ratio 0.73 with a p-value 0.0027. And the median disease-free survival from pembrolizumab was 29.6 months versus 14.2 months in the observation arm. They also looked at different subgroups by PD-L1 status. Again, the PD-L1 status appears to be a prognostic marker. If you are PD-L1 positive, defined by CPS scored greater than 10, they have somewhat better disease-free survival, but PD-L1 status was not a predictive of benefit of pembrolizumab. They also looked at by nodal staging as well. Again, we know that nodal staging is a prognostic, but again, the benefit of pembrolizumab was not limited to certain nodal stage. There's benefits were seen throughout different nodal stagings here. There were some common sites of metastatic disease at recurrence. Again, the lymph node metastasis are very common. The pelvic lymph node, bone metastasis, liver, and lung were common sites of metastatic disease recurrence. So adjuvant pembrolizumab, it's again improved disease-free survival compared to observation in patients with high-risk muscle-invasive urothelial carcinoma after radical cystectomy. And the subgroup analysis show DFS benefit of pembrolizumab regardless of the PD-L1 status and the lymph node status. Metastatic recurrence were common in patients on observation group, and the sites for lymph node metastasis, lung, bone, and liver. Based on the doubling of the median DFS and manageable toxicity, the study supports the use of pembrolizumab as one of the therapeutic options. So this is currently under review at the FDA. So I'm going to switch my gear to a different interesting study called Tombola study. This was done in Denmark. This was actually a national non-randomized study looking at the use of ctDNA as one of the biomarkers to intervene with the adjuvant atezolizumab. So patients who underwent radical cystectomy, they were followed with the ctDNA testing, and when they become positive, if in other words, if they have a ctDNA detectable, they were treated with atezolizumab, and they were followed for up to 5 years worth. So again, this was not a randomized controlled trial, looking at the ctDNA as one of the biomarkers of intervention. So interestingly, ctDNA positivity was totally independent of their clinical high-risk features. About half of the patients who had no high-risk features on pathology, they still had positive ctDNAs. As you see here, about 56% of the patients has positive ctDNA following their radical cystectomy, and about 3/4 of the patients had detectable ctDNA within the first 4 months after a cystectomy. And the median lead time over the metastasis identified the CT scan was about 43 days. And of the patients who were ctDNA negative, only 2 patients end up developing metastasis on the CT scan during the follow-up time. ctDNA positivity is a prognostic factor for patients who has positive ctDNA. They have somewhat worse relapse-free survival and overall survival. So based on these data, there was a couple of trials going on in Vigor 011 study and also a modern trial where they're looking at the ctDNA positivity as a marker to intervene. So what they are doing in these studies is that after cystectomy, they follow, and if they become ctDNA positive, so on this in Vigor study, the patients will be randomized to receive either 1 year of atezolizumab versus placebo. If they were ctDNA negative, again, they'll be followed. If they become ctDNA positive, then they can be intervened with the adjuvant therapy. Again, this is a modern trial coordinated by the Alliance Study Group. We are participating in this study. Again, very similar design to what I told you with the InVigor study. Again, here we are using adjuvant nivolumab with or without relatlimab. Again, this is for patients with a ctDNA positive, but for ctDNA negative patients, they'll be randomized to either nivolumab for 1 year versus surveillance. Again, as they are being followed, if they become ctDNA positive, they'll be randomized. They'll be crossed over to 1 year of nivolumab. So I'm going to switch my gear to the prostate cancer. So AR degrader is really making a big, shift in prostate cancer. So BMS 365 is an orally bioavailable first-in-class heterobifunctional molecule with a dual MOA that degrades and also inhibits the androgen receptor. As a heterodimer, as a bifunctional molecule, it has 2 binding moieties, one AR binding moiety, and then the other is a CRBN binding moiety. Idea is to bring androgen receptor to a CRBN, which will facilitate the targeted ubiquitination and subsequent proteasome AR degradation. It also has AR binding moiety and competitively inhibits the androgen receptor binding. So this was a phase 1 study. They presented the part B, which is the dose expansion cohort. They tested about 4 different dose levels. They were sort of going into a twice-a-day dosing level, starting from 400 milligram to 900 milligram. Again, this was patients who were actually fairly heavily pretreated. And this is the baseline characteristics. Nearly about 50% of the patients received prior chemotherapy and both lines of RP inhibitors. So in terms of safety, there were mention of prolonged QTCs. Some of them are grade 3 QTC prolongation. They were asymptomatic. About 6 patients had QTC prolongations on this study. And in about 4% of the patients had this adverse event at 900 milligram twice-a-day dosing. There's no treatment-related adverse event that led to the discontinuation of the study drug here. This is a PSA response by prior treatment and by the dosing. It appears to be a dose-dependent response, more responses at 900 milligram dosing, but we have to keep in mind of the toxicity that were noted at the dose level. This is the PSA response, and also looking at the median PFS in patients based on the AR ligand-binding domain mutation status. The response was seen in both wild type as well as a mutant group. Again, numbers are quite small for a ligand-binding domain group here, only about 11 patients. But again, it seems to be a good activity with this agent, regardless of the AR mutation, ligand-binding domain mutation status. So in summary, BMS 986365 was fairly well tolerated with manageable safety profile. There was some concern for QTc prolongations. They're still working on the dose optimization at this time. They were seeing some anti-tumor activity in heavily pretreated patients with MCRPC, all progressing on at least one line of RP therapy. This is one of the first-in-class dual AR degrader and antagonist with the potential of overcoming the RP-resistant MCRPC, regardless of their ligand-binding domain mutation status. We are in process of having the study in our GU-CRT. We do have some other AR degrader trials in our GU-CRT. We've been heavily involved with the studies with Arvin 766, as well as we have another AR degrader using from Genentech Roche as well. So this is another study. This was actually one of the presidential presentation at the ASCO meeting. This is a PEACE-3 trial. This is basically looking at the combination of enzalutamide with radium-223 versus enzalutamide monotherapy in patients with MCRPC who are asymptomatic or mild symptomatic with bone metastasis. So this was the again, credits to Dr. Fezazi, who discussed this study. Really, at the time of study design, we knew that the enzalutamide improved, overall survival in both pre-chemotherapy setting, post-chemotherapy setting, or from trial, previous trial. We knew that. We also knew that the radium-223 improved survival based on its SIMCA trial. This is over a decade ago. And there's no overlapping toxicities of these two agents. And based on our experience with combining ADT with the radiotherapy, it made perfect sense to combine these two agents. We also knew that bone protective agents is important in managing our patients. It does prevent the SRE. We use either denosumab or zoledronic acid for our patients. So in terms of the efficacy and safety data, again, the patients were randomized to receive either combo versus enzalutamide monotherapy. It met the primary endpoint of a radiographic progression-free survival. Difference was about 3 months. In terms of the safety, we have to remember the earlier trial with the ERAS 223 trial, where they used the radium-223 with abiraterone. There was increased fractures in patients not receiving bone protective agents. So actually, they terminate this study, and on this PEACE-3 study, they mandated the use of the bone protective agent, and it does have an impact in preventing the risk of fracture. Right. And in terms of the safety of the study, overall safety AEs were fairly well manageable. There was an increased incidence of hypertension in patients receiving enzalutamide. More than 30% of the patients experienced hypertension. So we have to closely monitor those side effects. And also, we have to keep in mind of the osteonecrosis of the jaw, which can be caused by the bone protective agents. They have not reported this data here in this presentation. So is it practice changing? We do know that the combination have an impact on the RPFS. We'd like to have another meaningful clinical endpoint. In this study, they did not show improvement in time to pain progression or time to skeletal-related events. Looking at the survival data, there is a difference in survival by about 7 months or so. But if you look at the first 18 months or so, there's an overlap of the survival curve. We do need to wait for further statistical analysis to make sure that this holds a statistical significance. But clinically speaking, there seems to be a big difference in the overall survival here. Again, the landscapes is changing constantly. It's not the only study looking at the radium combination. We do have a study that's led by Dr. Michael Hurwitz here at Yale. We have a DORA trial combining docetaxel chemotherapy with the radium-223. Again, this is a randomized control trial. And there are also other trials going on to combining radium-223 with other RP and chemotherapy in other setting. All right, so combining enzalutamide with radium-223, it does improve RPFS as well as overall survival in patients with MCRPC. Somewhat earlier setting, we use radium-223 rather in later stage setting in patients with quite significant disease symptoms. But this data support that we may be able to use this agent early in the setting. Again, the bone protective agent is mandatory, for our patient population, especially when they're receiving the radium-223. And the baseline symptoms was not needed to benefit from this combination approach. And the blood pressure management is very critical in patients receiving the enzalutamide-based therapy. More data is needed from the trial, looking at the ONJ, quality of life, and also long-term survival data with additional statistical analysis. With more radium-223 based trials, we'll be able to optimally use this agent for our patients. And I discussed this, the data for lutetium-177. There's really emerging data using lutetium-177 as well as other radioligand therapy in prostate cancer. So just kind of summarize. For urothelial carcinoma, again, the landscape's changing. We are using this IO in perioperative setting and also in adjuvant setting. We need to do better. We are sort of looking at the use of ctDNAs in identifying patients who are at risk of relapse of their disease. We're identifying what they call minimal residual disease status, where we can adequately use the immunotherapy in adjuvant setting. Also in prostate cancer, again, AR degrader is one of the agents of promising activity. AR remains to be a valid treatment target for treatment refractory MCRPC. There's novel targets such as PSMA and STIP1. We have several trials in GU portfolio. I did not discuss in MCSPC setting for newly diagnosed metastatic castration-sensitive prostate cancer. We have a PARP1 selective inhibitors, as well as a SIMCAP trial looking at the cytoreductive prostatectomy for our patients. We also have a trial with Sipuleucel-T with a bipolar androgen therapy for in earlier setting of MCRPC. We have several bispecific trials using SIP1, CD3 bispecific, PSMA, CD3 bispecifics. These trials are really ongoing right now. We have other novel targets such as GR antagonists and others as well. In urothelial carcinoma, as mentioned, we have a VORGA trial in perioperative setting using EV-based therapy. In adjuvant setting, the modern trial, again, looking at the nivolumab with relatlimab, and we are using a ctDNA to identify these patients. And for frontline setting, we have a different Nectin-4 antibody conjugate, again, combined with pembrolizumab in both frontline setting and in second-line setting as well. We have a couple of STROC trials using a Ribulant combined with gemcitabine. Dr. Matt Austin is leading the study from our care centers. We have other novel targets in urothelial carcinoma. Very good. Thank you. Any questions? Yeah. Okay. If not, then we'll come on over and we'll moderate the next session. Thank you.
So, good morning. Great seeing everybody here today. We're going to be talking about a couple of cases. We introduce Dr. Matt Austin, Dr. Yi An, and Dr. Michael Hurwitz, and Dr. Joe Kim will be discussing some of our cases this morning. So one of the things I think that's becoming very apparent is that enfortumab vedotin is a critical drug in the treatment of metastatic urothelial carcinoma. And we presented some data to ASCO this year, retrospectively looking at 3 trials where we found that dose intensity within the first couple of cycles was really critical to the overall response rate. So, Mike, you want to start talking about this case?
Sure. Can you hear me? Yeah. Okay. All right. So this is a 64-year-old guy with metastatic TCC. He got pembrolizumab 200. Now it's on. I'm pretty loud anyway. All right, and he got 2 doses of EV, which as Dan pointed out, you know, this dose intensity early matters quite a bit. So 8 days after his second dose, he developed generalized myalgias and a generalized exanthematous-like eruption. Rash was pruritic, it had a burning sensation, and didn't improve with diphenhydramine. And on exam, he had diffuse 2 to 6 millimeter pink, blanchable, non-tender macules and thin papules, which I think we have here, right?
That'll be the next.
Oh, that'll be the next one.
Yeah.
So, you know, what are the options for this guy? Oh yeah, well, there he is. Okay. So, going back, and what are the options for him? And I guess, one question is, what is the etiology? Is it definitively enfortumab? But so one you could treat through potentially. Another you could dose reduce from 1.25 by 20%, which is sort of a standard dose reduction we do with this agent. You could hold it and start topical steroids, or you could continue it and start topical steroids, or finally you can continue it and start oral steroids. Anyway, should we just go through, or
Sure.
do people want to talk
Why don't we
about
go through that? And well, actually, yeah, why don't we just simply go through this? This is our rash. And these, Mike, these are the skin manifestations that we've seen with enfortumab. It can range from anything from conjunctivitis, maculopapular rash, truncal rashes, blisters, dry skin. Hyperpigmentation is actually something we've seen in people who've been on this for a long period of time. Not really sure what the etiology of this is. But the important thing to keep in mind with enfortumab is managing toxicity, because you're looking at the long-term treatment gain from this particular drug. So we presented some data that at ASCO that you can actually interrupt doses safely after the first 2 cycles of treatment without compromising the overall response rate. So in this particular case, the rash is something that we found from that analysis that generally occurs within the first 8 to 12 weeks of treatment. Neuropathy occurs much, much later, and that really you do need to dose reduce or hold doses at that particular time. But these are the classic rashes that we see in this situation. And there is an algorithm we use to basically treat these particular patients. A grade 1 rash, supportive care is clinically indicated. A grade 2 rash, you would consider anti-infectives as well as topical steroids. And then grade 3, you would interrupt and then potentially give oral steroids as well in this particular case. And the thing you don't want to see happening is Stevens-Johnson syndrome. We've had 1 case of Stevens-Johnson syndrome on the phase 1 trial. So that's something that's important. In fact, in France, when the drug was first being rolled out, they actually stopped the rollout because of that particular reason. There were patients who were treated through the rash and they developed grade 3s and they were never put on topical steroids.
If you want to go back for 1 second, I think one of the other things that is notable, it doesn't happen that often, obviously, but this at the top here with the red sign there, those are the things you have to worry about. If people are really having pain, if they're febrile, if they're having systemic symptoms, then you really worry that it's one of these really terrible Stevens-Johnson, et cetera.
Exactly. So that's I think the critical thing. Watch out for Stevens-Johnson syndrome. And the neuropathy is something that we dose reduce or hold doses at a particular time. That is not as much an influence on the overall response rate. In fact, you can interrupt patients for 2 and 3 months and their disease will remain stable. So I think that's really a critical thing towards patient management. Okay, number 2.
Yeah, thank you. So case 2, 48-year-old male, presented with progressive lower urinary tract symptoms, was noted to have an elevated PSA, which prompted a prostate MRI. He had a PIRADS 5 lesion in the right side of his prostate and was noted to have this diffuse abnormal signal throughout. Additionally, was noted to have pathologic appearing lymph nodes in the pelvis. Through urology, given some urinary retention, underwent a TURP, was noted to have a frankly malignant mass. And pathology was a little bit of a curveball. It showed a mixed high-grade neuroendocrine carcinoma combined with a Gleason 5+4 prostatic adenocarcinoma. The neuroendocrine component stained classically for a neuroendocrine tumor was synaptophysin chromogranin positive with a very, very high Ki67. The adenocarcinoma was negative for neuroendocrine markers and positive for NKX 3.1. Patient underwent a PET scan, had widespread diffusely FDG avid. This was not a PSMA PET scan. Lymph nodes in the pelvis, innumerable FDG avid pulmonary nodules, and then markedly hypermetabolic lesions in his liver as well.
So quick question, Matt. What was the patient's PSA at initial presentation?
Relatively low, less than 20. I believe it was probably 12 or 13.
So this is actually classic for this type of presentation. Low PSA, small cell or neuroendocrine generally does not make a large portion of PSA. In fact, often coexists, as you're seeing in this particular case, along with the standard adenocarcinoma of the prostate. You're making an important point about the PET scan. This patient had an FDG PET. And one of the things that we have noticed has been noticed with PSMA PET scanning is that these are generally cold in the neuroendocrine tumors or the high-grade prostate cancers in the liver. We've had some cases where you've actually imaged positive for small cell with PSMA, but they're very, very rare. But the one thing you have to be very, very careful of if you use a PSMA PET scan is you can miss hepatic metastases. And the other area too that we tend to see false positives in is in the ribs. So what are your options for this patient?
Yeah, so I put up 4 options, and I think it highlights a lot of practice variability in the community. Option 1 would be triplet therapy for high volume metastatic castrate-sensitive prostate cancer, second generation anti-androgen plus hormonal therapy plus Taxotere. Option 2, I put doublet chemotherapy with carboplatin docetaxel. Option 3 would be carboplatin etoposide. Then option 4 is really extrapolating from the lung cancer literature with small cell lung cancer, where we saw survival benefit with incorporation of immunotherapy. And I would say in the community, in academic centers, there's a lot of variability about the use of immunotherapy in extrapulmonary high-grade neuroendocrine carcinoma. So I put that in as a 4th option as well.
So this is a castration-sensitive patient, correct?
Yep.
So he's
De
not
novo, new diagnosis.
a new diagnosis. He has not had any treatment previously. So, Joe, what do you think?
So I think, we have to treat both disease. I mean, what's going to kill him will be, neuroendocrine carcinoma of the prostate. So that will be the priority. So actually, I will go with option number 3. Again, we have to kind of think about some study that we may discuss later on, but carboplatin is sort of what we have in mind. And I think, given it's some adenocarcinoma component, I would definitely start some ADT with a second generation AR antagonist as well.
Mike, do you agree?
Yeah, I think for the most part, I think that we totally agree with Joe that the thing that's going to kill this man is going to be the neuroendocrine component. Even though this is a very high grade adeno, that's not going to be a big issue for him comparatively. I think it wasn't definitively small cell, right?
Nope, it was
Yeah.
specifically high-grade neuroendocrine carcinoma with high K6.
So I think that there's a similar but not identical approach, really primarily driven by the work of Anna Aparicio and at MD Anderson of using taxane platinum combinations. So I think number 2 would be a reasonable option as well, or even Capaz. You could use Capaz instead of docetaxel. But yeah, so I think either 2 or 3 would be reasonable. I just want to point out one thing, which is that the only time I ever see this combination, which we see relatively frequently now, is de novo, is when you have Gleason 4+5, 5+4, or 5+5 disease. I've never seen it in anything less than that.
Right.
And so I think, or what we now call WHO 5 disease, in those patients, I'm particularly worried. So if I see anyone with WHO 5 disease, and if they don't have this, I scan them more frequently, because sometimes you'll have the PSA drop to nothing, and then the next thing you know, they've got liver mets or something else.
Exactly. So there is a difference between de novo versus treatment related. In fact, if you withdraw androgen from prostate cancer cell lines, you'll find that they do develop along the neuroendocrine pathway. So anytime you have a patient who has a low PSA or no PSA, and they start developing systemic symptoms, that's a justification for reimaging that patient. Again, preferably with conventional imaging rather than with PSMA PET scans, because you may miss hepatic disease. Dr. Ahn, any role for local therapy here?
In this situation, really local therapy with radiation reserved for palliation. The one exception that we will say is that if it's really oligo metastatic, we can attempt reasonably safe local therapy and see if that can delay the need for adjusting the systemic therapy, but it's really case by case.
Terrific. Okay, so Matt, why don't you describe SWOG 2012?
Yeah, so this is a cooperative group study, and my clinical practice is in the community. And what I get excited about with this trial, it's available in probably the majority of the Yale Cancer Center community sites. So it's extrapolating from the small cell lung cancer literature and really trying to answer the question if incorporation of immunotherapy for poorly differentiated, high-grade, extrapulmonary neuroendocrine carcinoma makes a difference. So it's a 3-arm trial. Arm 1 is the control arm. They get randomized, or in this slide, it's arm 3. They get randomized to platinum standard of care chemotherapy with etoposide. And then in the diagram, arm 1 is atezolizumab in the induction, followed by maintenance atezolizumab. And then arm 2 is trying to answer a question of whether we really need to continue atezolizumab in the maintenance arm, or is that really only important in the induction setting, and continuing in the maintenance arm may provide additional autoimmune toxicity, but no clinical benefit. So it's a 3-arm trial, and essentially it's trying to answer the question, extrapolating from lung cancer, small cell, if incorporation of immunotherapy to extrapulmonary neuroendocrine carcinoma makes a clinical difference.
Terrific. And I think one of the unique things about this study, often these patients come in with rapidly progressive disease. You want to get them treated initially, and their LFTs may be elevated if they have hepatic metastases. So you can actually treat with one cycle of carboplatin and then move on and randomize them on the trial. So if you've treated the patient, you still have the potential of putting them on study after their initial induction treatment. So that's important to note.
Yeah, great point. This patient, it may be the next slide. He actually was given his first cycle of carboplatin etoposide urgently off trial, given burden of disease. The trial, from a prostate cancer perspective, does allow hormonal therapy and second-generation hormonal therapy orally to target the Gleason adenocarcinoma component. So he got cycle 1 off trial. He was started on hormonal therapy and enzalutamide, and then for cycle 2 was randomized into the atezolizumab arm. Got it with induction therapy, was randomized into the maintenance phase. So he started therapy in February of 2024. He's had a very robust PR. He's 11 cycles in and remains on treatment today.
Terrific. Problem is, what do we do with these patients afterwards? These patients should be molecularly phenotyped. We are moving on some newer unique trials in this state of disease, and most of them require that the patients have at least a 50% component of small cell or neuroendocrine in their prostate cancer. So that's moving forward. Our final case, last but not least, radiation oncology. Dr. Ron, please, you have the forum.
Thank you. So this is a patient who had prostatectomy about 6-7 years ago, needed salvage radiation and had short-term ADT for biochemical recurrence about 3 years ago. The PSA was initially undetectable after the radiation, but now rising to about 1 with a normal testosterone level, still castrate sensitive. The updated PSMA PET scan showed only uptake in 2 sites, and L1 in the sacrum. And patient also personally preferred to try to delay the ADT initiation as much as possible, given their experience on the prior course. So in terms of next treatment options, of course, patients can be on ADT alone. There's some evidence now, especially for maybe short ADT doubling time, of adding additional anti-androgen. But we have this concept of metastases-directed therapy with or without ADT as an option. And I think it really speaks to the heart of when we have oligometastatic disease, how much microscopic disease there is elsewhere in the body that we can't detect. In this situation, we ultimately, in a multidisciplinary setting, elected for SBRT alone. And so patient received SBRT without ADT to the 2 sites, and the PSA nadir was undetectable a year later. And you can see that we have this typical delayed cell death after radiation, took about a year. Now it's about 2.5 years from the treatment. The PSA is detectable, but the patient has still not needed any ADT, is eugonadal, and has not had any late toxicity from this SBRT course. Recently, very thoughtful. We chose a SBRT dose that was not the highest dose. This is not necessarily a curable situation. We wanted to avoid compression fracture, especially with patients who may need long-term androgen deprivation and risk of bone density issues with that. No lumbar plexopathy, given the location of the sacral lesion. But overall, this has been a successful case. But it speaks to, especially with such a great biomarker that is PSA without ADT, we were able to confirm that clearly there was not much, if any, microscopic disease outside from the 2 lesions.
So I really like this case because I think it highlights something that we're all starting to think about in this disease. The use of PSMA PET scanning earlier, detecting disease earlier. This, we don't know, since we don't have conventional imaging, we don't know if this is somebody we would have detected by a conventional scan or not. And then how much therapy is necessary in a patient who may be frail, may be elderly, may not tolerate androgen deprivation therapy very, very well. So this is why it's so important to have a discussion amongst the nuclear med doc who's performing the PET scan, the radiation oncology doc, and the medical oncologist to be sure that we're doing the right thing for the patient. I have somebody like this who's 93 years old, and he's doing great right now off ADT. And he clearly had hot lesions on the PSMA PET scan. Joe, what are the things that you look out for in a PSMA PET scan? Where do you think you see most false positives?
We see a lot of false positive, mostly in the rib lesions. We have to kind of definitely look at the clinical context of this. If it's kind of isolated rib lesion, we also look at the CT correlates as well. In the absence of CT correlates, we tend to say this likely a false positive finding. We definitely look at the lymph node metastasis and other pelvic, bones as well. Yep.
Well, I think what you're pointing out is that it's important to look at the overall clinical picture of the patient. Dr. Ahn and I have a patient that we share together that had a relapse 12 years after radical prostatectomy. He lit up in the bed and he also lit up in the ribs. As Joe pointed out, there's a lot of false positivity. We gave him 6 months of hormones, radiated the bed, and then stopped. Those ribs are still there, but he's got a negative PSA at this point, PSA of 0. So you have to put this in the clinical context. Do you think this is aggressive disease or not, based upon how quickly it relapses and where it relapses? So, gentlemen, any other thoughts before we wrap up for today?
I'll just add, obviously, de novo, like a synchronous metastases, oligometastases is very different than a metachronous oligometastatic disease. We have separate trials ongoing nationally and internationally in both settings. And the best evidence we have for a metastasis-directed therapy is in the metachronous oligometastatic setting right now.
Exactly. In fact, there are trials going on right now in metastatic patients. We have one, SimCap, which is looking at doing a radical prostatectomy or radiation therapy prior in a patient who has metastatic disease. It seems that at least in retrospective data, the treating the primary does have a different impact on overall survival. Mike,
Yeah, no, I just think that because PSMA PET is so sensitive, we feel a little more comfortable if we see a lesion and we don't see a lot of other stuff to ask Dr. Ahn and his colleagues to go after things that we never would have done in the past. And probably for a lot of patients can sort of keep them going for a long time without having to worry so much about other things, even if it may not be curable. It gives them durable responses for a long time.
And I would just extrapolate on case 3. The other situation where I've had really good success with this is elderly, frail people that are becoming progressively castrate resistant that I don't want to escalate care on or treatment on. Mm-hmm. So I have an 87-year-old who's now progressing on Zytiga, had oligometastatic progression, really not a great chemotherapy candidate. And we SBRT'd, he had single site progression and has done fantastic, even at time of progression, with the goal of delaying escalation of systemic therapy.
Right. Gentlemen, thank you for your cases and comments. Turn to podium, Dr. Kunz.
Great. Thank you to the GU team. We are next moving to GI. I'm not allowed to have favorites, but this might be my favorite. Dr. Lacy, you can come over. So we will kick this off with a hot topics. I'll move for you. Hot topics in GI cancers by Dr. Jill Lacy. And then we will move to a case discussion that I will moderate with presenters, Drs. Laura Baum, Jeremy Kortmansky, Saj Khan, and Kevin Du. Thanks, Jill.
Okay, so thank you, Pam, and welcome everyone this morning. It's truly a pleasure to be here today speaking on the hot topics in GI cancer. And here are my disclosures, and here is the agenda. So I've selected a few of many, I think, impactful oral presentations at ASCO and ESMO from 2024, starting with resectable esophageal adenocarcinoma, the ESOPEC trial, and then moving to metastatic colorectal cancer, advanced HCC, advanced neuroendocrine tumors. And if time permits, it probably won't, I'd like to touch on some of the promising new therapeutics that are really bringing hope to this field and where Yale has had an important role in studying these drugs. So here are the key takeaways from each of these presentations in bulleted form, and I'll highlight these as we go along. I think the overarching takeaway from my perspective is that in 2024, we have made significant progress in GI cancers, albeit admittedly it is more incremental than transformational. But we have ever more options for our patients, and so careful patient selection and weighing the toxicities against the efficacy is increasingly important in outlining a long-term management plan for our patients. So we'll start with ESOPEC, perioperative chemotherapy, FLOT versus neoadjuvant chemoradiotherapy, or CROSS, for patients with resectable esophageal adenocarcinoma. So ESOPEC was a plenary presentation. It's received much attention, and it has been heralded as practice changing. So we're going to take a careful look at what we learned from ESOPEC and also importantly, what we didn't learn. So why do ESOPEC? So in 2016, when this study was initiated, we had two options for this patient population. Both had been shown to be superior to esophagectomy alone in these three randomized trials highlighted here in this figure. So we most often were using preoperative chemoradiotherapy with the cross regimen widely used, which was radiation with low dose weekly carboplatin and paclitaxel. We also had the option of a non-radiotherapy treatment with perioperative chemotherapy with the FLOT regimen, fluorouracil, oxaliplatin, and Taxotere shown to be superior to the very old MAGIC trial. So there was no clear winner between these two options, and part of that was because these randomized phase 3 trials included a very mixed patient population. The perioperative trials included gastric adenocarcinoma, actually were predominantly gastric cancer studies, and the cross study included squamous cell histology, which is really a very different disease biologically, we know. So I think when we put ESOPEC in context in 2024, it's important to appreciate the treatment evolution that we've seen since this study started, and largely really since 2021. And I've highlighted the three publications that are relevant to this. So we've shifted away in the adenocarcinoma patient population from cross to FOLFOX, and that's based on the disappointing long-term results of cross in adenocarcinoma. It's better in squamous cell carcinomas, and the very encouraging data with FOLFOX using more induction FOLFOX as well as radiation from the CLGB 80803 study. We now routinely use adjuvant nivolumab. This is a standard of care since 2021 after preoperative chemoradiotherapy in the high-risk patient population with residual carcinoma in the esophagectomy specimen. Increasingly, we are considering organ preservation in selected patients with the complete clinical response. This is what's happened in rectal cancer, again, where the morbidity of surgery is high. And then finally, for the MSI high patient population, which is about 5% of our patients, we go down a completely different treatment paradigm incorporating immune checkpoint inhibitors in the neoadjuvant setting. So here's the ESOPEC trial scheme. It's very straightforward, a one-to-one randomization of perioperative FLOT versus cross with a locally advanced patient population, muscle invasive or node positive adenocarcinoma, no metastases. Importantly, patients had to be medically fit, and I would say also agree to an esophagectomy. Gastric cancer patients and squamous cell patients were excluded. So this is a more homogeneous, clean population. Primary endpoint, overall survival. It's important to appreciate that in the cross arm, a third of the patients did actually not complete chemoradiation therapy. That's a surprise and a much higher percentage than we've seen in other studies. Not surprising was that about 47% of patients did not complete postoperative FLOT. It's very hard to give chemotherapy after an esophagectomy. So here are the results. This was a positive study favoring FLOT with an improvement in overall survival with a p-value or hazard ratio of 0.7. There was also an improvement in progression-free survival. And the additional findings were that both of these approaches led to similar R0 resection rates. They were both reasonably safe. What was a little disappointing was the low pathologic CR with both treatments. So these are not really great strategies for organ preservation. And also disappointing is that still we are not curing about 50% or more of patients. And so clearly we need better systemic therapies because most of the relapses are metastatic. So importantly, we should not extrapolate ESOPEC to patients who are not proceeding to an esophagectomy. Those patients should get chemoradiotherapy, not to squamous cell cancers and not to MSI high tumors. So we know what we learned, but what did we not learn? And I think this is important. So the elephant in the room right now is what about immunotherapy? So the standard of care has really moved to preoperative chemoradiotherapy, followed by adjuvant nivolumab if there's not a path CR. That's based on Checkmate 577, where we have impressive PFS benefit, no overall survival data yet. So should we just add immunotherapy to FLOT, extrapolating from Checkmate 577? I think the answer to that is clearly no. There are 3 studies looking at this, and the Keynote 585 study adding Pembro to perioperative chemotherapy was a negative study, so we should not be doing this yet. And then what is the role of preoperative chemotherapy when it's added to optimum systemic therapy, which cross is not? And I think this question was partially, but not really addressed in the Top Gear study. So we have waited many, many long years to get the results of Top Gear, which was asking the question, is there a benefit to neoadjuvant chemoradiotherapy added to standard perioperative chemotherapy? Now, this is really a gastric cancer trial. You can see that in the title. This was presented at ASCO and published simultaneously the same day in the New England Journal of Medicine. So take that under advisement. Esophageal adenocarcinomas were excluded. There were a subset of patients with EGJ cancers. So cut to the chase, the bottom line is that adding chemoradiotherapy to perioperative chemotherapy in gastric cancer is not of benefit, although it does not increase toxicity, and it does increase the pathologic complete response and leads to more tumor downstage, but not translating to survival benefit. So perioperative chemotherapy remains the standard of care in gastric cancer, no chemoradiotherapy, no immune checkpoint inhibitors. I think the jury is out for esophageal adenocarcinoma as to whether there's a subset of patients that might benefit from chemoradiotherapy. And in fact, Top Gear actually suggested that in the subset analysis with a hazard ratio of 0.78 for chemoradiotherapy in the EGJ patients. So here we are, 2024, and this slide summarizes what I just went through. The pendulum swings, cross out cross, plots in. I think the story certainly will be continued, but flawed is the preferred treatment for now. Nivolumab in the adjuvant setting should be limited to patients who were treated with chemoradiotherapy neoadjuvantly. I think we still need to understand how to deploy chemoradiotherapy with good systemic therapy and who benefits. And then importantly, for patients who are declining, deferring, or cannot undergo surgery, chemoradiotherapy is still a part of the standard of care, preferably with more and better systemic therapy. So we're going to move now to metastatic colorectal cancer. And there were two really important presentations at ASCO looking at patients with liver-only metastatic colorectal cancer. So the first was the Collision trial. This trial was focused on patients with resectable liver-only metastatic disease. So I think we've all known for about 4 decades now that hepatic resection for patients with liver-only metastatic CRC is curative, although with long-term survival, the cure rate drops to only about 20 or 25% of patients, but curable nonetheless. And the big question in the last decade or more has been whether surgical resection is better than taking a less invasive ablation approach with microwave or radiofrequency ablation. And the retrospective studies have yielded mixed conclusions. In NCCN, hepatic resection still is sort of the gold standard treatment of choice with thermal ablation consideration. So the Collision trial was designed to test the hypothesis that thermal ablation is non-inferior to surgery. So here is the design. Patients with limited 10 or less metastases were randomized to resection. Ablation was also permitted if needed, or ablation with limited resection also permitted. Most of these patients had a limited tumor burden, 3 or fewer small lesions. And again, this was a non-inferiority study. So this study met its primary endpoint. Thermal ablation was non-inferior to surgery in this study. No difference in survival. Also no difference in local and distant progression-free survival, but differences in adverse events, length of hospital stay, favoring thermal ablation. So thermal ablation, I think clearly now is a comfortable option in selected patients with small, limited liver-only metastatic colorectal cancer. I think we can feel comfortable that we are probably not compromising cure, although it's important to follow these data long-term, given the late relapses that we can see. I think the question is how generalizable is this strategy, given the patient selection that went into the study. I'm sure there are going to be strong institutional biases and certainly differences in institutional expertise. And I think for the oncologists in the room, the big question is always how much and what systemic therapy is needed both before and after, especially given the high rate of relapse. So now we're going to pivot to patients with unresectable liver-only metastases. And unfortunately, most patients with liver-only disease will not be candidates for consideration of a Collision strategy. They have multiple disease in both lobes. And we've had intriguing data regarding transplant, liver transplant in this population. So the TransMet study was designed to address the role of transplant in these patients. So here is the trial design. Patients were randomized to transplant plus chemo versus chemo. Very selected patient population, younger, good performance status, no BRAF, lower CEA. And these patients went through really a very rigorous selection and prioritization process. So about half the patients were deemed ineligible after independent multidisciplinary review. So 94 patients were randomized and 74 completed therapy per protocol. So these results were impressive. Obviously, the Kaplan-Meier curves speak for themselves with a significant improvement in 5-year overall survival, the primary endpoint in both intent to treat and per protocol patients. This is not a cure. 72% of patients who were transplanted did recur, but many of those recurrences were oligometastatic lung and could be handled with focal therapies. So the takeaway here, in the context of very rigorous patient selection, liver transplant, I think, offers the hope of long-term survival in this very difficult patient population compared to chemotherapy alone. So this is very tantalizing and very exciting, but it has really led to many questions and many challenges, and I've highlighted a few of them here, and this list could be much longer, but I think I would like to jump to the bottom, and that is, can we ever achieve equitable access, at least in the United States, to transplant for appropriate patients? And I stole this figure from the discussant of this study, who showed the distances that patients in the United States are traveling to access liver transplantation. And so I think it goes without saying that many of our patients will be excluded from this very promising treatment. So we're going to flip now to microsatellite instability high metastatic colorectal cancer. So going into 2024, the standard of care here was Pembro, based on the Keynote 177 study, which showed dramatically superior PFS and OS with Pembro versus chemo in the first-line setting for MSI high metastatic colorectal cancer. So at ASCO GI and ASCO, we heard the results from Checkmate 8HW, which had 3 arms in it, standard of, well, FOLFOX, not standard of care, Nivo plus Ipi and Nivo. And we heard about the results from the chemo versus Ipi-Nivo arms. We are eagerly awaiting the most important results from the Nivo versus Ipi-Nivo arms. Study. This is in the advanced HCC space. We're moving from Checkmate 8HW to 9DW. Good luck keeping those straight. So this was a randomized trial in advanced good patients with HCC, so Child-Pugh A, good ECOG performance status, comparing a TKI, lenvatinib or sorafenib, against the Nivo-Ipi combination with the higher dose of Ipi, primary endpoint overall survival. And this was a positive study for overall survival, hazard ratio 0.79. I think it's important to look at the treatment-related adverse events, 25% serious and 4% deaths. So that's a little bit sobering. And of course, again, cross-trial comparison is inevitable with the 2 other regimens we have, Atezo-Bev and the STRIDE regimen with a single dose of Tremi and Durva. And again, sort of you be the judge here, but what's notable about Ipi-Nivo is the response rate and the durability of response. So again, another first-line option in this setting. in addition to atezo-bev and the STRIDE regimen. And again, for those patients who are not eligible for bev, which is a considerable number due to varices and where response may be a priority, and again, balancing toxicity against efficacy. And last but not least, a very important study in advanced neuroendocrine tumors. This is the cabinet study that was presented in an oral presentation at ESMO with a simultaneous publication in New England Journal of Medicine, very much deserved in my opinion. So the patient population here is well-differentiated neuroendocrine tumors from any site, including lung. Patients had to have had a prior, not only somatostatin analog, but have progressed on one other FDA-approved treatment. So these are patients with advanced neuroendocrine tumors refractory to at least one line of treatment. 60% of the patients notably had prior Lutathera. So I think this is important, really important data for that patient population. And the majority of the patients had prior everolimus. So here's the trial design: extrapancreatic and pancreatic, 2-to-1 cabo versus placebo, primary endpoint progression-free survival by blinded central review. I think these results are really impressive. This is very exciting from my opinion, with cabo significantly improving the PFS in previously treated patients, not only in pancreatic neuroendocrine tumors, which I think we might expect, but also in the extrapancreatic tumors, including lung. And benefit was seen in all subgroups. And so this is really the first reported randomized study looking at treatment options after prior Lutathera or other targeted drugs. And again, another treatment option for patients with previously treated neuroendocrine tumors. So the challenge that Dr. Kunz faces every day in clinic is with these expanding choices, including liver-directed therapies, what is the optimum sequencing of these modalities? And I think that is a story to be continued. In the interest of time, I will not go through these promising new therapeutics. I will show them here, though. Domvanalimab, which is a TIGIT inhibitor, which is showing very encouraging promise in treatment-naive metastatic gastroesophageal cancers in combination with the PD-1 inhibitor. We saw that data. An adenosine receptor inhibitor from Arcus, looking very promising in combination with bevacizumab and FOLFOX in chemorefractory colon cancer. And I think very, very encouraging data with AbbVie's AD400 antibody, drug conjugate to CMET, which is showing very impressive activity in a highly refractory colorectal cancer patient population. So to be continued, and these have been drugs that we have had in trials here at Yale and continue to do so. So back to our key takeaways. We'll conclude with that. I think this is a very exciting time, not only for increasing options for our patients, but also I think the promise of new therapeutics. I think we are truly entering a new era in the GI oncology space. So thank you all for listening through this, and I have to acknowledge ASCO and ESMO for making all of this really exciting data publicly available for me to borrow, and most importantly to the presenters, the authors, and the discussants for their slides and some of their content, and to my GI oncologists who gave me a lot of feedback about how to contextualize these studies.
Great. I would love to invite the panelists for our case discussion up. So Drs. Baum, Du, Kahn, Kortmansky. Dr. Lacy, you're welcome to stay up if you would like. Great. So we have two cases, and we are going to try to emphasize a few of the points that Dr. Lacy made a little bit earlier with a few of the abstracts. Okay, the first is on esophageal cancer. So this is a 74-year-old who presented with a 3-month history of dysphagia to solids associated with regurgitation and a 30-pound intentional, he said, weight loss over 8 months. He had a history of melanoma of the shoulder, a status post-resection that was T3B sentinel lymph node negative 4 years prior, other medical conditions as listed. And with medications listed here. He was married, was just getting ready to move out of the state. His wife also had a recent history of a cancer diagnosis, no alcohol or tobacco, had a golden retriever and no children. So what is the recommended workup? And I'm going to let Dr. Baum help us think about that.
Thanks, Pam. So obviously for esophageal cancer, we'll need a biopsy. To complete staging, we'll need the EGD with EUS. I think what's become complicated, or maybe less complicated, but intellectually complicated to think through, is the nodal staging. So are you looking for regional versus distant nodes? Until 2010, a lot of it had to do with where the primary tumor was versus the regional tumor. But since then, we've been staging regardless of the regional site. As long as there's 1 to 2 nodes, it's N1, 3 to 6 is N2, and 7+ it's N3. So you're really thinking of nodal staging from TNM by that valuation, but complicating that with how you're considering the radiation field and the surgical field, and then also supraclavicular nodes, for example, would still be distant. So in order to try to make sure you avoid an unnecessary major surgery, we are getting PET CTs in all of our esophageal cancer patients, which is upstaging about somewhere between 5 to 10 to 20% of patients. And I at least am referring many or all of patients with T3 or T4 esophageal gastrojunction disease to Dr. Kunz's team for staging labs. So there's a few things up there as well, and I just want to highlight the multidisciplinary tumor board evaluation, keeping in mind that it is a complicated decision now, balancing whether you're starting with chemotherapy, chemoradiotherapy, and whether the patient is considering organ preservation, sort of non-surgical option, or is definitively going to surgery.
Great, thank you, Laura. So this patient went on to have this diagnostic workup. So his labs were normal. He had an EGD that showed a mass noted at the lower third of the esophagus between 37 to 40 centimeters that was partially obstructing. The biopsy showed a moderately differentiated adenocarcinoma that was HER2 3+. Of note, this was a couple of years ago, and so we did not have some of the standard immunohistochemical or genetic markers that we normally do. This is a very busy slide, but I am going to turn to Dr. Kortmansky just to have us comment a little bit on how our molecular testing for GI pathology has evolved. And this is, I will say, major credit to Drs. Gibson and Zuchen Zhang as a partnership with PATH.
So I think one of the things that's been clear over the last several years is that although cytotoxic chemotherapy still remains the backbone of what we do, that there are a lot of molecular targets that have been demonstrated to be beneficial across the disease spectrum. And so for patients with upper GI malignancies, we think about microsatellite instability. In fact, we think about microsatellite instability in all patients with GI malignancies, and this should be a test that is done de facto for a new diagnosis. But in upper GI malignancies, we also think about HER2 expression. We think about PD-L1 expression. And recently, we've been thinking about Claudin expression as well, which is a new target seen in GE junction and gastric cancers. There's not yet an approved therapy for that particular target, although there is promising data with a new antibody treatment in combination with chemotherapy. And so we expect that approval at some point. We've been saying that for like 6 months now, but it's coming. It's coming.
Great.
But then, HER2 is also relevant in biliary tract cancers. It's relevant in colorectal cancers. And so we, as this slide outlines, we have a lot of testing that we do de facto, but we really do encourage molecular profiling for all patients with new GI malignancies.
Great, thanks, Jeremy. So moving on with this case, so an FDG PET-CT showed an avid irregular circumferential thickening involving the lower esophagus and likely GE junction. There was no metastatic disease. On endoscopic ultrasound, the patient was staged as a clinical T2, though per Dr. Baffa, if the patient has dysphagia, it's T3. And so how do we think about treatment? So I'd like to, I'm going to turn to Drs. Du and Dr. Lacy, and the context is that we actually had a robust debate in one of our seminars on the ESOPEC trial. I'm going to let Dr. Du start since Jill had a little bit of time already. How do you think about this in terms of radiation, chemotherapy, and what our options are? And I'm going to put back up this table that helps us think about this.
Sure. So I'll say
Yeah.
Okay. I'll say that I'm kind of a follow-up back to Dr. Lacy's incredible discussion already about ESOPEC. And, this is a GE junction cancer. The issue with GE junction cancers is that they've been folded into many esophageal cancer trials as well as gastric cancer trials. And clearly, as the Top Gear trial disappointingly for me demonstrates, is that there really is a limited role of radiation for gastric cancer in the modern era for resectable cancers. But for esophageal cancers, I think the role of radiation still remains very relevant, and the benefit of radiation is still the same as it always was, which is that of improved local control, improved downstaging, and the very promising possibility and ever increasing rates of pathologic complete response rates with chemoradiation. It is still reasonable in this case, despite the ESOPEC trial, given the concerns with the unbalanced chemotherapy given in the arms, to consider chemoradiation. As you said, Pam, this patient was treated a few years ago, and I think at that time, even when you were treating this, there was an awareness that the low-dose carbotaxol chemotherapy given with the cross-arm, the chemoradiation arm of the ESOPEC trial, was not the right chemotherapy to give with radiation, and we can talk about that.
Anything else to add, Jill? Can you comment maybe briefly on the CALGB 80803? Jill, if you want to do that.
Yeah, so so I think I share the bias and view that we just heard from Kevin. I think we know that cross does not offer effective systemic therapy, and patients are largely recurring with metastatic disease. I think what CALGB showed us is that when we include more effective systemic therapy, so that was FOLFOX, 3 cycles of induction FOLFOX, and then 3 cycles of FOLFOX with chemotherapy. So 6 cycles, which is actually more than what patients are often getting with perioperative chemotherapy because we can't give the chemo after surgery. Those results were very impressive with overall survival rates that rival anything that we've seen. And the advantage of that in terms of starting with induction FOLFOX is that often pretty rapidly alleviates dysphagia and makes tolerability of the chemoradiation therapy better. I think impressive pathologic complete response rates, which is extremely important given that many, many patients are really seeking organ preservation now, learning about the long-term morbidity of an esophagectomy. And so this is a shift that we have gone through in rectal cancer, and I think now we're seeing in esophagus.
Yep, great, thank you. So this patient went on to receive multimodality treatment as per the CALGB trial. Again, this was pre-ESOPEC data. So received FOLFOX and then concurrent FOLFOX with radiation therapy. I'll just put in a plug that DPD testing was done prior to the start of 5FU, which was negative. We can certainly address questions on that, but that has become part of standard of care for fluoropyrimidine-based treatments. Kevin, for sake of time, I may not go through. Do you want to give a couple comments briefly on your pretty pictures?
Since you invite me, I'll just comment very briefly. This is an example of our radiation plans showing really very conformal distribution, sparing nicely the heart, lungs, and spinal cord. And I'll note again, kind of this awareness even a few years ago, using FOLFOX-based chemoradiation is really the appropriate treatment in this case.
Great. So a post-treatment PET-CT showed a significant interval decrease in the hypermetabolic distal esophageal mass. The patient underwent a minimally invasive distal esophagectomy with no complications and had a path complete response. So I'm hoping maybe Dr. Khan can comment a little bit on any surgical considerations you might think about, special surgical approaches or techniques. And then I'll plant the seed for Dr. Kortmansky to comment on, would you give adjuvant treatment in this setting? If no, and then maybe explain your rationale.
Yeah, thanks, Pam. Thanks, Pam. Yeah, so for patients with GE junction tumors, there are multiple surgical approaches. The ones we use at Yale are led by Dan Baffa, and he does a minimally invasive esophagectomy where there's the transthoracic component and an intra-abdominal component as well too. Other approaches can be a transabdominal and cervical approach. Transhiatal esophagectomy is an approach that sometimes is used as well too. So there are multiple surgical approaches towards this, but at Yale, we use a minimally invasive approach through the chest and through the abdomen.
Great, thank you.
So the first thing I would say is that patients that have a pathologic complete response are an excellent prognostic group. So your post-treatment staging is relevant for prognosis. And so median recurrence-free survivals for these patients can be measured as high as 4 to 5 years. So significantly better than patients who have any evidence of residual disease at the time of their surgery. And so that plays into the role of adjuvant immunotherapy, which was addressed in the Checkmate 577 study, which was really only open to patients who had residual disease at the time of their surgery. It did show an improvement in recurrence-free survival, about doubled that timing. And so we have no data to support the use of immunotherapy in this population, in the pathologic complete response patients. And so I would not offer any additional treatment at this time.
Great, thank you. Oh yes, reminder. So Dr. Raghav Sundar joins us next week. He will be helping to lead a new gastroesophageal cancer program here. So next year we'll invite him back to talk some about that. I'm not going to go into the details of this, but this is just a reminder to me that we all need to be thinking about social drivers of health and health disparities as we care for all of our patients. Esophageal cancer is a male, white, predominant cancer, and we are seeing more and more patients, certainly in the state of Connecticut, who are Asian, and it's also an Asian predominant cancer, especially gastric cancer. So I'll move on just to the next case for sake of time. Okay, so we are going to talk a little bit about metastatic colorectal cancer, liver dominant, and we'll try to be speedy. We'll do this in 5 minutes. So this is a 49-year-old with a history of polyps and normal colonoscopy who presented with rectal bleeding. The patient has a history of depression and anxiety in addition to some other medical issues listed here. The patient has no history of alcohol use or remote history of tobacco, smokes marijuana daily, and recently relocated from out of state. The patient's husband is disabled and she serves as the primary caregiver. So let's start with the initial workup here. And I'm going to turn to my notes. Bear with me for 1 second. So you guys can remind me since I can't find my notes. I think, who did we decide was going to talk about this one in terms of the initial workup? I'll move to this. Dr. Kortmansky, I think I'll ask you.
So I mean, I have all the answers on the board, but but the most important thing is getting the colonoscopy and biopsy, which confirms the diagnosis, but also tells us the side of the tumor. So left-sided tumors, which is from the rectum up into the splenic flexure, versus right-sided tumors, which include the cecum, ascending colon, and transverse colon, is all relevant in terms of our treatment decisions. As I had mentioned earlier, we prefer molecular testing on all patients, specifically microsatellite instability, and most importantly for metastatic patients, testing for KRAS and BRAF mutations, staging studies with a chest CT of the abdomen and pelvis, If there is liver metastases, consideration of an MRI for better clarification is important. And then pelvic MRIs for patients with rectal disease. Always multidisciplinary tumor board evaluation. I think it is very important to ask the question in somebody with metastatic disease, is there a role for surgical therapy of their metastatic disease or other local therapy? And it's important to ask that question early. They may not be relevant at the time, but at least you know what we're working towards. And there's a lot of patients that wind up getting a lot of chemotherapy before a referral for some sort of local therapy.
Great, thank you. I'm going to pass to Dr. Baum just to briefly comment on this patient certainly had some interesting and challenging social drivers of health in addition to mental health challenges and is under the age of 50. This is an area of expertise for Laura. So how do you think about this when you have a patient in front of you?
So I think when you're looking at a young person, and this is also my patient, who's came here to be with her daughter, who's an undergrad at Yale. So she's an older, early onset patient, but I still think you're thinking, what are there family or fertility issues? Are there pragmatic issues? And are there medical issues related to the age? So I think for all early onset patients, you do want to make sure you've considered, genetic and familial testing. You want to consider fertility issues, and then you want to consider pragmatic issues. Obviously, younger patients have childcare issues. They're more likely to be underinsured or uninsured, and they're more likely to have a school or career disruption. I also think that in younger patients, and particularly in people with a history of prior mental health diagnoses or prior traumatic exposures, the cancer diagnosis can be perceived as traumatic. And so the way we approach that from the beginning makes a real difference in their experience. When we experience trauma, our executive function decompensates, and we lose sort of order and processing in our thoughts. And so helping the patient to identify those traumatic symptoms versus their, cancer-related symptoms can help them think more clearly, have better long-term outcomes, improve their sense of order and their self-observing capacity, and I think essentially help them feel supported and that they're not alone, and that we're going to take good care of them. So just to plug, we do have an early onset team here now. And then for all patients, regardless of age, we have a psycho-oncology consult service and a pretty comprehensive social work service.
Great. So the laboratory workup, CBC, CMP were normal, CEA was elevated, a colonoscopy showed a mass at 10 centimeters, and PATH showed moderately differentiated adenocarcinoma, microsatellite stable, HER2 negative, KRAS G12D mutant. For sake of time, I'm going to get into the management, so we're not going to focus extensively on the imaging. So maybe I'll just move to the next slide. So this patient went on to receive FOLFOX and bevacizumab for 9 cycles at an outside hospital. She moved to Connecticut, transferred her care to Smilo, reports increasing neuropathy, some additional symptoms, and an interval CT showed stable disease in the liver and colon primary. She's presented to tumor board, which we have here essentially. Jill presented interesting data on liver transplant and on thermal ablation. And maybe what we can do just in the limited time that we have is maybe Drs. Khan and Du can talk about some of these additional liver-directed therapies, including hepatic artery infusion, radiation, and perhaps thermal ablation.
Great, Pam. So, for patients with colorectal cancer liver metastases, the staging workup was great and nicely presented. And for this patient in particular, the patient presented with bilobar hepatic metastases. Patients with bilobar hepatic metastases are not necessarily unresectable patients. They can be treated with potentially curative liver resections with an ablation as well, too, can also be incorporated into that in the armamentarium as well. I do think it's important to note that even though patients may present with unresectable hepatic metastases, they do be seen by a surgical oncologist because there are patients who who initially present with unresectable liver metastases who may be resectable down the road, and resection of the primary and the metastatic tumor may provide cure. We have a hepatic arterial infusion pump program right now that we have at Yale, and which is going quite well. We've operated on several patients with unresectable colorectal cancer liver metastases in unresectable intrahepatic cholangiocarcinoma, and we are seeing good results, and potentially patients that may become resectable, or at least their liver disease is controlled also at this time point. So there are different ways to treat this, and I think it's important from a multidisciplinary approach to actually have the patient seen by a surgical oncologist early on if possible, because sometimes too much chemotherapy may render someone unresectable down the road, and I think that would be one of the goals down the road. To you, Kevin.
So the role of radiation for this metastatic rectal cancer patient is debatable. However, I would say in general for rectal cancers and colorectal cancers, we do, as Dr. Khan was just discussing, consider that metastatic colorectal cancers are potentially curable. With more limited disease, I would say that the role of radiation is really in terms of local control in the pelvis, and then also the role of the question of whether SBRT may help in terms of clearing the liver. For this patient, there's certainly enough bulky presacral lymphadenopathy. I would think that local recurrence, even after an excellent rectal surgery, would still be a concern. If you are going for cure, to consider adding in pelvic radiation for this patient. The different modalities for liver directed therapy are numerous and poorly defined as to which ones may best benefit the patient. I'll just point out that Dr. Lacy brought up the collision trial for colorectal cancers, looking at surgery versus ablation for small tumors. And the collision group following up on this is also enrolling currently on the collision XL trial, the supersized version of collision, looking at ablation versus SBRT in a randomized fashion, which is really I'm looking forward to as a radiation oncologist.
Great. I think we're going to, do you want to make one? Yeah,
I just want to
Jeremy
make
gets
one,
the last word.
I want to, I actually just want to make one quick comment about, the choice of upfront chemotherapy for this patient. So she is a young patient with a left-sided tumor, and we have two studies that have demonstrated that in combination with bevacizumab triplet therapy, so FOLFOXIRI as opposed to FOLFOX or FOLFIRI, do show demonstrations in improvement in survival, as well as improvements in conversion to resection. So I do think we should be thinking about which patients are candidates for triplet therapy at the time of their diagnosis.
Great. Well, we will end there. I want to thank the panel for their comments and really appreciate that. I think we have about a 10-minute break. So thanks, everybody.
Now I know how Rodney Dangerfield felt. Come on. Okay, so this year we had a very new format. I'm very honored. I should have said at the beginning to be working with co-directors Scott Huntington, Pam Kunz, Kiran Taraga. But now co-director Sue Evans here is going to introduce a very special lecture, because one of the things that's special about Yale and Smilo is our new technology, the innovative techniques we have. And who better to do it than one of our top radiation oncologists? So Sue.
Thank you for that, Roy. Thank you, everyone, for settling back down so lovely. So we are going to start off with two presentations, one from Dr. Udi Mendel about the spine oncology program at Yale, and then that will be followed by Dr. Henry Park. Dr. Park is with radiation oncology, and Dr. Mendel is with neurosurgery. So please give them your attention and applause.
Hey, good morning, everybody. So I was asked to give a talk about the spine program at Yale, and specifically some of the stuff that's unique to Smilo that we are doing here. So as you all know, I we all work very close with all of you. It's all about a multidisciplinary approach where we deal with every patient very much in an individualist way. And ultimately, over the last 3 years, we developed specific pathways within Smilo to make treatment better for our patients. So we develop ERAS pathways for appropriate and urgent need for quick biopsies and pathology on patients who come in with no cancer diagnosis, but very high suspicion for cancer. We develop pathways for a spinal cord compression protocol. So patients coming into the emergency room and they may have severe cord compression and rapid succession of workup needs to be done. So we now have an ERAS pathway for that. That leads to emergent, urgent, or routine MRIs or urgent, emergent, routine CT myelograms or biopsies. All of those things have been significantly improved over the last few years. Now, why are we doing it? It's because spine tumors is not, unlike here, you get the specific talk about specific cancer. We're dealing with cancer, all cancers. So spine tumors involve all cancer types. They can be aggressive and debilitating, causing significant pain. Some of these patients develop rapid development of neurological problems. As you all know, patient can progress to paraparesis, paralysis, bowel bladder problems, and increased risk ultimately with all the other things that goes along with these type of patient populations. What are the patients that we're talking about? Well, it's mostly the metastatic cancers that a lot of you are dealing with, but we also have to deal with a lot of primary bone tumors. The chondrosarcomas, the sarcomas are another separate patient population. And then we have the intradural, extradural tumors, whether it's a leptomeningeal disease, where we're relying on oncology colleagues, or whether it's more of the benign patient populations. And so you can see when it comes to these spine tumors, they can be intradural, intramedullary, extradural, in the bones, all of those things. And each one of these patients really require a specific plan for these particular patients. The majority of the patients we deal with are the metastatic tumors. So about 1.2 million new cancer cases diagnosed in the US, about more than 500,000 deaths a year. It's a major cause of death due to complication due to metastatic disease. And the skeletal system is the third most common site of metastases after lung and liver. The spine itself is the most common site of metastatic disease. And as many as 90% of patients with cancer will have spinal metastases at time of autopsy. So it's a huge patient population. And out of those, we don't see all of them, but up to 30% of these patients have some symptoms leading to us getting involved with this patient, whether it's pain or whether it's some neurological issues. The primary tumors are the ones I just mentioned. That's, again, a smaller group. It's 15 to 20% of the patients we deal with. You guys all know about these, require completely separate different planning. Now, why are these patients feel difficult from our point of view? Well, you guys don't know all of this stuff. They are mostly elderly. They are immune deficient. They are on steroids. They have rapid weight loss. They are already got some chemo, radiation, steroids. So healing issues for these wounds are critical. A lot of them are coagulopathic. A lot of them have wound issues, whether it's infection, whether it's wound breakdown. A lot of times we don't know what we're dealing with. So establishing a diagnosis, operating on the right patient with the appropriate surgical plan are all difficult. Patients, unlike most spine patients who get the routine degenerative work, in the degenerative ward, we like fusion, we like bone growth, we like healing. These patients rarely fuse, and so it leads to high rate of failure. And then timing of surgery, when is the right time to do something? So I'm going to just skip through it just for the sake of time. But again, a lot, immunocompromised, decreased white count. We see more and more patients who get cement injections. The multiple myeloma patients get a lot of those cement injections for fractures. They get infected sometimes. Cement loves infection. It's very porous, very difficult to eradicate those infections from the cement. Steroids, lots of side effects related to these steroids. Coagulopathic, a lot of these patients, we want to do surgery, we can't do surgery, or white count is high or low, The platelet count is very low. So they are at higher risk for DVTs. And then beyond all that, when we're planning on doing surgery, a lot of these tumors are very vascular. And so when you go in and you start removing this tumor, count on significant blood loss. And the renal cells, the liver cells, the thyroid cell, the pheochromocytoma, all of these tumors, and including the primary tumors, we anticipate liters of blood loss during these type of surgeries. And then, when we do these embolization, there's always issues that are more specific for surgery. But if you guys remember from medical school, there's always issue with artery of Adamkowitz. Artery of Adamkowitz is a blood vessel that feeds the spinal cord. And as they do these angiograms and they're doing this embolization to cut on the blood loss, we get some information that sometimes we don't want to know. And that's specifically about this artery of Adamkowitz that feeds the spinal cord. That's what we want to see. This is a patient with a renal cancer, vertebral body. That's what it looks like before they embolize it. The whole vertebral body is one gigantic blood vessel conglomerate. And so we need that preoperative planning, preoperative embolization to cut down on the blood loss. And now we have a huge team at Smilo that actually available 24/7 to give us this particular image and then make it look like this. So after the embolization, they can go in, they can put coils, glue, whatever it is, in order for us to be able to attack these vertebral bodies and cut on the blood loss during the surgery. Wound issues is always a big deal, as I mentioned. So collaboration with the plastic surgeons is very critical on a lot of these cases that we do. So we have a close collaboration with our plastic service, and now they have a team that's actually available for wound closures in patients with cancer. Ultimately, when it comes to primary versus metastatic, different goals, different adjuvant therapy, different surgical technique. With goal for primary is to cure the patients of cancer. So a lot of the cases that we do with the primary tumor, massive surgeries, but the idea is to cure them of the cancer. If we can get clean margins around these, we can cure that patients of a cancer. Versus metastatic, a lot of these are palliation. Adjuvant therapy for primary very limited, metastatic available, and the surgical technique is very different. The big issue with spine tumors is what I talk to my fellows, colleagues, residents, fellow, is that sometimes you find yourself doing the wrong operation on the wrong patient by the wrong surgeon. And many times what happens is you get the emergency room spine person on call, and they apply degenerative trauma principles for patients who have spine cancer, and those things just many times don't go together. So let me a couple of cases here. This is a 23-year-old lady. She fell in the office, in a chair, no cancer diagnosis, start having back pain, and neurologically moving everything, just having back pain. This is what the MRI looks like when she comes to the emergency room complaining of nuanced back pain after she fell. You can see the spinal cord is squashed. Something is going on. We have no cancer diagnosis, but the patient's moving her legs, just a lot of pain. Why is it hurt? Because the vertebra is broken and because there is significant compression on the dura. The dura is very painful. When something compresses the dura, there's a lot of pain related to it. Well, what is it? Don't know. She's in the emergency room. The consult for the spine surgeon on call. The spine surgeon comes in, examines, the patient is moving everything. I don't like the fact that the spinal cord is severely compromised. I'm worried about it. Here is the CT scan. And the surgeon takes the patient to surgery and does a decompression, laminectomy. Right? That's what it looks like after the surgery. The back of the spine has been removed. That's what it looks like after the surgery. And you can see the MRI on the left. About 10% of the tumor has been removed. The cord looks better, happier, but all this stuff around the vertebral body is still there. The biopsy intraoperative specimen comes back as lymphoma on this patient. This patient cannot get radiation, cannot get a lot of the adjuvant therapy that you guys want to do on her, and that's delayed the treatment options for her. The wound got infected 2 weeks after the surgery, could not get any radiation, any treatment. The patient died in 3 months after the surgery. I'm going to skip that because that's more specific. There is another case right here. This is a patient who come into the emergency room complaining of back pain, bowel bladder incontinence over 24 hours, and foot drop. And the MRI shows a sacral lesion. The sacrum has a lot of tumor there. The canal is completely full of tumor. The S1 nerve roots are completely displaced to the side. No diagnosis, but neurological deficits, Baum bladder incontinence, back pain, foot drop. What is it? Take the patient to surgery, not take the patient to surgery, neurosurgery, spine surgery, that's called. And they do a laminectomy, they decompress the nerve roots. The patient's doing great for 6 months. Baum bladder recovered, foot weakness recovered, and the pain has gotten better. And this patient presents 6 months later from that hospital to our hospital, and he says, hey, Dr. Mendel, I think one of the screws that he put in there is poking up through my back, and he points to this. That's what his back looks like. You can see the incision in the back, and he points this. He said, I think that's a screw. One of those screws are coming out, getting loose. That's what the MRI looks like, and you can see what it looks like now. This was a chondrosarcoma that had an intralesional resection, and within 6 months, this tumor is now filling up the whole canal. And the, quote, screw that's loose is actually that bump. It's a tumor recurrence through the path of the surgery. This patient should have had a completely different surgery, considering an unblocked resection with clean margins and not going in there and decompress the nerve roots, which gives temporary relief for about 6 months, and that's it. This is a patient who potentially had a chance for a cure. This patient now has a death certificate on his name because this patient is going to ultimately die from this. So the decision-making of making the right choice is super critical. This is the patient. Not only that, he also had a broken rods from the surgery that was done at this other hospital. There's no fusion. Some of the pain is coming from the tumor growth. Some of the pain is coming from the rod broken. I took him to surgery. We did an unblocked resection for that little bump that was sticking out of his back. And you can see the plastic surgeons then had to put it all together for us to remove this specimen. Here is a woman with breast cancer presenting to her oncologist with fractures of 2 vertebrae in the back. And so there's mechanical instability for this spine, significant. She's presenting with significant amount of neck pain. C7, T1 are broken. They are a little bit broken, not severely, but they are broken. They are pushing a little bit on the spinal cord. This patient, instead of referred or being presented or discussed surgical options here, ended up getting radiation, and that's what it looks like a month after the radiation. You can see, and I don't want to blame my radiation oncologist, but you can see that what happened, right? The 2 vertebrae are not able to hold this, right? It completely collapsed. The tumor shrunk down, but the vertebrae collapsed. Now the spine is falling over, and there's severe spinal cord compression. This patient should not have had radiation, should have had mechanical restoration of mechanical stability, and then follow with radiation down the road. Look at the CT scan. There's no anterior column support. The patient is in agonizing neck pain, walking to the office holding a neck like this, cannot move. So we ended up doing this surgery. You can see on the right side, a lot of reconstruction with front-back surgery, and that's what it looks like at the end when the front and the back has been reconstructed. Again, was it the right choice? That's where every patient has a specific need for a multidisciplinary input from all services. This is a patient with melanoma, pathologic fracture of the vertebrae. There is severe cord compression, patient presenting with back pain, seen at an outside facility. And how did they treat the back pain? Well, a CAT scan shows that the bone is eaten away, the back wall is missing, and this patient underwent vertebroplasty. Why? To help with the back pain because the patient has a pathologic fracture. You can see the cement here. Okay, here is an X-ray, and look at the bottom picture. Where else is the cement? It's not just in the vertebrae. It's in the spinal canal. The cement leaked through the back of the wall into the spinal canal, compressing the spinal cord. So there are a multitude of issues here, right? And that's, you can see right here on the CAT scan, the cement that leaked through the back into the spinal canal. And the patient is doing fine. The back pain got better, no neurological deficits likely because there's not a lot of cement in the canal. But that was not the right choice for this patient to get through cement injection to help with the back pain. Did the back pain get better? Yes, for about 3 weeks, only for it to break further and ultimately require an anterior transthoracic approach. and fixing all this. So I always say, we tend to think like spine surgeons, and we should think like spine surgeons on a lot of the trauma injuries, a lot of the infection issues. But when you're dealing with cancer, you got to think as a cancer person first, then think about it as a spine surgeon. It should be reversed. And it's very hard for spine surgeons to think like that. We are very focused on neurological deficits. We are very focused on fixing it. And the fix may be a short fix, but not a long-term fix. So at Smilo, we develop a huge multidisciplinary team where we have a high level of collaboration, not amongst just medical oncology, radiation oncology, and Dr. Park is going to talk about it, but also about, collaboration with our colleagues in surgery. This is a lady with thyroid cancer. You can see the vertebrae is broken in the front. She has a C6 or C5 fracture. The cord is severely compromised there with cord compression. Here's the CAT scan. And, I was involved with developing this thing called the spine instability neoplastic scale. A lot of you guys calling and you say, hey, is that spine stable? Is it going to break more? Is it not going to break more? Can we leave it like that? We start the chemo? Can we do the radiation? So we developed this thing called spine instability neoplastic scale. It meant for you, not for me. For many of the medical oncologists, a lot of the radiation oncologists will call and say, hey, we're getting ready to radiate. Is this spine stable? We have a scale. We had the points. There are a lot of surgeons, radiation oncologists, and medical oncologists. We all got together and we developed it over a 2-year course, and we developed this thing. And if you add your points, then you can figure out whether the spine is stable, 0 to 6 points, potentially unstable or unstable. This patient, if you add the points, were unstable, had an angiogram, Christmas tree lighting, very vascular tumor. And you can see the plan. So we're now developing very nice reconstruction vertebrae for a lot of these patients to make it patient-specific. We used to put a piece of bone in there, a piece of fibula, iliac crest. We don't do this anymore. ENT gets us the exposure. This is during surgery. This is what it looks like after the surgery. The whole vertebra is removed, and we're able to restore mechanical stability. This patient doesn't need to wear a collar, and she can move on with everything else. You can see the vertebra has been removed. The spine has been all reconstructed. And then we follow with radiosurgery, and we're going to talk about it very quickly. I'm going to be done in 5 minutes. Is that okay?
Yeah, we'll just take it out of lunch. No
All right,
problem.
sounds
We'll be
good.
good.
So we're going to talk about the radiosurgery here. I want to talk about this case. This is a case against Mosmilo. This is a 34-year-old with a giant cell tumor that destroyed the whole pelvis. There's nothing left of the pelvis here. And that's been growing for many, many, many years. It's not to the point that the whole pelvis is one gigantic tumor. What do you do for that? Right? I mean, it used to be, that's it, that's the end of the world. But this is a giant cell tumor. It's nowhere else other than here, right? It's not metastasized yet. But is there any surgical options for this type of patients? Well, look at this, right? It's coming, it's just filling up the whole pelvis. How do you fix something like that? Not only that, why is she at Smilo? Pain, severe amount of pain. This patient is unable to get out of bed, already paralyzed, or kind of moving her legs barely, just the feet. Look at the amount of pain medications, including 1,600 micrograms of ketamine infusion at 30 milligrams an hour. Nothing could help with the pain management for this patient other than this. And the idea, what are you going to do here? And we brought the option of doing something that sounds nutty, and hemicorporectomy. Have you guys ever managed these type of patients? This is the kind of cases where you literally cut the body in half. And is it being done? Yes. I mean, there are many studies out there that show that this can be done. I was involved in one of these cases. A lot of surgeons are involved with these when it comes to need for ligation of the aorta and the vena cava and so on and so forth. The idea was about pain management for this patient. Is there any other option? The pain gets better after this type of crazy surgeries, and a lot of plastics involved. This is the case that I was involved with. This is the picture from the operating room. And you can see how many surgeons are involved. The list is on the left. These are massive tour de force type surgeries. I'm taking it to the extreme here, but that's the type of situation that a multidisciplinary component is very critical. And ultimately, that's what it looks like. This is a picture from this case. When these cases are over, the plastic guys then needs to kind of put it together. What did we ended up doing? This patient was not a candidate for this type of surgery, and we can't do it at Smilo. So I'm just showing that these are options that are available. And, you know, we now offered, there was no other option when it comes to the pain control. We offered this thing called singulotomy, where our functional neurosurgery colleagues were able to do a singulotomy. And what is singulotomy? In essence, is a procedure where you do a lesion in the brain and the patient's pain perception goes away. So these are known options for this type of patients. We ended up doing a singulotomy on this patient. This case was presented in multiple tumor boards. And after multitude discussion with all the teams involved, we have elected to do this. And you can see how we choose the spots in the brain to go ahead and do these lesions. And you can see following this, the patient within 2 weeks was discharged on fentanyl 300 microgram patch to the skin with no pain perception. So in that sense, I'm going to stop. I can show you many other treatment options that we are having available, but ultimately, for the sake of time, we're going to talk about our radiosurgery program that we have developed at Smilo. We can't do spine surgery without having a very robust radiation oncology treatment, especially with a stereotactic radiosurgery program. We do have, for sake of publicity, we do have a spine tumor board that Jen have helped us establish. I can't see Jen here, but she's helped us create. And so anybody who wants to have patients, want to discuss it, we have a weekly spine tumor board that all of the team gets together. Each medical oncologist, radiation oncologist could get a Zoom link, present the case, and then in a multidisciplinary fashion, we can discuss those type of cases. So with that sense, I'm going to let Park keep going with this.
Thank you so much, Dr. Mendel. That was fantastic. We'll welcome Dr. Park. And Dr. Park, our job in radiation oncology is to take care of residual disease. I'd like you to take care of some lost minutes, please.
Is it this one? You downloaded it already. Are you that one? Park. Yeah, that one. There we go. Good. All right, thanks very much for the invitation today. It was really a great segue to talk about the new tools we have in radiation therapy as well. I'm going to talk about two things, mostly focus on the first one that we have already, and then the second one we're hoping to get soon in 2026, proton therapy. But I'll first focus on the PET-guided radiotherapy. My disclosures. So external beam radiation is really typically given by, it's usually given by from a LINAC or linear accelerator, produces high energy X-rays to treat cancer. So for each patient, we typically customize the delivery of radiation using IMRT or SBRT, which you've, I'm sure, heard of before. This is guided by daily imaging before each treatment. However, some tumors do move as the patients breathe, especially in the lung and the GI tract. So the next one is a new machine we have that we installed last year. It's a novel radiation technology that has the capability of using the tumor's own PET signal itself as a fiducial, meaning as a marker, to be able to track the radiation beams in real time. So normally we do what's called a 4D scan. We can track a lung tumor, for example, as you breathe, and we target the whole area where it goes in real time. But what we can do here, though, is as a tumor moves, the radiation will actually follow along the tumor, so we don't have to treat that whole area. So this is called biology-guided radiation, or BGRT, and it's now tracked as 6 therapy. So now the FDA has approved this for lung and bone only. So it's for both primary and secondary cancers. So this really links nicely with the METs that we just talked about in the bone, can be used there as well. Mostly we've been using it for lungs so far. It could be delivered with SBRT, so really anything that could be otherwise SBRT could be considered for this as well. You can also use this machine though to treat with IMRT and SBRT as we're doing right now. For most of the machine right now is being used for the most of the machine time right now is being used for that purpose. So the biological advantages of Syntex therapy. So let's say we have, this is a simplified view over all of this, but this is what we call GTV, or the gross disease, is a tumor. We add some margin to it called PTV. So what we do with SBRT, again, that GTV will move and then we'll put some margin around that. So to capture all of that becomes the actual target that we end up treating. Now with BGRT, we can track the PET signal in real time to decrease the size of the radiation field for where the high dose goes.
we can increase our confidence in fully hitting the target, because sometimes the tumors move, it's possible to have it move in different ways than it was at the simulation scan. So, and we're seeing that now that we're using this technology. It's actually pretty disconcerting sometimes to see that that what we think is happening is actually maybe not happening quite as precisely as we thought for how lung tumors move. And then the other thing is that we can decrease the risk of side effects potentially, although that hasn't yet been proven in clinical trials. So the installation happened here in April 2023. We installed the world's 5th machine of this type. We were the first on the East Coast. There are now 6 total overall. Now we installed the Synthex therapy part in December. So a little about, it looks like about 9 months ago now, soon after the FDA approval for lung and bone tumors. Here was the ribbon cutting, and we did our, which we did in January, and then the first treatment in March. So Synthex therapy, the main patient selection criteria, we look for a target that's about 2 to 5 centimeters. And you all don't have to worry about this too much. We'll figure this out when you send patients to us for SBRT. And basically, if you have lung or bone tumors that could be SBRT, just ask to see if this is something that the patient might be eligible for. The main thing you all have to know is that we do need a PET scan beforehand to see if the SUV is high enough. So just think of the number 6, SUV of 6 being the main cutoff there. So if it's hot enough, then they may be a candidate for this. So lung or bone tumor of any type with an SUV of 6. And then the signal has to be a little bit homogeneous as well throughout the target. So the basic procedure is similar to what we normally do. We do a CAT scan simulation, but the one extra thing we do is a PET modeling scan afterwards. So usually a couple of days later, we'll do a PET modeling where we inject the FDG, a little higher dose than you would use for a diagnostic PET scan, so 15 millicuries. And then at the PET modeling, we actually basically run a PET scan in our department of radiation oncology on the treatment machine itself in the treatment position, so that we can see exactly that the target is confirmed to be within the expected bounds, and we confirm that it passes basically the tests it needs to do in order to proceed with treatment planning. And then we can actually run it through the system, even based on a diagnostic PET beforehand, just to make sure that it's hot enough and big enough to treat. And then we do similar preparations for each fraction. So if we do 3 fractions of BGRT, we'll do the PET modeling, and then then we do the FDG injection, each of the fractions as well. So you might end up with 4 injections in total. So I'll just give a couple cases here. Case 1 is the first successful case we did was a left lung metastasis from endometrial adenocarcinoma, about 2.8 centimeters, somewhat close to the chest wall and somewhat close also to the tracheobronchial tree, which are 2 organs that we watch out for with SBRT. SUV was 9.5. So it passed the evaluation that we did on a diagnostic PET. It passed the modeling scan that we did on the patient. We ended up treating 60 gray in 5 fractions with the, here's the 60 gray line is right here where the target is, and then 40 gray and 20 gray. So there's a kind of a normal scatter that we expect. And then you can see here on the treatment machine, we're getting the PET signal that we're tracking as well. And here's, I'm not going to go through the full details of this, but basically this is meant to point out that we can see exactly what we're targeting now. We have the PET signal each day. We have that matched up to the PET signal we get at the modeling, and then we can actually see where the dose actually went afterwards, which is something that we model with normal radiation therapy, but can't actually tell for sure at the end exactly where the dose went. But here we do. We can see that. Now, this second case was also right lung metastasis. There's also, while we were working this patient up with a CT with contrast, we also found a left kidney lesion that was new compared to the PET scan the patient had 3 months prior. So after speaking to medical oncology at Dana-Farber, who sent the patient to us for this, then we ended up deciding to treat both. Now, we had just gotten an upgrade at that point of the software that let us treat both at the same time in the same plan. So we were actually the first in the world to ever do this. So this passed the PET evaluation, and we ended up treating 40 gray and 5 fractions to both, and we successfully completed the first of these hybrid Synthex and SBRT plans at once, which is remarkable mostly in the fact that not that we could treat 2 things, that's in and of itself not that interesting because we could have done that separately. But the main idea is if you have 2 or 3 or eventually 5 or 10 lesions in the lung, for example, and you're going to be treating all at once, that is something you can plan together. And then that's a future that we can imagine could be really exciting, that we can treat not only oligometastatic disease, but potentially polymetastatic disease in the future. But right now, we're not at that point yet. We only can do one site with the BGRT, but now we can combine it with SBRT to other sites as well in a single plan. So I'm not going to go through this much more. So the basic our vision for the future with Syntex at Yale, we're hoping to, and overall, we're trying to expand indications beyond lung and bone. We're going to try to treat multiple metastatic sites at some point eventually. This may be a year or 2 or 3 away from really happening in real time, but we're on the ground level working with the company, working with the other teams, the UC Southwestern, City of Hope, Stanford, as well as the fifth one's over at Pittsburgh. So we're working all together on this to study outcomes, but also to potentially expand indications, and also to study novel isotopes beyond FDG. That really could be very useful down the road. So research opportunities, we have a prospective registry for all of our patients who are getting this right now. We're looking at health-related quality of life as well as other endpoints that are the standard endpoints. Also, the potential for industry-sponsored grants. So we're really looking for collaborations around medical oncology, surgery, from nuclear medicine, PET center. We're very excited for this chance to work with all of you on that for all different disease sites eventually. And then just a quick sneak peek on Proton Center. This is opening in groundbreaking, should be within a month or so, happening in Wallingford. It's a combined effort between a joint venture between Hartford Healthcare and us. So we'll be someone in the middle in Wallingford. The basic idea here is that there's a little less low, there should be actually substantially less low dose scatter for certain patients who benefit from that. So that could be advantageous to some degree. It's not going to be for everybody, just like Syntex is not for everybody either. So we'll help you, to figure out who are the best patients for protons. And there's also the insurance issue as well, which is the insurance issue is a problem that we can deal with at some point. But otherwise, this is coming. 2 years, that's the idea right now. All right, so thank you very much. Just really excited to collaborate going forward, and thank you for everyone's support.
You, Dr. Park.
Groundbreaking happen, Henry. Need lots to go around. That could be under us for all we know. Okay, we're running late, so maybe we'll just skip lung cancer. I don't really care about that. Just kidding. No, so now we're gonna hear about lung cancer, and no better person to start us off is our leader of the center, co-leader with Justin Glassberg and Katie Paletti, Sarah Goldberg, and Sarah's gonna give us the hot topics. So Sarah.
Thank you so much. Hi, everyone. I think I might have the wrong slides here. I think this is the panel.
Okay, we need to swap out.
Yes, we just need hopefully you have my slides.
We'll not take this out of your time.
Oh, thanks. So can I say some things while you're working on that?
Yeah.
So it's so wonderful to be here. I was hoping I'd have an extra minute to say hello and welcome. This is such an amazing event. I think selfishly, mainly because I get to see everyone and so many people that I work with that I don't get to see in person all the time. Do you need me to stop talking to do this? You don't have it. Well, I'll just keep talking. I uploaded them like early. That's what happens when you do things early. It doesn't, oh. Can I give you my laptop?
Yeah.
Really? Okay. Hold that thought. Connect my laptop right there.
Yes.
So never to waste an empty microphone. So, lung cancer is one of 3 areas at Yale where we have a SPORE, a specialized program of research excellence, which really takes science from the lab to the clinic. We hope to have this in 3 or more by the next time, or in next time we meet. Lung cancer, melanoma, and head and neck. You'll hear from all of them today. And we'll have a couple of very nice cases. And now to Sarah.
I'm going back to my welcome. So anyway, what I was saying before is I really, it's so nice to see everyone. It's, we have our fellows here. I think they're in the back row. Lots of people from the lung team. It's awesome to see you all here. People from across the network, colleagues, industry partners. So really wonderful. Now I'm going to talk about lung cancer now that we have my slides. So I think probably most of you know that there's been a lot happening in the field of lung cancer research in the last several years, but this year was no exception. So I am going to try to summarize that in 15 minutes as best as I can. Here's what I'm going to try to cover. I'm going to focus on early stage and locally advanced non-small cell lung cancer, talk about neoadjuvant and perioperative immune therapy, also talk about how we can incorporate targeted therapies into our management. And then I'm going to focus on EGFR, ALK, and KRAS in the metastatic non-small cell lung cancer space. The initial version of this talk had like 60 slides, so that's not possible in 15 minutes. So this is what I had to omit. There's actually some interesting data this year on oligometastatic disease. I'm not going to cover that. I'm not going to talk about small cell. You'll hear a bit about that in the cases. I'm also not going to cover antibody drug conjugates, a really important area of development in lung cancer, but just ran out of time. So I'll give you a sneak peek at the end about another talk I'm going to be giving that you can hear more about those topics. But this is really what I'm going to try to address today. What is the role for perioperative chemoimmune therapy in stage 2 to 3 lung cancer? And what about those patients with multi-stage N2 disease, something that I think has really changed in the last few years? Should we give adjuvant therapy if we've already given neoadjuvant therapy? How do we use targeted therapy in the early stage, locally advanced setting, EGFR, ALK, and KRAS? So first about perioperative immune therapy. So these are the two trials that we have now several years of follow-up data on and are both approved regimens for the treatment of patients with stage 2 or 3 non-small cell lung cancer. So it's the KEYNOTE-671 and the AEGEAN trial. They're similarly designed studies, although of course there are differences. The KEYNOTE-671 is neoadjuvant and then also adjuvant immune therapy with pembrolizumab. The neoadjuvant portion has chemo with a cisplatin-based regimen. This is one of the nuanced differences in the trials. Cisplatin regimens only, and in addition to pembro, and with the AEGEAN trial, it was any platinum doublet with durvalumab versus placebo and chemotherapy. And so I think we all already know this because now this is a couple years old. This data is that both of these trials were positive for event-free survival, their primary endpoints. And you can see there with several years now of follow-up that the benefit persists into 3 years and beyond. So again, this was practice changing a couple years ago already and something that's made its way into our management of patients with lung cancer. We do have some data on overall survival. This is still somewhat immature analyses, but you can see here that both of these trials look like they are at least trending towards a benefit in terms of overall survival. Both of them are not statistically significant, at least not yet, but we'll keep our eye on that and see if that becomes significant in the future. We also saw data at ASCO on the CheckMate 77T trial. This is, again, a similarly designed perioperative trial, but this time including nivolumab. So patients get 4 cycles of chemo plus nivolumab and then surgery and then nivolumab for 13 cycles afterwards. This is the primary endpoint of event-free survival for this trial. And again, you can see a benefit here, not as much follow-up here as with those other trials because it's more recently presented, but still a benefit. So now we have 3 and actually more trials than that show a significant benefit of adding immune therapy in the neoadjuvant treatment of and adjuvant, the perioperative treatment of stage 2 and 3 lung cancer. This is what I really wanted to drill down on because I think this is something that we started to see this year even more that I think really has changed the way I think about selecting patients for perioperative therapy is looking at the stage 3 patients, the N2 positive patients. At least in our practice at Yale for years, we really were thinking patients with N2 disease, especially multi-stage N2 disease, should be more going the chemoradiation route as opposed to the resection route. But I think this data, as well as some other studies, have really started to show us that these patients can do very well when they get a perioperative approach. So you could see on the bottom left, stage 3 N2 single station, on the right, multi-station N2 disease. Patients are significantly benefiting from the addition of immune therapy to a perioperative approach. And actually the hazard ratio for the multi-stage N2 patients is 0.23. So really significant benefit with the addition of immune therapy for those patients. So to answer my question about early stage non-small cell lung cancer, I would say based on the superior event-free survival and these trends towards improved OS, I think this is now really our standard of care. Perioperative chemoimmune therapy, either chemo pembro, chemo durva, maybe at some point chemo nivo if that is approved. It really should be considered for patients with stage 2 to 3 disease, even if there's multi-station N2. So what's really critical here, and we try to do this every week in our tumor board is to have multidisciplinary discussions. These patients with especially stage 3 disease, but also stage 2, really need to be seeing surgeons, radiation oncologists, medical oncologists up front and having these kinds of discussions so that we could choose the best therapy. Perioperative chemoimmunotherapy is clearly an option for these patients, but is not the only one and should be at least considered and discussed. So one thing that I think I thought a really important study that came out just at World Lung just a couple weeks ago was trying to answer this question. If we give a patient neoadjuvant therapy, should we then give them adjuvant therapy after surgery? So we don't have prospective data yet. So I'm not showing you a prospective trial. Maybe one day we will have that. But for now, what we have is this analysis, again, presented at World Lung, which compared the data, the patient level data from Checkmate 816, which is a neoadjuvant only study, to Checkmate 77T, the trial I just showed you, which was perioperative. And they basically compared how those patients did. So asking the question, do you need the adjuvant component? So there were some flaws with this study, as there always will be when you're comparing two trials, lots of questions that were asked of the speaker at World Lung. But I think it still starts to get at this question of, is the adjuvant portion important in these patients? And what this study showed, again, with its flaws, showed that it may be actually important. So that what they found was that patients who were on the perioperative regimen of chemo-nivo, followed by nivo in the adjuvant setting, did better than if they got neoadjuvant alone. I think this is also really important. We often will say, well, what was the pathologic response? Should that guide our use of adjuvant therapy? Again, this is comparing across trials, so you have to really take that as part of the understanding of how to interpret this. But what they found was that both of these groups appeared to benefit with a hazard ratio 0.5 to 0.6. Although if you look at the curves, it maybe looks like in the non-path CR patients, those patients seem to benefit more. These are fairly small numbers, again, limitations of comparing across trials, but we're starting to see some benefit, especially in the non-path CR patients. So to answer this question, should we give adjuvant therapy after neoadjuvant therapy? This is something I'm sure we'll debate about for many more years in tumor board, but I would say probably we should. We don't have randomized data to guide us yet, but comparing across trials and starting to get at it with this study I showed you, it does seem like maybe there is a signal for benefit of giving the adjuvant component, especially in patients who don't have a path CR. So what about targeted therapy in early stage and locally advanced disease? So we've known this data for some time. ADAURA was the big splash last year at ASCO and several years before that as well. Roy showed us that very clearly in his plenary presentations. We know that giving adjuvant osimertinib is beneficial for patients after resection. And then we also saw this past year in a publication in the New England Journal that the ALINA trial was also positive. So adjuvant alectinib in ALK-positive lung cancer patients is also beneficial. What we saw at ASCO this year, and this was in the plenary, got a standing ovation, it was very exciting, was the LAURA trial. So this is giving patients consolidation osimertinib after they receive chemoradiation for stage 3 unresectable non-small cell lung cancer. So these are not the resectable patients. These are patients who are getting chemoradiation. They were randomized to osimertinib versus placebo after they finished their chemoradiation. And these are the results. It's probably why I got a standing ovation, an absolutely stunning improvement in progression-free survival. A couple of things to note about this study. Patients were given osimertinib indefinitely. It wasn't a designated amount of time. It wasn't 1, 2, 3 years. It was forever, as long as it was tolerable and they didn't progress. And so that is really a difference. And I have to say, when I heard about the design of the study, I was really surprised, but now seeing the results, I think it makes sense because you can see how poorly patients are doing when they don't receive osimertinib. Almost every single patient is progressing in a few years. And so again, there's limitations in this trial, like there is in any trial, but really patients with unresectable stage 3 EGFR mutant disease are not doing well with chemoradiation alone. And so indefinite osimertinib does seem to make sense in these patients after seeing results of this study. I won't go into details, but basically every subset seemed to benefit here. And then there's some overall survival data, although very immature and early, with maybe showing a trend towards improvement in overall survival, but we'll probably see more of that in the years to come. So is there a benefit from target therapy in early stage and locally advanced disease? Yes, clearly for EGFR and ALK. We now use osimertinib. We've been doing this for a few years now for early stage disease. Now we should absolutely be using it after chemoradiation. For unresectable disease, alectinib as well, we're using that now after surgery. We don't have data in the prospective data for using alectinib after chemoradiation, but I would argue maybe we should be considering it. What about other subsets like ROS1? Again, we're extrapolating, but I think we should be using it or at least thinking about it for those patients as well, where we have really active drugs. And so really what this comes down to is we have to test for these alterations or we'll never know that we have these options for patients. So we have to test for these molecular alterations, not just in stage 4 disease, but now in stage 2 and 3. And actually the 1Bs as well is really important. They were included on the trials too, in the adjuvant trials. So we need to get that information before we give all of our patients chemoimmune therapy in the adjuvant set. So it's really important to do this test before making decisions on it. Moving to advanced disease, and this will be fairly quick, and then we'll wrap it up. So what about for EGFR? A lot is happening in the EGFR space in the first-line setting. We've seen these 2 trials over the last maybe 2 years or so. This is really the contenders for the first-line EGFR space, which is a combination of amivantamab, the EGFR MET bispecific antibody, plus lazertinib, a third-generation TKI, and then the FLAURA2 regimen, which is chemo plus osimertinib. And these 2 regimens were compared in obviously different trials, Mariposa and FLAURA2 versus osimertinib, and both had significant improvements in progression-free survival versus our, to this day, at least standard drug osimertinib. So these are now both approved regimens. You can use these in the first-line setting for EGFR patients. Toxicity is absolutely a concern. I'm not putting this here to give you any details, but these are something that needs to be considered when you're thinking about regimens for patients. There's toxicity obviously associated with anything more than a TKI. Amivantamab has unique toxicities of kind of the similar EGFR toxicities, but can be quite severe in patients, rash, nail issues, diarrhea. So those are absolutely things to think about. And then chemo, I think we all know well, something to consider for patients. Do we want to bring them back and forth for IV infusions as opposed to an oral drug? So the other thing to think about with these combinations is that there really does seem to be a benefit in the CNS, which is interesting since we don't always think about chemo or an antibody getting into the brain as well. But these drugs really do seem to provide a benefit in terms of time to intracranial progression compared to osimertinib alone. At ASCO, there was an interesting study looking at high-risk features. So maybe we can select patients for these combinations based on some other features. And basically what they found is all of these high-risk features, there seems to be a benefit to giving the combination as opposed to osimertinib alone. So maybe we should use that to select patients. The challenge is almost 90% of patients had at least one high-risk feature. So you're basically then saying all patients should get combination, and I'm not sure that that's true. We do have some overall survival data. It's not mature yet. I feel like I've said that in multiple studies, but that's how things are right now. They both seem to be trending in the right direction, but not statistically significant at this point, but maybe one day will be. So how do we select the optimal EGFR strategy? Well, this is from a talk that was given last year at ESMO, but I think it highlights very well the challenges we have. We don't really know. There's a lot of different options in the first line now, and then second and third line where we can be thinking about different strategies for our patients. So how do we select in practice? I think chemo and osimertinib or amilaser really should be considered for really most of our patients if we think that patients can tolerate it, especially if they have high-risk features, which again is most of our patients, including brain mets. We should be considering a combination. Single agent OC is still an option, especially if patients are older or frail, low bulk disease. If people really don't want IV infusions or coming back and forth for treatments, absolutely still an option. For ALK, I'll very quickly go through this because I think this is a pretty straightforward summary, but I think it's really important in case you missed it. This was one of the most exciting studies I thought at ASCO this year. The CROWN study, lorlatinib versus crizotinib for first-line ALK. Again, an amazing progression-free survival curve. This is actually what I've been told. I haven't checked if this is true, but I've been told this is the best 5-year PFS for any metastatic lung cancer ever. So 60% of patients are progression-free at 5 years. Really incredible with lorlatinib. Amazing results for intracranial control as well. I won't go into details for the sake of time. Again, something to think about with lorlatinib when you're selecting first-line regimens, because alectinib is another very reasonable option, brigatinib as well, is toxicity. So there are adverse events that are pretty unique to lorlatinib, the cognitive side effects, weight gain. So these are some things to consider. But I think one really interesting thing that was shown at ASCO is that even in patients that needed dose reduction, they still did extremely well. And actually, maybe they seem to do better in terms of PFS and time to intracranial progression. So don't be afraid to dose reduce these patients. So very easy answer for me here. What's the best first-line treatment? It does seem to be lorlatinib. I've changed my practice based on this data, but you absolutely need to think about side effects discussed with patients. Some patients may not want to risk the side effects, but I think starting the drug and really having a low threshold to dose reduce is a good strategy. In KRAS, we saw that adagrasib does have improved progression-free survival compared to docetaxel in the second-line setting. We saw similar results with sotorasib a few years ago. These are both now approved drugs and can be used in the clinic. There are some new kids on the block that are coming. We have trials for both of these drugs in the clinic right now at Yale. Divarasib and olomorasib, they both look really promising. I'm not going to go into details, but they look like they have maybe higher response rates and durability than sotorasib or adagrasib, and really, really exciting to see them coming into clinic. So I didn't get a chance to talk about so many other really exciting things, all the new agents coming. There was some really interesting and promising drugs that we saw at ASCO and in World Lung and at ESMO. So I had to get it out there. So we're going to do this again. I'm going to do this again. We have a translational lung cancer conference once a month at noon at Yale. And so I'm going to give you some more updates, the things I didn't get a chance to talk about. We can go into detail and have more of a discussion then. So December 4th at noon, if you're interested and want to come, let me know. I could send you the link if you don't already have it. Thank you so much.
Yeah, please go. Okay, that was wonderful. We'll take some questions, but now we're going to have our panel. So joining the panel, we have Dr. Ann Sheng. Where's Ann Sheng? Hi, Ann. And does a lot of things, a lot of our collaborations and innovative medicine in the SWOG. Okay, Michael Grant. Michael Grant, all the way from Waterbury. Henry Park. We met Henry already. Henry, come on over. Andrew Danispan, is he here? He did an operation and he's already back. I hope they're not bleeding or anything. And then Yu Zhang is not here, so I'm going to ask Sarah to take her place. Yu Zhang from the VA, if there's a seat. Okay, so we're going to do a case discussion, and I have to keep us on time. Okay. There's certainly a lot of, and that was a slow year for lung cancer. Where's Eric? I tell him there's a lot more interesting work in lung cancer than breast cancer. Oh. Tell him I said that when he gets back. Okay, so now we have our lung cancer panel, and we'll go through the case. So we have a 65-year-old woman with a history of diabetes with 60 pack year smoking, present with a shortness of breath, chest pain, a cough, a chest X-ray with a large right upper lobe mass. So we can all see that on the PET scan. PET scan with an avid right upper lobe mass, mediastinal lymphadenopathy, right hilar and right supraclavicular lymph nodes. EBOS with mediastinal lymph node biopsy shows small cell lung cancer. And I'll let you all read that, and do you agree that's a good, that looks like small cell? Our pathologist says so, it's got to be true. Pleural fluid cytology is negative for malignancy, and the MRI brain is negative. So Anne, from what we've seen so far, is this a limited or extensive situation?
Well, this one is a limited stage situation, and it's going to highlight some of the major advances this year at ASCO.
Okay, so it looks pretty limited to me, but okay, good. So the patient has a limited stage, I knew that, but I'm just, small cell lung cancer, and it's stage 3C, T4N3N0. Radiation oncology can treat with definitive radiation. You can do that, Henry? Going to use the new machine or just the old stuff?
The old stuff.
The proton won't be ready till 2026. We got to wait for that. What initial treatment and radiation schedule would you deliver? 1, carboplatin, etoposide, and atezolizumab or durvalumab without radiation therapy. 2, cisplatin, etoposide with concurrent definitive radiation followed by observation. And 3, cisplatin, etoposide and concurrent definitive radiation followed by durvalumab for 2 years. So do we have a way to vote here? Well, do people want to vote? So who thinks number 1? And everyone can vote. This is not one of those events where those who aren't healthcare providers can vote. Who wants number 1? Probably get fired. Who wants number 2? Oh, only a few people that can fire me. Who wants number 3? Okay. So now we have an august panel. So Dr. Grant, they're out there in Waterbury. What would you do? Do we have slides? How do you want to do this? And do we have slides to show? Okay, so would you like to take a lead?
Perfect. So I'm going to actually turn to Henry to talk about the Adriatic trial. And then I'm going to talk a little bit about the sort of implications after that. So
Okay, but before we do that, our public are waiting. So what would you do? Which option?
3.
Michael, Anne, Andrew, Sarah.
Is it approved yet?
It's not approved, but it came out in the New England Journal and we have been using it. I think it's a new standard of care and we'll look at why.
Okay, so we have unanimous consent on number 3. So, okay, Henry, the floor is yours, and let you.
I'll just go through these slides real quick regarding some immunotherapy trials in limited stage that have been ongoing. But the 2 that have been reported is Adriatic, which we'll talk about here. Actually, LU005 is technically embargoed until tonight, so I won't talk about that right now. But it's going to be at Astro where I'm going next. Would be presented on Monday. All right, okay, okay. So I mean, so I can tell you because it's printed in the abstract's already printed, so I will tell you. All right, so Adriatic, it's basically stage 1 to 3 for limited stage small cell lung cancer. Mostly stage 3 though. Here's where everyone got chemoradiation first, either 60 to 66 gray for over 6 weeks or 45 grade BID. So they left a choice that was open to the investigators. Radiation had to start no later than the end of cycle 2 of chemotherapy. And then the randomization was either immunotherapy or placebo. Now the last part hasn't been reported yet, so I won't talk about that yet. Overall survival here, you can see that the main differences here at the median survival being 55.9 months for Durva versus 33.4 for placebo. So really remarkable differences here in limited stage small cell lung cancer where there haven't really been any advances since the advent of concurrent chemo and radiation together. We've been trying to dose escalate for radiation. There have been some trials that have looked at that and so shown an overall survival benefit, but not a progression-free survival benefit. It's been kind of messy data, but this is the first real, the really first real advance, I think, in this area for a very, very long time in this disease. And it really mirrors specific in a lot of ways with non-small cell lung cancer in terms of the kind of 10%, the absolute difference that you're seeing at both the 2-year and the 3-year marks so far. Progression-free, same idea here. So it's pretty remarkable. So basically food for thought, when adding.
I can go through this. Yeah. I think that, just to highlight, this is 2 years overall survival, still early, but that kind of a benefit for small cell, I think everybody can agree it really impacts their lives. And this was a plenary, there was a standing ovation, and this is something that, is, I think, a real breakthrough in the field. Some of the questions that we are thinking about as we start to implement this, obviously is anti-CTLA-4 going to improve, and that arm will read out eventually, and then to emphasize, this is for 2 years, right? So this is different from Pacific and non-small cell, which is for 1 year. This is Durva for 2 years. And, should we continue immunotherapy if the patients recur within 2 years? So I think that's going to change our ideas around platinum chemotherapy challenge and utilization of new agents. We don't know if adding chemo to the IO post-progression works. There is some thought, and our Insignia trial will read out in terms of saying whether or not, you add chemo and then create more neoantigens. Does that does that stimulate the immune system? Maybe we can use ctDNA to identify high-risk patients. Small cell is a disease which has a high burden of circulating tumor cells, and so maybe we can leverage that. And finally, is limited stage different from extensive stage? Because, in extensive stage, that IO only had the benefit, adding IO to chemo only had a benefit of about 2 months, and now we're talking about 2 years. I think there are other questions that we can talk about with the panel around PCI and patients who recur, and the role of surgery for limited stage small cell.
I guess I'll take the first one on PCI. Can you all hear me? With this, okay. So with PCI, that's something that we're studying with the Maverick trial right now. Thank you for the slide. So yeah, if you go back one. So this is a SWOG 1827, the Maverick trial, looking at PCI versus MRI surveillance alone. So on both arms, they get MRI surveillance, but we do have this trial open at Yale still. And the target is currently 600. We're around 200 right now overall, but they're trying to change the study design a little bit to get this a little closer to accrual. The target around 360 instead. But the basic idea is with immunotherapy now, do you need PCI still? And also with MRI surveillance. And I think we don't have a slide here on this, but over at ESMO, they presented the actual subgroup analysis of those who did get PCI versus those who did not. And actually those who got PCI and both those who got Durva and those who did not get Durva, the people who got PCI still did better than those who didn't. Now, of course, that was not a randomized comparison that we really need this trial to see, but there was about 10% difference there in terms of how people did, irrespective if they got immunotherapy. So I still think, I'm not sure, I'll still say standard of care is PCI, but we are offering this trial to everybody to potentially omit PCI on trial.
Let me ask Andrew and get you into the conversation. Is there a role for surgery in limited disease? That's been back and forth in the literature.
Yeah, I think this is potentially practice changing from a surgeon standpoint. Up to this point, typically surgery has been utilized in the so-called very limited stage situation, a small tumor, T1, potentially T2 and 0. The studies that had looked at surgery was of the sort of decades ago when there was less prevalence of the minimally invasive approach, whether robotic or VATS. I think because a lot of the cancer operation these days are minimally invasive, patients are recovering more quickly, able to get back to their pre-op performance status sooner. I think it's definitely worth considering surgery as for a local control.
Right. Does anyone in the audience have questions? Please, I'd love to see interaction. I see our fellows, extra points to fellows asking questions. You get free lunch next Tuesday. We already do that. Okay, new stuff. So this patient's, I've been treating this for 30 years, and I have a few people with small cell limited who are alive, but many will recur. So when they recur, what do we do? After all this, they've already had immunotherapy, they've already had chemotherapy, they've already had radiation, maybe Adner's stuck a knife in them. So then what's next? Sarah.
I feel like I should be the last one to talk about this, but be down at this end of the table. So I think this is really what we wanted to highlight here is that for really the only approved drug for years was topotecan. But now we have other options. There's some really exciting drugs that have just basically shown data. Tarlatamab, I think, is the main one that we're really excited about. We've had this in trial for the last couple of years. We have a few more trials coming with it, but now it's really standard of care for our patients, select patients. I think I'll let Anne tell you more about how to select these patients, and she has a lot more experience than I do with this. But it's so exciting that we have this option for our patients. And then the antibody drug conjugates are also looking pretty good in small cell. I was really surprised to see that. We've had a couple of trials with them. We have a few more coming, and we're seeing great responses durable with ADC. So those are not approved in small cell yet, but hopefully that will be to come.
Right. The clinical trials of today are the therapies of tomorrow. And when tarlatamab had its approval, Gina Colada had one of our patients, front and center in the New York Times. Small little paper there, right? We prefer the New Haven Register, but we got the New York Times.
Playing pickleball. I mean, this is what's so exciting about tarlatamab, this bispecific, is that it directs, it leverages what we know about small cell biology. These are cold tumors. There's not a lot of T cells there. So having a bispecific that one head is recognizing DLL3 on the tumor cell and the other recognizing CD3 to bring your immune system in, that it's so exciting to see response rates of 40%, stable disease 30%, so 70% disease control rate. And at 6 months, 60% of the patients are still on the drug. So we're still, the median median is probably going to be somewhere around 11 months, which is terrific for this patient population. There's really high cytokine release syndrome. So for the first 2 doses, day 1, day 8, we do admit them to the hospital afterwards for monitoring. But at ESMO IO, we hopefully are going to be presenting our data at around the 8-hour monitoring. So stay tuned for that. Hopefully it'll get accepted and I can go. But we have a lot of trials and we're really excited about this space. So if you have patients, please send them or give us a call, email, and we'd be happy to help.
Okay, good. We only have a few minutes, but we'll try to quickly do the second case, okay? And we might just limit who talks just so we can move it along, because otherwise we'll miss lunch, you know? Okay, so Mike, do you want to tell us about the case?
Yeah, sure. You hear me? So this is case number 2. It's a 75-year-old male with a history of lymphoma and also a smoking history, but, remote, quit in the 1990s. This patient recently developed shortness of breath and a cough and had a chest CT, a chest x-ray first, but then a chest CT, which showed a right upper lobe mass of 3.5 centimeters and an enlarged paratracheal lymph node. You click, Roy, you'll see the PET scan. So the PET scan showed that this right upper lobe mass was hypermetabolic, and there was a paratracheal lymph node, also hypermetabolic, and then a subcarinal lymph node and a hilar lymph node as well, but nothing outside of the chest. So this looks to be locally advanced disease. So the rest of the workup ensued, good pulmonary function. He ended up undergoing an EBUS, which showed lung adenocarcinoma in the paratracheal and hilar lymph nodes. But at that time, the biopsy was insufficient for tissue testing or molecular testing. MRI brain was negative, and it was decided to undergo a repeat biopsy to get enough tissue to undergo the molecular testing that we all want. And then this molecular testing showed a PD-L1 of 50% and an EGFR exon 19 deletion. And this is an exon 19 deletion that is uncommon, but is known to be sensitive to TKIs, to all TKIs, but most notably in this case, osimertinib. So this was a stage 3A, as Sarah was talking about, multi-station N2 disease. This is obviously a patient that we need to talk about in the context of a multidisciplinary discussion with radiation, medical oncology, surgery, all the disciplines that go into lung cancer treatment.
We got a whole tumor board here. Okay, so yeah. Andrew, is this a surgically resectable case?
I think for this situation where I guess we'll maybe talk in the next slide as far as therapies for multidisciplinary care. I think it's number one, resectable from a tumor standpoint. Number two, evaluating the paratracheal nodes. I think that'll be important as far as evaluating whether it is bulky, too bulky to be able to get a negative margin or not. So I think there is some, it's sort of a case by case.
So Henry, I know you'll radiate anything, but what do you think about this one?
Well, here I think that well, here the patient, it'll really depend on the surgeon, and I think the key is that if the patient is medically operable and the surgeon believes they could do the resection up front, then I believe they should get chemo IO first and then surgery. I think the question is when it's more borderline and the surgeon is not sure if the patient will be able to get surgery, after the chemo immunotherapy, especially if it stays stable.
But this guy has a EGFR 19, so it's probably going to either be surgery followed by adjuvant therapy or I'm sorry, or chemo radiation, which I'm kidding you. I actually am a big fan of chemo radiation. I trained at the Farber. We used to do a lot of that.
For the EGFR patients, I mean, we see the outcomes from Laura now that show that with chemo radiation after osimertinib, the results are overall pretty reasonable. But I would say here to go for surgery first.
This could be either an Adora or a Laura.
Exactly.
So what do you name your daughter? So who wants to take Anne? What will you do here?
Give it to Mike.
That's a good one. I just thought of that.
So I think this case is highlights a couple of different things that are important. Number one, that we agree that there's a potentially curative intent therapy available for this patient. So the best way to make that possible for the patient is obviously the way that everybody wants to go. The other thing is going back and biopsying to get this biomarker. Sarah mentioned the importance of knowing upfront so that we can select the best treatment for the patient. And then third, the PD-L1 50% is tempting to look at, but in the context of the other genomic alterations is really what's really important for selecting the best treatment. So the EGFR mutation really, I think, takes the immunotherapy options, makes them less likely to be the way we go, because there's targeted therapy options that have resulted recently. So, and then, so the I think the best role for this patient, if surgery is not the best way to go up front, then I think chemoradiation seems like a reasonable option. And obviously Tagrisso or osimertinib would be used afterwards.
I like this. Okay, so show of hands from my panel. Who's going to go Laura? Who's going to do the Adora? This is why you have tumor board. And of course, you'll ask the patient what he or she thinks, right? Any comments? This is a good case. Good. Anyone have any thoughts? So it just shows that in this day and age, there are a lot of choices, and you wouldn't even know about this choice, right, if we didn't profile the patient. So, Sarah, is everyone profiled before they get to tumor board?
Not. I think sometimes we don't have enough tissue. I think sometimes we may not have even it's supposed to be reflex. It's not always, right? Sometimes things happen, but I think this is an amazing case, Mike, that you brought this up, that you did another biopsy because of how important that is. So they should be, and if they're not, it's really important to make that decision.
And I'll tell you, I've worked at 3, maybe 4 centers in my career. It would be different in each one. It depends who your radiation oncologist is and your surgeon, but really, and things change. But the best therapy is, I believe, when you decide what you're going to do up front. The problem is if you then start having to do a split course, and that's not good, right? But we're out of time. But you can ask our experts later, their thoughts. Actually, the photographer's here, so let's get a nice picture of this panel. But thank you all very much. Stay for your photo, and then we're going to move on to the rapid fire here. Okay, thank you. And don't forget the moderator too over here. Okay. Now, in the next, I need it from my CME report because they tell me I don't have my CME or my mock. We're actually giving mock points for anyone who needs mock. That's a real pain in the neck. Okay, so now we have 5 rapid fire. We call it rapid shots. Practice changing literature across disciplines. And I'm going to actually be strict here because if we have 50 minutes now, plus maybe a couple of minutes for the changeover, that'll get us to lunch about 12:20, 12:25. And look how beautiful it is out there. So it'd be very nice to have some lunch. So I'm going to keep the clock. And Harriet, you're the first up, Dr. Harriet Kluger. She's a vice chair of medicine. She's an associate director in the Cancer Center. She's the leader of the melanoma program and the melanoma spore. She's going to give us 10 minutes on melanoma rapid shot. Harriet. And Nelson's going to help you out here.
Okay, thank you. Thank you, thanks, Nelson. Good morning, everyone, and I will try to be as rapid as possible. So 10 minutes on melanoma, what's changed? So the bottom line is metastatic melanoma, not much changed in a big way this year. We've had many, many updates in recent years, but what I will talk to you about is adjuvant and neoadjuvant therapy. So I'm going to start off with one of the late-breaking abstracts from ASCO, where we presented a study of neoadjuvant followed by adjuvant therapy in high-risk stage 3B melanoma, where the results were quite staggering, but one needs to interpret them with some caution. This was presented by my colleague Christian Blanc. And the second one, I actually had to select from a plethora of novel therapies that are coming through the pipeline. And I picked one, a new drug called Preventafusp, which I think might actually make it all the way through the pipeline, and that'll be for metastatic melanoma. So the NADINA study was a very large multi-site investigator-initiated trial, essentially the type of study that all of us in academia dream of doing. It was a study for macroscopic stage 3 melanoma, which was defined as palpable melanoma. Because it was an investigator-initiated study, provides a terrific opportunity to interrogate samples in depth, and it accrued mostly in Europe and Australia in a mere 17 months, which is fairly unheard of for a disease that's not particularly common. The rationale behind doing this trial was that there was another study that was led by SWOG that I discussed here. I can't remember if it's last year or the year before, and I'm sure everyone remembers exactly what I said, of course, but we discussed a study of Pembro that was given before surgery for about 3 cycles, followed by surgery, and then adjuvant Pembro for up to a year, and that appeared to be superior to adjuvant Pembro alone. So the group in Europe took a look at the armamentarium of drugs that we have, and they did a few very small pilot studies looking at neoadjuvant Ipi-Nivo, which, as you all know, is much more active than anti-PD-1 alone. The early studies provided the biological rationale and some safety data. And most importantly, they provided the support for pathology-driven postoperative therapy. So the study design is over here on the right in a fairly simplified fashion. The experimental arm got a flat dose of ipilimumab, approximately equivalent to 1 milligram a kilogram, along with nivolumab, more or less 3 milligrams a kilogram for 2 cycles. Patients then went on to have a nodal dissection. If they had a major pathologic response, which was very carefully designed by the pathologists who worked on the study, they then just went into follow-up and didn't get any additional therapies. So in essence, the intent was to cure with 2 cycles of treatment only. If they did not have a major pathological response, they then went on to get a BRAF/MEK inhibitor if the tumors harbored a BRAF mutation, or 11 months of nivolumab. The comparator arm was the simple 12-month of nivolumab after nodal dissection. And the key result is depicted in the slide over here. There was a staggering difference in the primary endpoint, which was event-free survival at 12 months. Now, remember, 12 months is quite early, but the neoadjuvant group of patients had an 83% incidence of event-free survival compared to the adjuvant arm with 57%. So why do we actually give systemic therapy in resectable stage 3 melanoma? Because in theory, you just take out the tumor and you're done. Well, obviously, you want to increase the cure rate by eliminating microscopic disease that's not seen on scans at the time. But we got to be careful to do this while minimizing toxicity, be it physical, emotional, or financial. And we also want to decrease the recurrence rate, but overall, we really want to increase the cure rate. And that's why we have to keep our eye on the prize in this era. There's a list of potential drugs that have been studied in the adjuvant setting. I have them in that middle bullet over here. But we choose the drugs based on what we know from the macrometastatic setting, where we know that dual checkpoint inhibitors confer better response rates than monotherapy, and that immunotherapy might actually cure patients, whereas targeted therapies don't. But we've also got to take into account that the immune-related adverse events are a challenge. So drugs that have been used over the years, interferon no longer used, ipilimumab no longer used because anti-PD-1 is better and less toxic. There was a study of Ipi and Nivo in the adjuvant setting. It was not superior to Nivo alone. And BRAF and MEK inhibitors are still used because they don't have long-term side effects or long-term sequelae, but there's no actual improvement in survival in any of them. So even if you look at anti-PD-1 alone, if you give adjuvant pembrolizumab compared with standard of care, which at the time was observation, you can see that the survival curves are completely overlapping. So adjuvant therapy is no better than rescuing a patient if you just do the surgery, let things grow, and then treat them at the time of recurrence in terms of overall survival. So it's not clear that we need to actually intervene early at all. So the DINAS trial wasn't actually intended to address this particular question of whether we need to intervene early. It was intended to address the question of what early intervention is superior. So just to summarize the prior trial of neoadjuvant followed by adjuvant anti-PD-1 alone, we do see a difference in progression-free survival. It's not all that clear that overall survival is impacted at all, and that's the curve on the right. And the reason that we're so hesitant to give immunotherapy when we don't need to is the immune-related adverse events. So on this particular trial, the NADINA study, there was one death actually on the nivo-only arm from pneumonitis. The incidence of grade 3 immune-related adverse events was double, but that in itself isn't all that important if we can rescue a patient with steroids for a few weeks. But we need to really think about those that are irreversible. So adrenal insufficiency, 7% on the combination therapy arm, 1% on the adjuvant anti-PD-1 only arm. If you take a patient who's young or not young, it doesn't really matter, but person who's expected to live for many years and you render them adrenal insufficient for the rest of their life, that actually really impacts quality of life. There are others that weren't even documented over here, type 1 diabetes, cardiotoxicity, and neurologic toxicities. Those oftentimes are not reversible. So the main findings of the NADINA study, just in summary, are that there was this highly statistically significant benefit in event-free survival in the combination ipi-nivo pre-op compared to standard adjuvant post-op, but the data are still early. And it's not clear that this confers an overall survival benefit in the long run. This approach is good in that it's very brief. You treat patients for 3 cycles and you could then stop if they have a good response. And it works for patients, or it was beneficial for patients whether or not they had a BRAF mutant tumor. But again, remember that the incidence of immune-related adverse events needs to be weighed very carefully against the benefits, particularly as we still don't have clear evidence that there's an overall survival benefit. So to move on to the metastatic setting, ipilimumab and nivolumab have really changed what we do. At least 50–60% of our patients are alive after 5 years. And our goal is to keep improving that survival benefit. So we've heard over the last few years about the Iovance adoptive cell therapy, which might cure a few more patients, like another 10–15% of patients who aren't cured from ipi-nivo, but we still need a whole list of things that we can do for patients who don't respond to those initial therapies. So I selected one therapy only among the list of things that were presented at ASCO, just because my gut feeling is that this one might actually make it all the way through. So this was a phase 1 study of a CD3 combo therapy that targets PRAME, a bispecific antibody in the post-checkpoint setting for cutaneous melanoma. So brenetafusp is made by ImmTOR. It's essentially a T-cell receptor that recognizes PRAME when PRAME is presented within the context of HLA-A201. Now, this can be made for all sorts of HLA subsets, but A201 is the most common HLA subtype that's seen in Caucasian patients, who are those that tend to have melanoma. So when PRAME is presented by the HLA molecules, it's recognized by brenetafusp, and then brenetafusp on the other side has an antibody to CD3. So essentially, the CD3 cells are brought into the tumor microenvironment. We just heard something similar in small cell lung cancer. So this is a new class of drugs, and I think we're going to be seeing more and more of these in various different clinical settings. So for melanoma specifically, there was a monotherapy arm and a combination with pembro. I'm not going to talk about the combination with pembro because the N of patients was too small, but if you just follow the monotherapy arm over here, 47 patients in the expansion cohorts were treated with brenetafusp at 2 dose levels, and taken in combination, the overall response rate was only 13–14%. But if you combine the partial response with stable disease with confirmed tumor reduction, which in melanoma is somewhat meaningful, you do see that we're getting around a 25–30% actual benefit in patients who are PRAME positive. None of the patients whose tumors did not express PRAME responded. In other words, you need PRAME on the tumor surface in order to respond. The clinical benefit can be prolonged. As you see in the spider plot over here, the vast majority of the responses were ongoing. I think I'm being told to wrap it up. Okay, so this was very well treated. It's early in the game. We do believe that this is now going into phase 3 and more to come in the coming years. And with that, I'll stop and let the next rapid shot, hot shot, come on up.
Okay. A little too early for those kinds of shots.
Don't drop it. Okay, so next rapid shot. Hi, Nick. We have to keep on time. So Nicholas Blondin, wonderful neuro-oncologist, is going to tell us about neuro-oncology. Nick.
Thanks. Thanks to Dr. Herbst for the invitation to present some abstracts from ASCO in the neuro-oncology section. I'm Nick Blondin, neuro-oncology. No conflicts of interest. I was an investigator for the 3 studies I'm going to be presenting on enrolled patients into all these studies. I'll be talking about a study for GBM, meningiomas, and brain metastasis. The first study that I'm presenting is the evaluation of VAL-083 in the GBM Agile study, which is a phase 3 registration platform trial for newly diagnosed and recurrent glioblastoma. The goal of the GBM Agile platform is an adaptive design to test multiple therapies against one standard control arm for newly diagnosed and recurrent glioblastoma patients. The control arm is radiation with temozolomide, and the recurrent is with lomustine. Both temozolomide and lomustine are the standard of care, but relatively ineffective chemotherapies for glioblastoma. This reports the VAL-083 arm. Other arms are currently enrolling, including VT1021, troriluzole, and adipeg-20. This drug, the VAL-083, has been in development for some years. It's a non-selective alkylating drug. It acts independently of MGMT methylation status. It was studied in some small studies suggesting efficacy in GBM. So it was studied in this study, but unfortunately there was no improvement in overall survival in any GBM population, newly diagnosed patients that were methylated or unmethylated, or recurrent patients. Unfortunately, these are the standard, survival curves of GBM, a disease where survival is measured in months, sometimes even in weeks. So the key takeaway was that the platform is working well. I mean, from start to finish, this was less than 3 years to get this data, which is much faster than other studies in glioblastoma historically. The drug didn't improve survival compared to control, but this study continues ongoing. Hopefully a future arm will be effective. All right, in the second study, this was an alliance study, a phase 2 trial of abemaciclib in patients with refractory meningiomas harboring mutations in NF2 or CDK pathway alterations. It was found that meningiomas have several driver mutations. A small majority, like around 50 to 60% of meningiomas, harbor loss of CDKN2A and NF2. So using like a targeted therapy for this seemed to make sense. CDK inhibitors are used in other cancers. So this alliance study is a platform study for patients with recurrent or progressive meningiomas with different molecular subtypes being treated with different drugs. This again was for patients with NF2 or CDK alteration. And it was a single agent study. The study did seem to have some intriguing results with progression-free survival. And these patients enrolled generally have these relentlessly progressive meningiomas, and historically survival is usually in the 6 to 12-month range for these patients who have progressed after radiation and surgical therapies. So this seemed intriguing, and yeah, here's the overall survival. Most patients were censored after a year to a year and a half on study, but you can see more than 50% of patients enrolled have survived more than like 18 months. So that seemed to be pretty good results for this population of patients. The abemaciclib also had good tolerability. Again, it's a kind of a commonly used drug for breast cancer, and seems to be intriguing for these patients. So this is going to be studied in a larger study to be planned. And then the third study that I'm presenting is called the METIS study. This was an international multi-center phase 3 study evaluating the efficacy and safety of tumor treating fields or TT fields therapy in patients with non-small cell lung cancer brain metastasis. The concept here is to treat patients that have lung cancer brain mets with tumor treating fields therapy after they received SRS gamma knife for their brain metastasis. Patients were randomized 1-to-1 to receive SRS and then follow-up treatment with the device or best supportive care. Patients would continue therapy on the device past second progression. Patients in the best supportive care arm were allowed to cross over. Only a small number of people crossed over after second progression of 15 patients. So the primary endpoint for this study was the time to their first intracranial progression or neurological death. There was found to be an advantage in patients that were randomized into the TT Fields arm. Patients had, using the device, had I guess, slower time until intracranial progression and seemed to overall do better. The death between the patients was kind of similar between the groups. It's down there in the far corner. The median overall survival was no different. Again, a majority of patients died from systemic issues related to their cancer, not neurological death. But in using the device, there was overall improvements of quality of life in the patients in the device arm. And I think that correlates to just delaying the time of neurological progression. So as a neuro-oncologist, I want to delay neurological progression for as long as possible because that progression correlates with neurological disabilities and poor quality of life. So criticisms are brought to this device, making the patients wear the device may decrease their quality of life with having to deal with it. But in fact, when studied and using validated quality of life metrics, quality of life is improved in patients that use the device simply by virtue of delaying the time until progression. This is another curve looking at their quality of life outcomes, again, kind of favoring group with the TT Fields. So in conclusion, the study met its primary endpoint. The time to first intracranial progression was prolonged in patients on the device compared to best supportive care, and therapy was well tolerated. All right, I made up some time there, Dr. Herbst. So.
You want to take a question? Yeah. Anyone have any questions? How do we make an appointment with you?
Oh. Well, unfortunately, the survival for GBM remains grim. It seems to be the worst form of cancer compared to others that have been presented. I mean, it's just remarkable to see all the options. That data for the GU cancers presented at the beginning of the morning, the survival curves, or what Dr. Goldberg presented with that chart with all the options for lung. I just hope that someday my patients will get those options also.
Right, but when patients have brain, when we have patients, we need a consultation. Where do you see your patients?
I see patients in New Haven, Trumbull office. We have another faculty who joined us in June, Dr. Sylvia Kurz and Dr. Baring. And we're actively recruiting for another chief to replace Dr. Omuro. So we're trying to boost up the number of docs, and hopefully going along with that, we'll have more treatment options for our patients.
Wonderful, thanks.
Thank you.
So now, probably in between two surgeries, Elena has come here to tell us a little bit of an update on gynecologic cancers. Good to see you, Elena. Let's get her slides up here, Nelson. There you go.
Thank you so much, Dr. Herbst, for including us. We in the world of gynecologic cancers very much like to be included in these, so we greatly appreciate it. I appreciate that I am keeping you from lunch, so I will move nicely. I never like being in the spot. I will go through things pretty quickly. There's actually been a lot of very exciting updates in the last year in different conferences. This year, I have nothing pertinent to disclose. This year, unlike years in the past, where ovarian cancer is really the only cancer where there's meaningful research, this year we actually have been very lucky to see advances in many different very different gynecologic cancers. So I will start, and I will go very quickly because there's actually a lot of very profound, meaningful work that has improved PFS and OS, and I'll try to just then subdivide it by disease site. So in ovarian cancer, I'm really going to just mention two and then a couple subsequently that are a little bit earlier in the development. So the first one is RAM201. This is actually very exciting. This is a study for low-grade ovarian cancer. Usually, all ovarian cancer research that's done is in high grade. That's the cancer that's really deadly. But So is low grade, and low grade traditionally has been a very surgical disease because traditional chemotherapy really has not been found to be effective. So RAM 201 was very exciting. The previous treatments that we have overall response rate of 0% to 26%. So these are both targeted agents. Avelumab is inhibitor of MEK. Defactinib is the oral inhibitor of FAK. And has showed pretty profound overall response rate and benefit in PFS and OS. A lot of these patients additionally have been on MEK inhibitors previously. So this is doubly exciting because MEK inhibitor was the previous really exciting thing that I have discussed with you that really changed the nature of the treatment of this disease. It continues to be largely surgical disease, but now it's great to see some sort of targeted, personalized options for women. And this is another one that I wanted to select to mention, the ctDNA. In the world of gynecologic oncology over the past few years, we have had very exciting development, of course, of PARP inhibitors. PARP inhibitors, something that we started to use routinely for treatment of ovarian cancer and then subsequently for maintenance. And it really changed the paradigm, the nature of ovarian cancer. You know, women, it became much more of a biomarker-driven disease. PFS improved, OS improved. We really appreciated later. It was really mostly so for women with BRCA-ness, BRCA somatic or germline mutations, or homologous recombination deficiency. But we got so excited about it that unfortunately we have put all women on it. And then subsequently, this is now the time where a lot of women developed dysplastic syndromes and acute leukemias. And a lot of women, unfortunately, a number of women, unfortunately, have died from that complication of the PARP. So over the past couple of years, we really have struggled. How long do you go on PARP? You know, do we continue how like we used to do for 5 years, or do we stop at 2, which is really what is now much more acceptable, and certainly what I do now. I try not to go beyond 36 months. So this is one of the studies about ctDNA, about using that kind of testing as a biomarker-driven testing to determine whether PARP inhibitor should be continued and for how long. So this was a very positive study that really was very significant and very positive for being able to detect the specific mutations and then was able to help identify which patients should be continued and which ones should be stopped. I wanted to mention this one. This is a Yale study, exabeplon Avastin. This is something that we have discovered here. This is something that comes from us and something we have known for a long time, but really very novel chemotherapy regimen that's now nationally being tested. This is for a very, very bad prognostic group, platinum-resistant, very, very pretreated ovarian cancer. And this combination has now been used nationally and has been presented at conferences to show a significant overall response rate of almost 40%, which is not anything we see in this kind of a very pretreated, poorly prognostic population. And then very briefly, novel therapeutics, multiple different small molecules that are being studied in ovarian cancer that are all targeted based and biomarker driven. So endometrial cancer is actually even more exciting this year than anything else. I want to start with really the most exciting one. So I'm sure all of you know about pembrolizumab that has been included in the treatment of endometrial cancer, advanced and poorly prognostic endometrial cancer. We have started using pembrolizumab. And it was a very interesting and long journey for which I do not have time to discuss with you this morning. But in short, it was started to be used originally only for MMR deficient disease. Subsequently, it was FDA approved for MMR deficient disease. And then subsequently, literature has shown that there was overall survival in MMR deficient and proficient tumors, which was actually really incredible because we have not seen this in the world of endometrial cancer, these bad prognostic endometrial cancers, actually in generations. So very recently, as of August 8th and then August 10th, FDA approved both the dostarlimab that I will mention now and pembrolizumab for use in all patient population with high grade, high poor prognostic factors, high stage recurrent endometrial cancer. And the Ruby trial is that the second trial that followed after the addition of pembrolizumab about the addition of dostarlimab in the same kind of population. And again, it was the first study in a long time that we have shown very significant, but really profound PFS and then overall survival benefit in women with both deficient tumors, of course, much more profound benefit, but even proficient tumors. So this is actually something that's literally like right off of the press. And like literally in the middle of the chemotherapy cycles, women now, we added this, we started adding them directly to their treatment protocol and then for maintenance for 2 to 3 years between this and pembrolizumab. This is another targeted option, GOG 3041, where the similarly addition of the durvalumab to the carboplax or carbo and taxol, and this one is even more enticing because there's an addition of a olaparib as PARP inhibitor. And there's multiple different groups that show benefit, again, biomarker driven in multiple populations, but super exciting. Like for the first time, again, in a very long time, we're seeing profound PFS and even more OS benefit, and really, really exciting that it's happening biomarker driven in a really, truly personalized care kind of a model. Pembrolizumab, lenvatinib, something that I talked to you last time that was presented at ASCO a few years back. And now, of course, there's multiple studies that's looking, can those biomarker-driven, these targeted options, can they actually replace chemotherapy? That's, of course, like the future and the exciting aspect of it. At this point, we did not show that it can. It was not superior to chemotherapy up front. It was equal, and it's being studied further whether it can actually be replacing cytotoxic chemotherapy. Though there is some population like women who have had neoadjuvant chemotherapy where there was benefit, as you can see, overall survival of 34 months versus 21 months. So there was some presentation on PARP inhibitors in endometrial cancer, something that we have suspected for a long time and something that a lot of us use off trial and off indication, but there was finally some use presented of PARP inhibitors in the uterine cancers, especially uterine serous cancers with some benefit. Multiple trials in cervical cancer. I will not really go through them, but again, targeted options with some evidence of benefit. Interlace trial, which is a trial of using chemotherapy almost like in a neoadjuvant fashion before the chemoradiation in this population that showed some benefit, and certainly a very valid concept and something that's going to be studied more. More targeted options in this population. We have studied, so there's presentations on Nivo and EP that is better than Nivo monotherapy for metastatic ovarian cancer and other extrarenal clear carcinomas with 16% CR with this combination, something that we're now using in practice. There were some surgical trials, and this is something that's been debated for a long time and probably will be debated for many more decades to come, whether there is benefit of lymph node dissection at the time of surgical debulking. And this is something that no matter, I think, how much we study, old school and new school is going to do differently. So nevertheless, evidence shows that there really was no there was no benefit in these kind of profound surgical debulkings of the lymph nodes. There's a lot of use now and a lot of success now in using mirvetuximab in ovarian cancer for folate receptor positive tumors. This has really, again, changed the paradigm, and something in receptor tumor in platinum-resistant disease we use a lot and has been used a lot. So now there were studies that showed pretty similar benefit in endometrial cancer, which is very exciting. And then more of the same that I showed to you before, the immunotherapy, the targeted options that is being used now to understand which of the patients that are best selected and what is the best time that's best used in these kind of patient populations and for how long. Thank you so much for including us.
Thank you, Dr. Ratner, and thanks for all you do for the center and for our patients. Okay, next we have head and neck cancer, and one of the other spores that I mentioned earlier this morning and very happy to have for a rapid shot, Barbara Burtness to give us the sport leader to give us a update.
Hi. So when they said rapid shots, I thought it was early for vodka, but I guess it refers to gunfire. Okay, so this was a year, I think, where we finally started to see the engagement of many trials looking at novel agents in head and neck cancer. None that was necessarily practice, here are my disclosures, none that was necessarily practice changing, but really showing a lot of activity. And I think we're going to be having phase 3 trials that will change things. So there were 3 main classes I wanted to talk about: HPV vaccines, ADCs, and targeted therapy. And there was really a plethora of talks. So I just picked one from each. So among the HPV vaccines, we also saw PDS 0101. We also saw the Q Biopharma compound. I thought that I'd show you the Hukipa HB200. This is an arenavirus-based immunotherapy together with pembrolizumab as first-line treatment for HPV positive head and neck cancer. This was a 38 patient cohort. They had minimum follow-up of 4.5 months. Among the 35 evaluable patients, there were 13 confirmed responses, or an objective response rate of 37%. I think also striking that they saw some CRs. If you look at the waterfall plot, the CPS greater than 20 patients are shown in blue, so you can see that the high response rate was driven by those patients. But I think that this is something we're likely to see move forward, as with the Q compound, as with PDS 0101. A bispecific antibody that got a lot of attention is petosemtamab. This was given together with pembrolizumab and presented by Jerome Fayette. So peto is a bispecific that targets EGFR. You all know with cetuximab, really our only validated targeted therapy in head and neck cancer. And the other target is LGR5, which is a receptor for Wnt signaling. And Wnt signaling has been associated with EMT, worse prognosis in head and neck cancer. I think we don't totally understand what the characteristics of the binding of this bispecific are when there's not a lot of LGR5 around, and how that would stack up against cetuximab. But nonetheless, they took this forward together with pembrolizumab. The total enrolled population was 45 patients, and they only presented results on 24. I think that was due to maturity, not toxicity, but just take it with a little bit of a grain of salt because of that. But you see here the response rate of 67%, and this is moving forward in phase 3 studies, both in first line and second line. The first line study is pembro with or without peto. So I think people are very excited about this compound. There were a number of ADCs that were looked at. I pulled out tisotumab vedotin. This is from a presentation by Lova Sun. So tisotumab vedotin is a tissue factor-directed antibody drug conjugate. It's already approved in cervical cancer, and there was a multi-disease study that had a head and neck cohort of 40 patients in it. And you see here confirmed objective response rate of 32%. This was an extremely heavily treated, pretreated population. If you confined yourself to looking at second and third line patients, 40% response rate, and some of these extremely durable. Destiny Pan-Tumor 02 was looking at TDXD in patients who had previously treated HER2-expressing solid tumors, and there was a head and neck cohort. This was not actually driven predominantly by mucosal head and neck cancers. This was more salivary gland cancers, but again, very intriguing, a response rate of nearly 42%. This was higher at 57% for the patients with high HER2 expression by IHC. Didn't seem to be negatively impacted by prior HER2 therapy or prior radiation therapy. And so with a median duration of response of 22 months, median PFS of 12 months, and OS of 23 months, this was really very intriguing. A phase 3 study that was presented that I think people didn't quite know what to make of this was a comparison of intensity modulated proton therapy with intensity modulated photon therapy. This is a multi-center study. It accrued over a surprisingly long number of years, but people were very excited about the possibility that protons could decrease radiation dose to adjacent normal structures, and it was already known that it would decrease mucositis, adenophagia, weight loss, and so forth. So this was a randomized study, very heterogeneous management approaches. So they permitted induction chemotherapy. They permitted both HPV positive and HPV negative cancers. There was stratification on those as well as on smoking status. And then once patients got to the chemo-RT, there was a variety of the ways that the chemo was given, but the radiation was 70 gray IMRT or IMPT. And then restaging and then salvage surgery if necessary. So to the extent that these data are interpretable, they looked good for protons. So the non-inferiority p-value was 0.006. And you can see at 5 years, it looked like maybe there was a 5-year improvement in progression-free survival. And you can see how long this study has been ongoing with 10-year survivals here. But again, no disadvantage in overall survival and maybe an improvement in overall survival. I think the next slide will show you a little bit why people are skeptical of this trial. So you see in the control arm, 42% usage of gastrostomy tubes, not, I think, consonant with contemporary practice, where it's probably more 15 or 20%, but it did seem as if IMPT within these centers reduced that. We showed the long-term follow-up results of 3311. This is a study you may remember of transoral surgery for low-risk HPV-associated disease, followed by de-intensified postoperative therapy, asking the question of whether or not transoral surgery would be a strategy for de-intensification. Patients were eligible to a T1, T2 cancer, and they weren't supposed to have matted nodes. And then they went through their transoral resection and neck dissection, and then were categorized as either high risk if they had positive margins, E&E, or 5 or more nodes. We had hoped really not to have those kinds of patients in the study, but it ended up being about 31%. If they had close margins, minimal E&E, 2 to 4 lymph nodes, or PNI, LVI, they were called intermediate risk, and those patients were randomized between 60, which was the old standard, and 50 gray of postoperative therapy. And then patients who had a single, either no nodes or a single node of 3 centimeters or less with no E&E, which would have been AJCC7 N1 disease, were observed. So we updated this with 4.5-year follow-up. I think given the nature of follow-up in the cooperative group, this may be as good as it gets. And overall, everything continued to look as it had before. Overall survival, 95% for the strategy as a whole at 54 months. But we did see a fall off in progression-free survival for Arm A. So we looked at those 38 patients a little bit more closely. 11 of them had N0 disease, and none of those patients recurred. But among the 27 patients who had a single involved node with no E&E, the recurrence rate was 14.8%. That was actually higher than the higher stage patients who got 50 gray. And so, and interestingly, 3 of those recurrences were late at greater than 3 years. So I think there is a concern that we misunderstood the ability to de-intensify patients with node positive disease. And I think that may be the one kind of practice changing thing from this update. We also looked at tumor subsite and smoking history and whether or not they predicted outcome, and neither having a base of tongue cancer nor having a smoking history was associated with worse outcome. And then lastly, I'll show you what we thought was a failed trial. This was 3163. It was a study, I'm just about done. It was a study for patients who had nasal or paranasal sinus cancer who were going to require either orbital exoneration or resection of the base of skull. And the question was, would induction chemotherapy lead to structure preservation? Naturally, when you put that to patients, they said, well, if there's even a little bit of a chance, I want the chemo. So this study accrued very poorly. But when we looked at the 23 evaluable patients, structure preservation went from 15% in the control arm to 50% in the intervention arm. And if you looked at people who did not have T4B disease, it went from 18 to 71%, and that was statistically significant. So I think even though this was less than 30 patients, I don't think people are going to be able to run another study that doesn't involve induction. And so I think this does mean that induction is now the standard of care for structure preservation in nasal and paranasal sinus. Then just lastly, we expected at ESMO to see a phase 3 study of xevinapant, which is a SMAC mimetic. This inhibits an inhibitor of apoptosis, potent radiation sensitizer. There had been a completed phase 3 study, and the first interim analysis was read out as futile. So the abstract was actually pulled from ESMO, but I think this led to closing down the xevinapant program and is an important update. Okay, thank you. Sorry.
That was great. I gave Barbara a little latitude. She's built the best head and neck program in the world, and I really mean that. Okay. So our last speaker before lunch, a few announcements. This is going to be on palliative care with Dr. Elizabeth Prusik, and then the best palliative care is our lunch. Now, when we break for lunch, the faculty, Eddie, who are still here, and hopefully most, we're going to go outside and do a group faculty picture for next year's brochure, because we're going to do this again same time next year. But now for 10 minutes, we're going to hear from Liz. And by the way, we'll come back from lunch at 1 o'clock. You can bring your food to the table because we have one of our deans and department chairs, Lucila Ocho Machado, who's going to tell us about artificial intelligence. Everyone wants to know that, just so you know what stock to buy, right? You got to listen to that. Okay, so Liz, the floor is yours.
Apologies for the delay. Does this need to go full screen or? There we go. All right. All right, thank you guys for your patience. Thanks for giving me the opportunity to speak with you today. I'm Elizabeth Persich, and I serve as the Director of Adult and Patient Palliative Care Consult at Yale New Haven Hospital and also the Firm Chief for Medical Oncology. I'm trained in both, and I focus my care on the care of our admitted patients. I have no financial disclosures. The annual meeting this year focused on comfort to cure. We as cancer physicians, we all aspire to cure. However, cancer remains the second leading cause of death in the United States, and the treatments that we offer has significant physical, social, emotional, financial, and time toxicities. All of our patients, regardless of age, stage, and treatment intent who face advanced cancer, will benefit from the integration of palliative care throughout their disease course. I'm going to focus today on palliative care delivery and also symptom management, and in the interest of time, I'll just dive right in. I'm going to begin with this study highlighting the early palliative care among patients diagnosed with advanced cancers between 2010 and 2019. As we know, ASCO recommends the early integration of palliative care early integration for all patients with advanced cancers. However, evidence of its use in the role of practice patterns and organizational characteristics in its implementation is limited. This study looked at serum Medicare data of patients 65 and older with newly diagnosed advanced cancers in between 2010 and 2019 with 6 months or greater survival. Early palliative care was identified by claims within 90 days of diagnosis or up to their first hospice admission. And this study looked over the percent of patients receiving palliative care each year. As you can see, and as we all know, palliative care integration has increased significantly over the past decade or more. It went from just 1% of patients in 2010 to over 10% in 2019. There were statistically significant difference, it was statistically significant across disease types, as you can see above.
There were significant variations in patient factors as well as clinician and organizational factors. So patients who had higher comorbidities, older age, females more than males, non-Hispanic Black patients, and those residing in metropolitan areas were more likely to access early palliative care throughout this period. For non-patient factors, female clinicians, those of younger ages, and also larger organizations with integrated palliative care services, unsurprisingly, were associated with more early integration. What I found interesting here was that the variation in terms of early palliative care use was more dependent on non-patient factors rather than individual patient factors. More patients with advanced cancer are receiving early palliative care, but utilization overall remains low, with only 10% of patients nationally as of 2019 receiving early palliative care. And there were significant variation by clinician and organizational characteristics. The takeaway here is that early palliative care has been increasing over time, but the differences in terms of receipt is really more about us as clinicians and organizations rather than our patients and their individual needs. Second, I'm going to highlight a multi-site randomized trial of stepped palliative care for patients with advanced lung cancer. This is a study led by Jennifer Temmel out of Mass General. So we all know that early integration of palliative care is important from the time of diagnosis. It can aid both patients and their caregivers. However, this model has not been widely implemented, as we saw in our previous study, given the shortage of palliative care clinicians and also challenges providing palliative care visits throughout the course of cancer treatment. So this study looked to how we can deliver more patient-centered and less resource-intensive palliative care, looking at a stepped palliative care model, which I'll outline here. So this graphic outlines the stepped palliative care approach, where palliative care visits are stepped up in response to worsened quality of life measured by the FACT-Del. This study looked at patients with advanced lung cancer. I think realistically, this is how many more of us practice, responding to patient need rather than automatic referrals at the time of advanced cancer. So patients with advanced lung cancer here who were diagnosed within 12 weeks with a performance status of 0 to 2 were randomized to either stepped palliative care or early palliative care between 2018 and 2022. Patients with an initial palliative care visit within 4 weeks of enrollment had regularly scheduled quality of life assessments measured by FACT-Del. Patients randomized to early palliative care had visits every 4 weeks rather than in response to decreased quality of life per FACT-Del on the stepped group. And the primary aim of this study was to look at non-inferiority for quality of life as measured by the FACT-Del at 24 weeks. So what did they find? The mean number of palliative care visits at 24 weeks was lower for the stepped palliative care group compared to the early palliative care group, which is not surprising and probably beneficial given resource limitations on the palliative care clinician side. Importantly, quality of life scores at week 24 for those assigned to stepped versus early palliative care were non-inferior. The rate of end-of-life communication was similarly non-inferior between the stepped palliative care and the early palliative care group. However, non-inferiority was not demonstrated for days on hospice. Stepped palliative care approaches provided at the time of worsening functional status is not inferior to early palliative care in terms of quality of life or end-of-life communication at 24 weeks. However, stepped palliative care was associated with fewer days of hospice enrollment at the end of life. This next study I'll go over briefly in the interest of time, but I did want to touch upon this work. This is a study looking at behavioral economics and analytics to improve palliative care in advanced cancer. It used an algorithm-based approach to identify patients at highest risk for palliative care referrals. So early specialist palliative care can improve these outcomes for patients with advanced solid tumor malignancies, but most patients don't receive a palliative care referral before death. As we saw, 90% of patients in 2019 did not receive any palliative care whatsoever. Barriers to palliative care may include difficulty identifying high-risk patients and also physician referral burden, and that is what this study aimed to address. It was a two-arm pragmatic cluster randomized clinical trial that looked at patients with advanced lung cancer or non-colorectal GI cancers. It used an automated algorithm embedded in the EHR that assigned each patient a risk score. Patients in the intervention arm on the left received, their oncologists received weekly default EHR notifications that prompted specialty palliative care referral. If oncologists did not opt out,
a nursing coordinator reached out to the patient, introduced palliative care, and offered to set up a visit. In the control arm on the right, oncologists referred at their discretion as per usual. They use behavioral economic methods, including normative and risk-based messaging with explanation. What I found interesting here was that in their opt-out message to clinician, it was also signed by the chief medical officer and the president, of the organization, which I think probably helped with adherence as well. So in this study, there were 562 patients, 296 in the intervention arm. The risk score in terms of severity of illness and comorbidities was equivalent between the groups. In the intervention arm, nearly 90% of clinicians did allow for palliative care referrals. There was no opting out. And of the patients contacted, 80% chose to schedule palliative care visits. As you can see in this graphic, unsurprisingly, the intervention group had significantly higher rates of completed palliative care visits with an adjusted odds ratio of 5.4. It did result in decreased chemotherapy at the end of life. So of patients in the intervention arm, it was 6.5% versus 16% in the control group. There was no difference in quality of life or hospice use among the decedents. I'm going over things quickly because I know I'm standing between you and lunch. But in conclusion, this is a large community oncology network. Algorithm-based default palliative care referrals were acceptable to clinicians and led to a threefold increase in specialty palliative care referral and completion, as well as decreased end-of-life chemotherapy. This approach was supported by physicians in terms of the criteria for selection and those process, and was associated with decreased end-of-life chemotherapy. We all work so hard for our patients. I think this study reminds us that we can also use data analytics and AI to help us work smarter too. This study I wanted to touch upon briefly. I've got 2 more to go, but what I wanted to highlight here was the effectiveness of early palliative care delivered via telehealth versus in-person. Clearly, accessing palliative care, referring to palliative care is a challenge, and our patients who benefit the most from this with advanced cancer often have significant comorbidities in terms of mobility, time toxicity, and just a lot of interface with the healthcare system. So how can we help overcome these barriers? This study looked at over 1,200 patients with advanced non-small cell lung cancer diagnosed within 12 weeks who were enrolled across 22 cancer centers. This was done between 2018 and 2023. They were randomly assigned to meet with a palliative care clinician every 4 weeks through the course, either by video or in-person visit. And they had self-reported quality of life measures at weeks 12 and 24. The primary aim was to evaluate the equivalence of telehealth versus in-person at quality of life at 24 weeks measured by FACT-L. Nearly 80% of caregivers were also enrolled in this study, which I think was really important as well. Quality of life for patients assigned to the telehealth group was equivalent to those receiving in-person early palliative care, which was significant. And a review of documented topics that were discussed in the palliative care visit were also similar between groups. So exploratory outcomes also demonstrated that there was no difference in terms of depression or anxiety symptom between groups, which I think is also reassuring. So no difference in a range of patient-reported outcomes for this. More caregivers did attend in-person versus video visits, and there was no difference in terms of quality of life between the in-person and telehealth visits. So I think this is another important tool to expand access to palliative care and gives us reassurance that in many respects, the visits will be equivalent in terms of effect. Looks like you're wrapping me up, so I will skip over the rest. But I do want to touch on 2 things quickly. Yes.
I will give you another minute.
Sounds good.
Very palliative.
Yes.
Yeah.
I will go a one-liner for each, but
Back in, start the line. As soon as we stop, okay?
one study I wanted to touch upon, comprehensive prescription drug monitoring mandates. They help us keep our patients safe with the opioid epidemic and all the opioids that we do prescribe for advanced cancer. What I wanted to highlight here is that there are significant disparities in terms of how these mandates affect our patients. There is up to a 10% decrease in opioid prescriptions for patients with advanced cancer nearing the end of life in states that did implement the PDMP programs, and that this disproportionately affected our non-Hispanic Black patients. So I think we all need to be mindful of health equity issues when it comes to cancer care, especially at end of life for all of our patients. And secondarily, this one got me pretty amped up before lunchtime, but payer denial for prior authorization requests for long-acting pain medications, a major issue we all know 90% of prior authorizations for patients with advanced cancer and severe cancer-associated pain are ultimately approved. The average length of time it takes to deal with these approvals is 2 days. And of patients that do have denials, which is about 5%, they get their medications completely denied. A quarter of those patients will end up requiring acute care, either in the emergency room or in the hospital. And 1 in 10 of those patients will pay out of pocket. So I think this tells us we all need to advocate for improved, transparent prior authorization processes. And in the meantime, make sure we give at least 3 to 5 days to address these issues so our patients aren't suffering unnecessarily at the end of life. Palliative care has been growing, but not enough. There are a lot of care delivery innovations that can increase appropriate referrals and decrease clinical burden for our oncologists and improve staffing. And opioid state insurance policies may have unintended consequences that can be detrimental to our patients. So thank you so much for allowing me the time before lunch to talk about palliative care. Thanks.
Okay, that was great. TPN is in the other room. Okay, so now we have lunch. We are going to start the lecture at 1 o'clock. We have the tables. You can bring the lunch back to your tables and eat. There's plenty of food here. Everyone will get food. There's also exhibits and so forth in the other room, which I urge people to visit. So those who are closest to the food, you picked a good seat. Okay, everyone, we're going to start in 1 minute. 1 minute.
Yeah, you mentioned
This is it. Increase my profile. Yeah. Okay, let's all get to our seats. This lecture will be better if it's quiet. Okay, I'm going to give it another 30 seconds. Good to see all our fellows back. I went out and got the fellows. Yes. They need to hear them. You know Scott? Have you ever met Scott Herbst? Have you met yourself? He does all of our quality work and outcomes and he'd be someone good to know me. Okay.
Sorry. Hey, Christine. How are you?
Okay, thank you all. It's been a wonderful day, and the day still has a lot to go. I'm really excited. We have a whole big section on hematology, right, Dr. Huntington? I see Dr. Helene and Dr. Podostov here. I got a lot to learn, you know. Okay, so now what we're going to do is we have a special keynote lecture, and as has been our tradition the last, I guess, 13 years that I've been doing this, is we want to bring someone in who's going to raise the bar. You know, what's the future of healthcare, of medical research? And we're so fortunate this year that our committee, Pam Kunz, Sue Evans, Kiran Taraga, myself, Scott Huntington, our first choice agreed to come, and that's Dr. Lucila Ocho Machado, who's here on my right. She's the Waldemar Var Zetowitz Professor of Medicine and Bioinformatics and Data Science, Deputy Dean for Biomedical Informatics, and now there's a chair of a new department of Biomedical Informatics and Data Science. Her CV is enormous, so I'll just give a few highlights. She's been one of the leaders in using big data to solve healthcare issues. She has been in a number of amazing places, the Brigham and Women's Hospital, MIT, out in California and San Diego for many years, where she linked the databases for many of the hospitals in the California system. I think she'll probably tell us about how she did some of that, or certainly things that came from that, and really has been a leader in how to use big data. And I know that one of the initiatives in the last 2 or 3 years here at Yale has been to build that. So we're very happy that she's joined us and been recruited. She has many different awards, including election to the National Academy of Medicine, one of the highest honors. So it's really wonderful to have you here, and thank you for coming to our ASCO review and beyond.
Thanks for the invite and for the opportunity to talk a little bit about AI, which excites a lot of people, scares a few others, or both. So I also thanks for whoever came up with the title, because my typical is challenges and opportunities, but this is much more exciting, I would think. So I'll do an overview. So for those who know AI very much, it's a good time to get dessert or coffee and so on. For those who don't and are interested to learn, I will go a little bit about the basics. So I'll simplify, so pardon me for simplifying a lot of things, but I think it helps understand what the issues are. So here's an overview, and I'll get to talk about large language models, which everyone, it's an obligatory part of the presentation, but AI has been around for quite a while. In the 80s was expert systems, in the 90s was neural networks, other machine learning methods, and past decade was deep learning. And now we are in the era of generative AI. So I will review a little bit of what that is, and the history will be written for you at the 30s and 40s, what AI is going to do. So as you know, the New England Journal created a whole new cascade journal called the AI in Medicine. The JAMA network of journals has a special channel on AI because the volume of publications and research in this area has been increasing exponentially. But I will go back to a time where most of you weren't even born. In 1966, the first chatbot was, the publication was out. And this, as you look on the right-hand side, is at a time where the computer terminals didn't even have a monitor. It was all printed as the person interacted with the computer. An emulator exists, so if you Google ELISA emulator, you will be able to talk to a computer in the 60s, and it might prove very entertaining, as it is today to talk to ChatGPT. So expert systems came about in the 80s, and they were specific to diagnosing particular conditions, such as the one described here. And they were rule-based. They will elicit what rules a particular clinician uses to diagnose glaucoma and treat infectious diseases, and so on. And at that time, there wasn't enough data. There was a monitor. As you can see, this is a terminal for what's called a mini computer at the same time, and the mini was very big, as you can tell. So way less powerful than any of our phones. So I'll just go back to the basics here. What is machine learning doing and how does it do it? So think about inputs to a system, to an equation, for example, in which you have the age of patient 34, variable 1 value is 4, and you have a series of values. And then you're predicting some outcome, such as development of disease or metastases and so on. So a binary outcome, yes or no, could be death or alive. And all that happens is this mathematical equation multiplies the inputs by some coefficients and then passes through a function. In this case, it's called a sigmoid or logistic function, and predicts what the estimate would be. So 40% chance of death, for example, in this example here. And on the left-hand side, you see how it's depicted as a 2D graph, right? So the individuals in green might be the ones who survive, whereas the other ones in red, the ones who did not survive. And all this equation is doing is drawing a line and saying from this side, they will likely to survive with this probability for each one of the points. So again, this is a regression model way before any AI was around. So I'll contrast that in a minute. So just remember a few things about logistic regression. No one is scared of it in the first place. We know how it works. It's reproducible. It's good for interpretation, because it will say if you standardize the inputs, then the value of the coefficient will tell, oh, this is important. This is indicative of a higher probability of death or lower. So the risk factors, you would know what they mean. And then, as I said, it's very few parameters, easy to compute. Calculators of the past would do it. So it's very, very computer non-intensive and reproducible. And on the right-hand side, you see the line that separates these classes. Now think about machine learning, and all it does is a more complex model that includes one or more hidden layers in there, but the principle is the same. Instead of coefficients, these are called weights, and there are multiplications that will happen, and then we'll finally issue an estimate of the probability of the disease. So very similar. However, on the right-hand side, you see that the separating a line can be curved, can be much more complex than the other one, right? So the trade-off is it's more complex to compute, but it separates the cases better, as you can see here. But it's not so good for interpretation, because you no longer have those coefficients that you can say, oh, this is good, this is bad, and so on. It works well for most problems if lots of data are available. So it's much more data hungry than others, many parameters to compute, and it's hard to compute, but it's also reproducible. The moment you freeze the training and you say, these are the weights, it's completely reproducible model. So that's one of the myths that needs to be dissipated out there. Of course, if you keep updating, but it's just like a regression model. If you kept updating, of course, it will change, but they behave the same way. So this is the old machine learning, right? The deep learning what happens, computers got better. It added a whole lot of hidden layers, and that's why it's called deep. And it can do this classification problems that I'm showing up here. So this is kind of old news. It was there for a long time, and later we'll talk about the generative models. Regression and machine learning models have been in medicine for a long time. So a lot of the issues that are surfacing now apply to this other models, except no one talked about them much. And the models are only as good as the data that was used to estimate those parameters, right? And in that, you can tell, you know, if you bias the data, you will bias the model. There's no secret about that. So you might not know, but Framingham cardiovascular risk model is a regression model. The same as for the model for end-stage liver disease, which in fact ranks people for the liver transplant, provided there is a match. So very influential model would put people with higher risk at the top of the queue for the liver transplant. And there are many, many other regression models out there and some machine learning models as well, all doing this classification task that I talked about. So what are healthcare organizations want to use AI for? Increase in efficiency. There is this pilot of ambient listening now that will summarize your notes, having heard what happens during the visit. There is another application, very common, becoming more common now, which is to generate the draft replies for your inbox as a clinician. So those things are happening right now. We also want to decrease errors, right? Reduce diagnostic errors, therapy selection errors, promote safety, do reminders for differential diagnosis, and so on. So there's a lot coming up, but the first applications will be very much around the efficiency, around billing, you know, have all the billing codes been included and things like that. Now at Yale, there is a lot happening in machine learning area. Here is a slide from cardiologist Rohan Kara, in which he developed an app that you can, anywhere in the world, if you can take a picture of the 12-lead EKG, it will interpret it for you. So very exciting application, as well as integrating data from wearables. So this is happening at Yale right now. Of course, your colleague Sanjay Aneja is working on other like imaging-based biomarkers for lung cancer. So imaging is an area where AI is being a lot used. And in this case, he wants to determine whether through imaging you can start to predict what therapy works best for a particular type of patient. So exciting applications. In practical terms, there are a lot of AI software that has been utilized in the radiology department that recognize images, that tries to understand the disease progression and so on. So there was a lot happening. It's still piecemeal in several areas. Some of it is still research, but there are a lot of applications already happening. Now, we are very interested in polygenic risk scores, which are an equation of the type that I showed before. It's a regression equation, but it has a ton of parameters, right? It has a ton of inputs, which are basically the mutations in genes in other ancestry variations. We are cognizant that it could introduce biases that lead to discrimination. So we have to be very, very careful, particularly because the training data, the data that are available for the models typically comes from European populations in the majority. In other populations are not as well included. There's also the issue of privacy and the fact that genetic studies typically ignore individuals in which the mixed ancestry is above a certain threshold. So that is actually very sad because it leaves out a lot of potential participants in these studies. So like trying to represent here that a trait is a function of several determinants. They can be genetics, mutation, variant effects, or ancestral effects, and also social determinants and exposure, right? Which in many cases determine more the risk than the other portions. So we have to deal with this very, very long list of potential risk factors to try to estimate the probability of a certain trait. And we have to do that in operating in compute systems that do not allow data to come out. So you have to do the opposite. You distribute the computation, tap into these resources, and try to create these equations or machine learning and so on. So this is a center that we lead from Yale. It involves also colleagues at the Broad Institute and at UC San Diego primarily. And what it does is try to tap into the All of Us research program, which is a large database of consented participants that have whole genome sequence data, more than 400K of such data, and the Million Veteran Program, which is an equivalent resource, which is also kind of sequestered from the mainstream. It has its own compute environment, and it's reaching the million mark very quickly. So how do we compute with this data in a secure way, in a privacy-preserving way, has been one of the topics of our research. Now I'll go back to another thing that might be more exciting related to generative AI. So that classification problems I told you, people criticize AI by saying, well, it's not very creative. It just recognizes patterns that you give examples for, right? So how can it be more creative? And you can see here, you might like it or dislike it. And you might see that there is a source from which it tries to be creative from, right? So think about this image for a while. And also this one, this is an old NVIDIA research project that showed that from sources, the real people on the top, you can create the fake people at the bottom, and they might become indistinguishable for us to decide who are the real people. You mix them all together, and you might not be able to because the technology got so good that it does produce fake examples that look exactly like the real ones. So generative adversarial networks, there are two networks that are adversarial, and one wins, one loses on an iterative fashion. One produces the fake data. The other one tells, oh, this is real, this is not. So the whole game here is to generate and keep generating until the generator wins and the classifier can no longer say, you know, no, now I'm 50-50. So I put here, pardon my graphics because they're not professional, but they give an idea here. You have a real observation, you have some noise, and the generator creates a fake observation, right? That goes to the classifier network. The classifier network takes a real observation and is supposed to say, oh, this is real, this is fake. So in this first example here, it does exactly that. So it wins, right? Because it still can discern. This is another example. You keep doing it and it says, oh, this is fake, this is real, still wins, until you get to this point where it says, well, these are both real. And at that point, the generator wins, you stop training, and that's how you have your model, right? So a large language models, you know, with all the simplifications is nothing but the generator part. So what you have what's called a prompt, which is an input, and you say, diagnose a person with chest pain or pain, smoker. And the large language model, so this is ChatGPT, we'll start. I'm not a doctor, but here's the things that you need to consider and so on. So it's just the generator now. You're not training anything anymore. And the generator, what it does in this large language models is guessing the next word, that would come given the prompt that you gave. So it ingested a whole lot of the information on the internet, on articles and so on, and now is able to generate something like this. So you take another example here and it would come up with things that for the non-expert seems pretty reasonable. It's not a total out of line or hallucination, which the initial large language models would hallucinate much more than now. They would create things, and they still do. But if you're not the expert, it looks pretty polished and so on. So what are healthcare organizations doing with generative AI? So that application of ambient listening has some component of that because it generates the text for you, as well as the one that does draft replies for the inbox. But there's a whole lot of other things happening in terms of clinical research that, as you know, that article that said the large language models passed the exams and so on, because it ingested a lot of those questions, right, in the textbooks and everything. And it's it memorized them, and it's sending back what it learned from it. So published medical cases, they use biomedical literature. Now, the problem is they cannot use real observations, or should not, even though there are, you can purchase electronic health records these days. So I bet they used some of those too. But what we wouldn't do is have our records be input into ChatGPT. And so, and no organization does that because they have this ability to memorize, right? And if they have the ability to memorize, they can return the case exactly as it is. And this can be a privacy violation. So it's an important thing to note that the problem is they don't learn anything, right? We have the healthcare organizations have some contractual agreements that allow to be the data to be used, but not to learn with the data, not to keep anything that the user is entering in that. And that's the correct use to do through the organization. But on the other hand, it won't learn, right? So there's a problem right there. We have some developments in developing our own medical large language model. We call it medical llama. And the reason is llama is a foundational model, is one such large language models from Meta, from former Facebook, in which they made it available, open to the more training and so on. So you can do that, but it's still, you know, very initial, and still we're not doing with the records because of that privacy concerns that I mentioned before. So the challenges here at privacy are the black box nature of AIs and these myths that it will take over the world and you know, rule it by itself. Computational infrastructure is very demanding, so we cannot do in academic medical centers the same way as industry can. Workforce is better paid in non-academic environments, so all those AI, you know, super experts are working in industry and not in academia right now. And that there's the whole issue of AI fairness and unfairness, some of which is the same unfairness that any logistic regression model would have, but no one talked about that. And now everyone talks about as if AI had this way more unfair. It is unfair. I mean, I can say it's as unfair as the sources of data it got. And you can play tricks with it, and you will realize it can give different answers depending on how it learned that certain things are, you know, are more, there is more written about a false claim than a real claim. So it might come up with this issues as well. So here I would say unfairness comes from several places, including the misuse of data. This is a very old example, but it's still coming back whenever we talk about why American Indian, American Native populations are not so interested in participating in research, because it can be portrayed very negatively, right? The other one was the Havasupai tribe in Arizona. As you know, they authorized for use of data for a diabetes study, and then suddenly there were all other studies, mental health and other things done without data. So it was a violation. And also the limited benefit. If the populations don't see somewhat a benefit that applies to their particular group, they're less likely to want to participate. So AI created a lot of this angst and fear, because the first self-driving vehicles that were not trained in different skin tones, they were not trained on height of people, and they could make mistakes, you know, around those. So this headline came up. Another one is about this one in which someone wanted to optimize medical appointments and used a variety of variables, but it ended up overbooking patients who were from a certain racial and ethnic background, because it predicted that there would be more no-shows according to that. So the equation would predict that. And you can see how that problematic that can become. So again, it's not AI's fault. It's not the regression fault. It's the fault of whoever is employing this and how they utilize it. And there are several studies on AI chatbots. The things that it says back to us, particularly the older versions, can be very disturbing, because it learned from the internet, right? So it's a problem. It's a real problem. Now, we tried to gather a small group of industry and academic medical center leaders to talk about this up front, and to talk about potential ways to address the impact of this, or redress the populations that were affected by certain kinds of algorithms. We didn't say AI, because AI is in the midst of many others that actually are much more used these days. So I also wanted, so I talked about the challenges and the opportunities. There are many things, again, talking about precision medicine, about federated learning. So as Roy mentioned, I did manage to get the University of California system to collaborate on electronic health records, which wasn't the case before. And the reason is that we did it in such a way that was fair to everyone, and it protected the privacy as well. So it was a teamwork with a joint governance model, an open budget. Do not underestimate the importance of this open budget portion of it, because it was a deterrent to collaborate. Like, oh, this institution is getting more money than the other one, and so on. So that's a very important thing. You need to have a common data model, decentralized analysis algorithms, ability to opt out of research studies, and then the sites help each other to lift all boats. But it takes a while for people to get in this spirit. We later extended this to the whole VA network of electronic health records, as well as another network in Los Angeles, so we could have a much larger universe of people. And again, we also wanted to go beyond being data users, which we definitely are, but also to be data producers. How can we understand the process of recruiting these people and getting the data and so on? So we created a consortium to respond to the All of Us program request for applications in developing recruitment centers. And that's how we did it there. These are the main centers involved in our case. And we were one of several consortia that were created across the country to do that, including federal federally qualified healthcare centers, which are more community-oriented regional medical centers and other academic medical centers as well. So when we did all that, and then COVID hit and all of us programs stopped because no one could be recruited. However, we could still use the network that we had to do other kinds of work. So we decided that if there were clinical questions that were answerable by electronic health records, we would try to pull our systems to do. So we got our partners, plus some others who wanted to participate, including a large system in Germany. And in 2020, we were asking questions of this data, some, again, from an initial type of phase. One question that came early on was, should we stop ACE inhibitors for hypertensive patients because of potential issues with the virus receptors and so on? And we were able to show that with our data for hospitalized patients, it seemed that ACE inhibitors were doing just fine, where the mortality of those patients was lower than ARBs and other medications. And it was definitely all of them better than stopping any medication in this case. So in this case, we were 10 institutions involved, and we were able to do this early finding that later got confirmed in observational studies. So that was very reassuring. We did univariate analysis of this sort, in which, in this case, you could see the mortality, for example, according to race, was not different for hospitalized patients in our system, whereas in general, there was this description. And the reason is that once you adjust for age, the other factors become much less important. So we were able to do this multivariate analysis, again, with data that are all distributed. We never got the data centralized, and we were able to answer very, very simple things, adjusting for confounders and so on. So since I moved, we started also Yale as one of those recruitment centers, and also our partner in Puerto Rico. We had to change the name of the consortium, the Coast to Coast Consortium, but we continue to do the same thing. And it's a large program. It's very exciting to be in it. So I talked about federated learning. On the A side is how different hospitals have data and can collaborate. There's also what's called vertical partitioning of the data. Is the hospital has some data from the patient, the wearable company has some other data, the genome sequencing company has another one. So it's what's called vertical partitioning, and we can do federated learning, federated analysis in this similar way. It's harder, actually. This case is much harder than the first one. And then we have work on privacy protection, on data standardization, and also in informed consent. And the people want to contribute. Do they want to contribute everything, or they want to omit certain areas, or they want to contribute only if this type of research, but not that type of research, or this type of research entity and not another one. So all sorts of variations there, and we use a blockchain technology to keep track of all these preferences. The vertically partitioned, so that some data, for example, in Texas, whereas the phenotypes, the electronic health records, were in Oklahoma, so we developed the software so that they could do the analysis without putting the two together. So our vision essentially is to leave no one out, and have this large consortia to increase the representation of underrepresented groups. All of us in particular is very focused on having groups that were previously underrepresented. And then in our case, the technology people, we want to develop new methods and tools that allow those research findings to be applicable to all. So the consortia help link across disciplines, And also we do training, which I will talk about in a moment. We also participate as the coordinating center for this relatively small program from NIH. It's called Bridge to AI, in which the goal is to produce data that can be used by machine learning researchers, by AI researchers in a way that advances the field. So data sharing and access, we are dealing with a lot of considerations on the ethical and legal implications, the provenance of data, technical needs, basic data sharing. So I would say what we're trying to do is create a master's program, because we are also short of personnel that can do all of this. So we're proposing one, which is also in response to the Yale task force on AI that called for new programs, called for new training in particular, and is delivering on that by having also, remember I said the hardware is only in industry and so on. So we'll get some of that, and we will be able to do some smaller scale but very impactful research in that area. Benefits to Yale, we're doing a certificate program already. I want to move on to this master's program and train with another departments and then work with Yale Ventures and everything. So benefits to New Haven, we think we can extend these courses, many of them are online courses, to other institutions regionally or nationwide. That's another college that approached us. They have a new school of applied computational sciences, so we're trying to develop a program that interacts with theirs. So here's my last one. It's complicated, but we can do it. There's a lot of areas to tap at the same time, from mistrust in AI to mistrust in research in general, biomedical research, to, yeah, we got a good model. Can we apply? Can we not apply? Healthcare organizations, trade-offs between, more openness of data to privacy concerns, and also competitiveness with other institutions. So a whole lot at play. So I would like to once again thank the sponsors in this case, and thanks the organizer for the opportunity to talk to you.
For a couple of questions. I'll start. That was fantastic. And I know we're doing a lot of work at Yale. When you came here, did you have to increase the computing capacity of the institution to do all this, or was it already existing?
No, it is actually, it has been planned and purchased, and it will be implemented by end of this year. So it took a little while, but it's going to be there.
Because I imagine if we're using this for our notes, it has to be an internal system, because we can't use anything from the outside. Is that
exactly? So it's exactly that portion that I found at Yale could benefit from some updates, upgrades.
Any other questions or comments? Nikolai, any thoughts?
That was really great. Can you comment on the classifier in the generative model? Are those algorithm based? Are they influenced by humans, or that still is a bit of a black box to me? Can you?
Well, originally they are just machine learning model classifiers, right? But things have changed in many ways, so they're more complicated than what I described. But essentially, the classifier is a network, is a neural network that trying to essentially say, I can no longer distinguish, right? But of course, then the humans come and say, yeah, you're right, or maybe the classifier is not so good. So I think that, like the faces, right? In the beginning, they start not doing the right thing. Something is wrong. But over time, because the classifiers have the gold standard, right? So to have the gold standard, you had to have some people to judge that. There are also some other methods in which you need fewer gold standards in order to do that. But essentially, at some point, you have to agree that it did the right thing.
Any more questions?
I'll ask a question. So the AI has been utilized in imaging analysis as well as in, not only in radiology, but also in pathology.
Mhm.
And I wonder, so how does it affect the workforce issues? Does it help to relieve some of the burden because we have more and more images to analyze, more and more pathology reports to generate. So I just don't know what's the status of the application of this type of AI in our everyday work because it is used, right? I know that images are read and it's interesting how physicians who are responsible for it interact with it and, so how much verification is going on. Do they have to verify everything?
I would say not everything, but it's advisable that you agree with what's in there. Focus in your work, look more at these images, look more at this area, because that's where there could be some findings that you have not reported yet. In other not trivial, but important things, segmentation of the area, and is it growing over time? Is it not growing over time? So you have to have the particular nodule you're worried about, and the machine would segment it for you. The machine would get the other image and register to say that this is the nodule that is growing, and it's growing at this rate. And so I think it can assist you in some aspects of it. And that's the exact goal, right? Is the on the imaging side, even if you only have the imaging, it helps you focus on certain areas.
Fantastic. Any more questions? This was really a wonderful talk. I think it leaves a lot of room for thought, and there are many people here who I'm sure will be contacting you now for working with clinical applications. Thank you so much.
Thank you.
So now I'm going to invite Scott Huntington, our Chief Quality Officer. So expect a quality session there, my friend. And he's going to lead us through, and one of our organizers this year, he's going to lead us through the section on hematology.
Thanks, Roy, and the organizers. So it's really my pleasure to introduce my great colleagues with malignant hematology. We have three great speakers today. First up will be Dr. Sethi, who's currently covering our inpatient and was able to come from the hospital to present the key updates on lymphoma. Dr. Sethi joined us from Vanderbilt a few years ago, focuses on aggressive lymphomas, and we'll have a great discussion. Next up will be Dr. Browning, who will present on multiple myeloma. She was trained here at Yale and also had an advanced fellowship in amyloidosis before coming to Yale, and she'll have a great talk on myeloma. And then last will be Dr. Podosev, who will talk about leukemia. We'll then move on to the case discussion. We'll have three separate cases, and we'll invite Dr. Gowda and Dr. Sufi to join us for their perspective on transplant and CAR T for those patients. So without any delay, Dr. Sethi.
Okay, thanks, Scott. Thank you, Roy, and all the organizers and the sponsors. It is my pleasure to present the lymphoma hot topics in 2024 on behalf of my great lymphoma colleagues. So these are my disclosures. Fortunately, we have a ton of new data, a lot of exciting updates in lymphoma. In the interest of time, I'm going to focus on a few in diffuse large B-cell lymphoma and classical Hodgkin lymphoma. So we will start with diffuse large B-cell lymphoma, looking at 4 studies. 3 of them are conference abstracts, and one of them actually was a published paper that I wanted to highlight. All right, starting with the first study, this is EHAS 239, first data from subcutaneous epcoritamab and polatuzumab with Pola-R-CHP, basically epcoritamab and Pola-R-CHP for first-line treatment of diffuse large B-cell lymphoma. This is one of the arms from the EPCOR NHL-5 study. So as you can see here, there are a lot of MABs in that title. So just wanted to highlight that The epcoritamab here it's a BiTE antibody that has the two arms. One of them is directed against CD20, which attaches to our lymphoma cells, and then the CD3 two T cells. Polatuzumab vedotin is an antibody drug conjugate against CD79B. And then we all know rituximab, our standard the most commonly used CD20 antibody. Sure. The key eligibility criteria was that it included patients with untreated diffuse large B-cell lymphoma, and also included high-grade B-cell lymphoma, including those with high-risk translocations, as well as follicular lymphoma grade 3B, and it included patients with IPI 2-5. Here you would see that the inclusion criteria are very similar to what was the population in the POLA-R-CHP study, which has become standard of care for us frontline for many of our DLBCL patients with high IPI, intermediate to high IPI score. So as we see here, these patients had IPI scores from 2-5. Very few patients with those high-risk mutations, but it did have a balance of both GCB and non-GCB subtype of diffuse large B-cell lymphoma. So looking at so again, this is very early data. This is at a median follow-up of 7.4 months. They report that the overall response rate was 100% and the CR rate was 88.6%. So median time to response was 2.7 months. And the median time to CR was 2.8 months. As you can see, most people did end up getting a CR. And again, at a median follow-up of 7.4 months, the median duration of CR is not reached. So so there are only 35 patients. The study is really not powered to look at subgroups, but it didn't really show any differences in the studied groups shown here. And then also in terms of toxicity, it was the most common treatment evident emergent adverse events were basically cytopenias, and then also diarrhea and nausea, but that was a low grade. The most common, higher grade were basically different cytopenias. Importantly, there was no ICANS, and CRS was low grade and predictable. This is what we see in most BiTE antibodies. The CRS is more predictable as compared to CAR T-cell therapy, which is expected, and most CRS events were confined to cycle 1. And again, there was one death, and that was due to urosepsis that was thought to be unrelated to epcoritamab. So again, this is just one, this is a single arm study data. I think what we get from here that it is possible to build on POLA-R-CHP. We have a safety signal for combining BiTE with POLA-R-CHP from the study, but really we need to look at more randomized data, and we do have just this week we have a trial with glofitamab, which is another CD20 CD3 BiTE antibody, and that is being glofitamab plus POLA-R-CHP is being compared with POLA-R-CHP in a randomized study, and we have that open at Yale now, so we're looking forward to enrolling patients on that. Okay, so keeping with the BiTE theme, and glofitamab. So I'm going to talk about this study next. This was also an EHA late-breaking abstract. It was the STARGLO trial, I'm sorry. Glofitamab plus gemcitabine oxaliplatin, that is Glofit GemOx, compared with, and that was for relapsed refractory diffuse large B-cell lymphoma, and this was being compared with R-GemOx. So as you can see here, Glofit is also a CD3, CD20 BiTE antibody, but this one has a specific 2:1 format where you can see that there are 2 CD20 directed arms and 1 CD3 directed arm. So it's the key inclusion criteria were they just required 1 prior line of therapy, and those that had only 1 prior line of therapy had to be transplant ineligible, and They're stratified based on whether it was relapsed disease or refractory disease and then number of lines of therapy. And as I mentioned, this was a randomized study. We